A very warm good morning to all the esteemed faculty, delegates, and KIMS staff, that is our organizers, gathered this sunny morning after a long quest to quench your knowledge hunger. It is auspicious, customary, and blissful to start any program with a small prayer to the Almighty. So today being Sunday, let's begin the program with a note of gratitude to the visible miracle in the sky, the sun god. Om Adityaya Vidmahe Sahasra Kiranaya Dhimahi Tanno Surya Prachodayat. We from KIMS Hospital, Secunderabad, Art Society, on behalf of Course Director, our iconic stalwart Dr. Hygriv Rao, and Chief Patron Dr. Bhaskar Rao sir, extend a delightful, cordial, elated welcome to all the gracious ladies and gentlemen who have gathered today here from our doctor fraternity for today's hardcore discussions on cardiology and electrophysiology, that is Arrhythmia SYMPOSIUM-2026. So Tadasana, or the mountain pose, in our Indian yoga has been recommended to reduce vasovagal syncope recurrences by reducing autonomic tone. Our program director, Dr. Hygriv, and our team at KIMS had written a paper on this, and it was widely circulated in the last symposium we had in 2025, and it is available on the PubMed for all of you to refer. So we are opening today's session with the topic syncope and bradyarrhythmias. So before we proceed, I would like to inform, we have made a small change in today's symposium. That is, we have an anchor for some of the sessions. So we request the anchors to occupy the chair in the front row. And we'll have chairpersons on the stage. We have 3 to 4 chairpersons for some of the sessions. So the chairperson will be sitting on the stage. And of course, the speaker will be on the podium. So the time, regarding the time limits, we have a timer there, which the speaker and the people on the podium can see. And we have given 10 to 15 minutes for each speaker. So if you take 10 minutes, then you'll have 5 minutes for discussion with the chairperson and the audience. Or if you are taking 15 minutes, then you will not have time for discussion, so the mic will go for the next speaker. The anchor's role will come at the end of 1 hour. So after this, all the 4 or 3 speakers in each session finish their talks, then the anchor will get the chance to interact with the audience and the speaker and the chairpersons. He'll be involving them, and we'll be discussing any questions or any discussions more on the topic. So I hope the timings are clear. I request the speakers not to overshoot their timings. There will be a short buzz to remind them at the end of 13 minutes, and a long buzz to stop at the end of 15 minutes. So the timer is already set there. And I hope you all enjoy today's program and go back with a lot of knowledge and enriching day. So for the first session, I would like to call upon the stage the chairpersons for the day, for the session, Dr. V.S. Srinath, Dr. V. Mukesh Rao, Dr. Shashikant, and Dr. Krishna Mohan. So please come onto the stage. And I request anchor Dr. Ashish Nabar to come on to the front row and occupy the seat in the front row. Please give a mic for the anchor. Now I welcome Dr. Daljit Kaur from AIG Hospitals as the first speaker for today. It will be followed by Dr. Jaiprakash Center sir, Dr. Hygriv Rao, and Dr. Vanita Arora. Thank you so much.
Thank you, Hygriv sir, for the kind invite. Good morning, one and all. So my responsibility, I like the way sir has asked to present the cases. So it's like a case and how to go about it, whether this patient needs any intervention. So this is next. Okay. So my responsibility, like if you are in a OPD, you have a patient who's a 45-year-old male. His ECG shows 2:1 AV block, and his most important point here is he is asymptomatic. And he has a structurally normal heart, and there are no comorbidities. So now your decision depends upon next thing, because you have diagnosed this on ECG, right? It's a 2:1 block on the ECG. So the question is, what type of ECG it is, whether it is 2:1 AV block with the narrow QRS and a normal PR here like this. You have a case of regular normal thing going on, but there is a paroxysmal 2:1 AV block. I'll talk about this ECG, we'll go back to this ECG, and with the narrow QRS. Or you have a case who has a 2:1 AV block with underlying bundle branch block, that is wide QRS, maybe a prolonged PR. Here you can see 2:1 AV block, left bundle branch block, left axis with the prolonged PR. You may have right bundle branch block, normal PR, or you may have a prolonged PR also, but underlying bundle branch block, here there is a left antiofascicle also. So right bundle branch block, left axis with 2:1 AV block. So your decision is based on, this is really important, whether which kind of ECG you see when the patient comes to you in the OPD. So our decision depends upon what is the level of the block, whether the block is in the AV node, is in the His bundle, or bundle branches. So why it is important? Like if you have a block, it's, I think many people may know, if you have block in the AV node, it may not be a high risk. We will talk about this. Or if your block is in the intra-Hisian block, or your block is in the one of the bundle branches. So one thing is, once block is below the AV node, there is no question asked. I can stop my presentation here. If you have a very clear ECG, which shows that there is some kind of bundle branch block, 2:1 AV block, some kind of bundle branch block, right bundle, left bundle, any kind of bundle branch block, normal PR or prolonged PR also, like I showed the second ECG. There is no doubt here is, we are very clear that this is a very high grade AV block. Even patient is completely asymptomatic. It's better because at any stage they may become symptomatic. And the other thing is, what symptoms? Many times they may have little bit tiredness, they may have little bit of dizziness, they may not be able to express the symptoms. They may have some fatigue but not very obvious symptoms. But it's very clear that once the block is below this, or you clearly see on the ECG a white QRS, I can stop my presentation here. There's no question asked that the patient needs an intervention like a pacemaker. You may evaluate for other things, that's a different thing, but yes, intervention is required. But when we talk about intra-Hisian, the thing which we miss is here is intra-Hisian block. Why intra-Hisian block sometimes missed is, they may have a narrow QRS because when the conduction becomes a little bit slow here, it may have a equal conduction across all the fascicle. It may show a narrow QRS on surface ECG, but it is still a high-grade AV block. So this is important to know. Secondly, you have a prolonged PR. Always a notion is prolonged PR, and if there is a prolonged PR, it's AV nodal block. That's not completely true. Always remember, because sometimes when you may have intra-Hisian disease also. So prolonged PR with the narrow QRS don't always give away saying that it's an AV nodal block, because it may have an equal delay across all the three fascicles and you can have a narrow QRS. And the same patient suddenly becomes a narrow PR, smaller PR and some bundle branch block. That means it's an intra-Hisian block. I'll show the case, I'll show the example. So whenever you are confused, I'm talking more about 2:1 block with the narrow QRS. How to differentiate? Commonest two maneuvers are carotid sinus massage, and secondly you give something which will increase the AV node or sinus rate. So be cautious, but before giving this, it's either atropine or isoprenaline or exercise stress or carotid massage. So carotid massage, you are increasing the vagal tone. You are decreasing the AV nodal or SA conduction through the AV node. So if you are decreasing the AV node, if you do a carotid sinus massage, intra-Hisian or infra-Hisian block may improve or may not change. Always remember. If there is only AV nodal block, once you tell patient to start running, do treadmill or give atropine or isoprenaline, your conduction will improve drastically. That means in a AV nodal block. Below that, it will get exacerbated. So this is what I was trying to tell. 2:1 AV block and narrow QRS. A normal QRS is going on. Normal PR is there. So when you get this completely asymptomatic, as I said, you can think about doing carotid sinus massage. Or sometimes, so as I said, You may take for EP study if you feel, because 2:1 AV block in a middle-aged man, chances of intra-Hisen block also is high. So if you do EP study, that's what I was trying to tell you. Patient may have intra-Hisen block. So for EP with V, this is A, this is V, and this is His. Usually you have two His. You can see here. Usually you have a single His and you are getting two His. So one His is 43, other His is 65. That means there is a split in the His and there is an intra-Hisen disease. And when you do, so that's what I was trying to tell, that whenever there is a long PR, it is not always AV nodal disease. You may have an intra-Hisen disease, and when you have a block, you can demonstrate in the EP lab that the block is whether below the His or above the His. So how do you know this block is intra-Hisen? You can see there is a His coming and there is a V block. So the block is below the His. So although this is a narrow QRS, this is a block is below the His. So they can be intra-Hisen or intra-Hisen block if it's a narrow QRS, especially when it is consistent 2:1 AV block. What about atropine? You have to be very cautious to give atropine in these patients, because now, will you give atropine in this kind of patient? You have a 2:1 AV block, looks like narrow QRS. Will you give atropine here? So if you see here, it looks narrowish, but it's right bundle branch block already. And axis is 2,3 AVF is negative. It's antifascical block. So already right bundle and left axis block is there. Here, if you give atropine, what will happen? Your chances of AV block getting exacerbated is very high, because there is a bundle branch block on the ECG. Although it looks like narrowish QRS 130, but already there is a bundle branch block. You don't need anything to do here. It's a high grade AV block whenever you have any kind of bundle branch block, although it looks like narrowish. But right bundle left axis or right bundle branch block or left bundle branch block, with the normal PR, with the prolonged PR, patient is having a high-grade AV block, and there is no doubt patient needs a pacemaker. So that's why be very cautious. Like when you give atropine and all, you should be very cautious, because they may not have any rhythm after that if there's a high-grade AV block. So going to symptoms, whatever I said, it's the same thing has been mentioned here. If you have an AV nodal block, whenever you do vagal maneuvers, it will get worsened. And if you have, your intra-Hisen or intra-Hisen may not improve, may not change also. If you do exercise, you tell them to run on a treadmill or something. If there is an AV nodal block, it improves drastically. And this is specifically true. You will need this in the patient who's having a so-called congenital 2:1 AV block or congenital AV nodal disease. They'll say it is going on since many years. I don't have any symptoms. And as soon as you tell them to walk on treadmill, and as soon as they start running, the 2:1 AV block will decrease to AV Wenke-Beck, or sometimes it becomes 1:1 conduction. So in a younger patient, you feel that it's only vagally mediated AV block. Athletes may have this. So you can make them run on the treadmill, and you can see that if the 2:1 AV block becomes AV VAC or AV Wenke-Beck or 1:1 conduction, you know that it's an AV nodal block, and this patient has a high vagal tone or congenital complete. There is a changes in the AV node. He has no symptoms. We can wait and watch in those patients. But otherwise, if there is a His or bundle branch diseases, as soon as you make them exercise or give atropine, it will get worse, and always remember. Symptoms, yes, we know that actually 2:1 AV block, whenever there is intra-Hisen or infra-Hisen, chances of symptoms are very high. Those can be dizziness, syncope, tiredness, fatigue, little bit may not be, little bit slowing, especially in the older patient. They may get slowed down, they may not have very obvious symptoms. So you should be cautious about asking when you talk about symptoms. Yes, only thing is vagally mediated AV block related to AV node may not have symptoms. That's possible. Even I have seen in OPD few patients who are having underlying bundle branch block, looks like high grade AV block, but still they may not have symptoms. So it's like how you're asking the symptoms, because it may not be always be syncope or pre-syncope. I already spoke about here, when you talk about AV nodal disease, you may get this in athletes or very elderly. They may not have much symptoms, but they may have a decreased exercise tolerance. Intra-Hisen or bundle branch block, they may have symptoms, but rarely they may not tell you a clear symptoms also. Coming back to the second ECG, first ECG was clear. This is an ECG, this is a Holter. If you see, it's because this patient came for pacemaker. And if you see, it is important to understand, when the P dropped, although this PR looks fixed, When the P dropped, only first PI is little prolonged, then this is normal. It's a little atypical Vancomycin because the P which is PR before the blocked P wave is little longer than this PR. But more than that is, your PP has prolonged before the AV block. So when your PP prolongs before the AV block, it's vagally mediated AV block. And if you see the timing, can you see here, it has happened at 3:59. That is, it's happened at 4 a.m. when the person is sleeping. And this patient does a high exercise and he's a very active person. So these kind of patients, they don't need the pacemaker because it's an vagally mediated AV block. And these patients, as we spoke now, once you see bundle branch block, there is no question about it. They need a pacemaker. Yeah, additional anything required, not required, we can evaluate the patient, but yeah, they need an intervention. There is no doubt about it. So whenever because my job was this, Mobitz type 2, like 2:1 fixed block, chances of pacing requirement is very high. I would say just take a pause for a patient. When this AV block is at midnight, the way I show the patient, or patient has a congenital AV block since many years going on, no symptoms at all, you make them walk on the treadmill and then the AV block becomes 1:1 conduction, you can pause, but otherwise all 2:1 AV block needs a device, there is no doubt about it. Below we won't discuss. And as I said, if it's a narrow fixed PR, if you're little bit doubtful and all, gray zone, the way I saw, where you think it may be an intra-ECN block, there is no harm in going for an EP study, although it's a class 2B indication. I think I'll stop here. Thank you very much.
Excellent presentation. Any questions from the audience?
Yeah, very nice talk. What do you do with a patient like this who is on 25 mg of metoprolol?
Yeah, I should have touched that. You're absolutely right. And this is the last slide actually. If there is a reversible cause. So if there is a reversible cause, you feel high, because many patients for hypertension, old patients, they are on atenolol, they are on metoprolol, you should stop, especially narrow QRS. We are talking about only narrow 2:AV1 with the narrow QRS. If it's a wide QRS, even on beta blocker, you should have a low threshold to go towards the pacemaker because it still has intra-ECN or intra-ECN block. But narrow QRS, you should wait for 4-5 days. You should stop the drug, let the drug has a washout period, and then you can recheck it. And the other thing is, if a patient has ischemia, or if you have RC, AV nodal disease, branches disease. So those I didn't go because we thought we are talking about normal echo, no asymptomatic group, so that's why I'm not going in that. But yeah, if you feel it's a reversible cause for some reason, you stop the precipitating cause and then you can recheck it. You can wait and watch, absolutely. Yeah. Again them. So no harm in taking them for EP study if you feel that, and here you are talking about asymptomatic patient. Because if they have symptoms, then you have to be very cautious. The question was very clear that if the person is completely asymptomatic, and I assume that you are trying to tell it is accidentally detected, and you have this ECG, how aggressive you should be. That's what is the question, right? And it's written that there are no comorbidities.
Yeah.
Correct? So,
another question
sir.
is patients who have 2:1 block like this, sir, how often and when do you do workup for sarcoidosis? And second thing is, if it is proven, would you just treat and keep quiet or pace and treat?
So sarcoidosis, usually what I've seen, you will have subtle changes in the QRS. Here you are talking about 2:1 completely normal. If you have a subtle bundle branch block, certain fractionation of the QRS, 45 years, there is no other cause of AV block. I will do some imaging, rather you advise device, but you can do some imaging to check, maybe PET you can do MRI. It depends upon how is the QRS, and sometimes echo shows basal septal thinning, echo shows subtle changes, then you be aggressive for going towards, but yeah, PET is not an harm in a 45-year-old male. There is a 2:1 AV block, no comorbidities, zero comorbidities, no family history, nothing. There is no harm in doing one PET CT to rule out inflammation. I agree with that.
Just to add on to what you said, sir, that's something we've seen in, we've seen in young patients less than 60 years who presented with a complete heart block. So we studied over 100 patients. We saw that significant number of them had uptake on PET.
There is already a paper on that.
Yeah,
If
predominantly
you do
basally,
PET
yes.
and you do PET, they will have there's already paper on that
Some
by
uptake, yeah.
Tahir.
And some of them refused steroids, and then we had nearly 8 people pass away suddenly.
Not
after a
even
pacemaker.
that, it's better to ask family history because you will not get surprised that they have lemon AC mutation. Some of the family member has DCMP, some has a CD, some has a pacemaker. So a small history, detailed history, if it's an unexplained 2:1 AV block. No harm in asking family history.
A couple of comments, Daljit.
Sir, yes, sir.
Now, 2:1 AV block can be a part of Morbid's type 1 or Morbid's type 2.
Yes.
So one of the ways of assessing that is to do a Holter or long-time monitoring. Suppose you have a Morbid's type 1 block, then this type 2:1 AV block belongs to Morbid's type 1. If it's a Morbid's type 2 block, then that's different. So then probably even though he's asymptomatic, it might progress and you may have to put a pacemaker.
Sure.
Second comment, if you are doing a carotid sinus massage, the sinus node receives most of the nerve innervations from the right carotid. So if you want to slow down the sinus node, you better use the right carotid. If you want to block the AV node, it is better to use the left carotid. Number 3, if you find in a patient who is older than 60 years, slightly obese, you find a nocturnal AV block or nocturnal bradycardia followed by AV block, one should look out for OSA. So these are very important things that we may miss while we work up.
Thank you for writing those, sir.
Hygriv, I think the best discussion happens after the talk. We might just do it this way, isn't it? 5 minutes extra and after the talk.
Times is up. That's what we already discussed. You should stop beta blocker, wait for some time, and then again you can do an extended halter on the patient.
So Dr.
And
Arjit,
whenever I connect halter, I tell them to walk a little, do some exercise so that you can have minimum, maximum average heart rate.
for the audience, how long would be the washout period for a beta blocker, different beta blockers? Number 2, if the patient incidentally is on amiodarone for some reason, how long would you like to wait? Number 3, in your practice, how many percentage of patients or what percentage of patients would you send for a PET CT or a cardiac MRI in an asymptomatic 45-year-old with 2:1 AV block in your practice?
In my practice, that's why I'm saying, sir, it depends upon what ECG you are showing me. If you're showing me this ECG with bundle branch block, young, not obese, non-diabetic, zero comorbidities, what example has been given me, I will do PET CT or I may do MRI also in the patient. But the same patient is diabetic or hypertensive or having metabolic syndrome, I'll go towards the other side. I may think about doing angio also in these patients to rule out CAD. Coming down to different beta blockers, yeah, it's a big question, but yeah, at least wait for 5-7 days. Amiodarone is a difficult question because how much dosage of amiodarone, whether you have completely loaded the patient on amiodarone and why you are given amiodarone. If I've given amiodarone to a patient, I assume this patient has some atrial fibrillation or ventricular tachycardia I've given. So it's not a structurally normal heart patient. So I think it depends upon the patient's complete background. If he has some disease and you have intra or infraeason block on amiodarone, still I'll err on the side of putting some device because intra or infraeason block, you have to be very cautious. So that means it's not a normal patient, right? So it depends upon the other background of the patient.
Yeah, thanks Jagmeet. I think great discussion to start this topic. I think we'll stop here on this one and we'll have some discussion with you at the end of the 4 presentations. Let me invite Dr. Jayaprakash Shentar. I think he was erstwhile a professor of cardiology and electrophysiology at the Jayadeva Institute and he's a career teacher. So very regular at the Arrhythmia Symposium at KIMS. Let's have him talk on his experiences with different patients of syncope.
Can I get these slides on, please? I'll start by thanking KIMS, who call me every year for this Arrhythmia Symposium. I would also like to thank Hygriv, my good friend, who always calls me first for a Arrhythmia Symposium or any other meeting he is holding. Now, without much ado, let me start with the first case. Many of these cases are from my old files. So this is from around 2003. It's a 6-year-old boy. He was admitted actually in a neurology hospital in Hubli, which is about 350 kilometers away, for apparent refractory recurrent seizures. So the nurse on duty on one of these episodes found that the patient was pulseless and called the pediatrician there. The pediatrician went there and found that the patient was really pulseless, and he started deciding to put a halter on this patient. Now, I got a phone call at about 3 o'clock in the morning from the pediatrician asking me the dose of IV amiodarone to be given for a 14-year-old child who's having VTVF. So you are woken up at some time early in the morning, you mumble something and you go to sleep. So at 4:30, suddenly I had this, it was sort of a dream-like thing that I had done a mistake. So I woke up immediately and told the fellow, you send me whatever you have recorded, and also send me the 12-lead ECG. Now this is what was there on his ECG. You can see he's having polymorphic VT which degenerates, and then he has a period of asystole and then resumes his rhythm back again. So this was happening on and off continuously, and looking at his 12-lead ECG, you can see that this boy has long QT syndrome. So giving amiodarone would have worsened his condition. So this is one place where we have to be extremely careful. When you are seeing young people with syncope, you have to look at the QT interval very carefully before offering them any treatment. Now, in those days, 2003, this fellow did not have money. He was from a poor family. He could only afford a pacemaker since he was having brady also. I put in a pacemaker and put him on maximum dose of beta blockers. It is really unfortunate that this boy was doing quite well. 8 months later, he stopped his beta blockers and he was playing and he was found dead in a gutter. So this is the sad part. Today, I try to get these patients undergo cardiac sympathetic nerve denervation in most of these patients, because even if they drop out of the beta blockers, there is a chance that they will survive. So this is a message that I want to pass on. I'll go to the next case. Actually, this is a cousin of mine. A 52-year-old male, non-diabetic hypertensive doctor, he's an orthopedic surgeon, presented with history of pre-syncope and fatigue. He had returned back from the US 2 weeks before after visiting his son, during which he was vigorously active, including trekking in Yellowstone National Park during that visit. Since he was practicing in a group practice, there was a cardiologist there, and he approached the cardiologist who did an ECG and found that he had intermittent complete AV block. So he underwent chest X-ray, echo, MRI, everything, including a coronary angiogram, which all turned out to be normal. And he was advised a pacemaker. So this was his ECG, you can see. So as soon as they mentioned the pacemaker, he came running to me on a Sunday evening. So I said, look, we'll think of doing a PET scan tomorrow before we do anything. He did not have a frank syncope, but he had pre-syncope. Then the next day morning, I was just mulling over this. I said, I have missed something again. Because if I put a pacemaker for this fellow without further workup, he's going to have a problem. So I ordered him to get Borrelia IgG IgM antibodies done, because he had visited North America, and the Borrelia IgM was 500 units and IgG was 450 units. The diagnosis was Lyme's disease. So I put him on doxycycline for 28 days because I had written the first case report of Lyme's disease long back. So this was something which stuck me, and in fact, his ECG turned out to be normal after his treatment. So this is something that one should be very careful about. Whenever you see a young patient, these days people do travel a lot. There are endemic areas, especially in the North America, central part of Europe, Scandinavian countries. There is a very high chance of having Lyme's disease if the patients have traveled in those areas, and many a times they go for trekking in these national parks. So it is worthwhile asking whether he has gone trekking, whether he has. Then when I retrospectively asked my cousin, Did you feel anything there? He said, yes, it was something like a mosquito bite I felt. I was wondering why in US there was mosquitoes in. So, in fact, you will mistakenly have not asked that question. So, I always make it a point to find out the travel history when I see such patients. So, next. This is a patient who first time I did a mistake, I'll tell you. I made mistakes a lot of times and I have learned from it. A 16-year-old female, adopted daughter of a poor retired teacher couple from North Karnataka. She picked up the phone and was talking to somebody, and suddenly she had a cardiac arrest and she was taken to the nearest hospital where she was resuscitated. So she was referred to me from, again, this patient has come from Hubli. That area is endemic for some of these diseases. So she came to me, her echo was normal, her baseline ECG, I'll show you, was normal. I did a Holter, heart, MRI. I also went ahead and did an EP study. And finally, I could find no diagnosis. I just put her on some beta blockers and sent her off. Then again, after a month, she has another cardiac arrest while playing near her house. And fortunately, she stayed next to a nursing home. The doctor who sent her to me said, I saw polymorphic VT sort of thing when I connected her to the monitoring system, and he cardioverted her, and again he referred her back to me. Now I had finished most of my investigations. So I again thought about it that, look, God has given me a second chance to do something to this lady. So you can see this ECG. Now this is the baseline ECG. You will see the QT interval is perfectly normal. PR interval is perfectly normal. There is no pre-excitation, nothing. But what I did was I put her on a treadmill. So when I put her on a treadmill, this is the bruise stage 1. You can see ectopy started appearing. And then you have this bidirectional ectopy. So this is a CPVT. So you can easily miss this. Holters will not pick it up. EP study will not pick it up. So in young patients who have syncope, it is worthwhile putting them on treadmill also while evaluating for syncope. So as you can see, it is a familial disorder. Unfortunately, she was adopted daughter of a retired teacher. Both her parents had died. We did not know what the cause of death was. And these polymorphic VTs can be induced by physical or emotional stress in structurally normal hearts. The mutations in genes encoding cardiac ryanodine type 2 receptors or calcitonin causes the in autosomal or autosomal recessive forms can result in CPVT. So evaluation of these patients is very important so that you do not miss this very lethal disease. Of course, I had to give her an ICD, and she still comes to me. She got married. I counseled her husband that if you get a child, you will probably have a possibility of having a child with CPVT, but that fellow has agreed and married her. So they are doing quite well now. So beta blockers, propofenone, flecainide, sympathetic denervation, and ICDs are the treatment for this. Now, do I have time? Yeah. So, okay, this is the last case. A 54-year-old female with recurrent syncope and restricted sudden cardiac arrest was implanted with an ICD in Kerala. This patient came to me from Kerala. Now, she had normal LV function on echo and MRI, and she actually came to me because she was so fed up with the number of shocks that she received every month that she came to me for explantation of this device. Now, I was not sure that she was already on antiarrhythmics, but I was not ready to do it. I said, let us do a Holter and see what you have. So you can see on ECG, she has got a single ectopy, short-coupled VPC on the T wave, and on ICD interrogation, she had received appropriate shocks. Again, this was way back from 2009 that I have this case from, so I just pulled it out. Now I put a Holter. This is the Holter recording. You can see a short-coupled PVC inducing polymorphic VT and VF in this patient. And you can see the number of runs totally that she has had, 353 in 24 hours. And what is to be done? She was already on amiodarone and beta blockers, but not responding to that. She's still getting shocks, wanted me to take out the device. Now, I said, let's map this PVC. I did not have a 3D mapping at that time, but nevertheless, I said, we'll do a 2D. You can see I mapped it to the inferior fascicle on the left side. And there are nice fascicular potentials when the PVC occurs. And I did pace map of that. I'll show you this is the first beat of the PVC, and this is the pace map. You can see the 2, you can see number 3, you can see number AVR, AVL, AVF, absolutely 12 by 12 map. So delivered an RF current, and then it stopped. So we observed her for some time and then sent her off. After about 7 months, I did a Holter again. She has not received a shock since then. The problem now is she's come back to me saying that I have not received shock. Should I change the box? So I am in a dilemma. So I've said, we will change the box because I do not know what I have done. I do not know whether it can recur again. So I have suggested her to undergo a box change. So thank you all for a patient hearing. I'll make a comment. Patients, whenever a patient with syncope is seen, the first thing they'll ask is, do you have giddiness? And they'll send it off. Giddiness is an extremely vague term. It does not mean anything. Giddiness may be even imbalance. Giddiness may be vertigo. They may not even have loss of consciousness. You should ask 4 questions in syncope, I'll tell you right now. The first question is, have you fallen to the ground? That means, have you lost postural tone? Number 2, the second question is, how quickly did you pass out? Was it rapid and quick that you passed out? Number 3, did you have any premonitory symptoms like sweating or, they feel butterfly in the stomach before they pass out, especially in reflex syncopes? Then number 4, when you got up, were you clear-headed? So these are the 4 questions that you should ask. Please don't say giddiness and send it to Dr. Jayaprakash, Dr. Raja Selvaraj, Dr. Nabar. Let them work it up. So you should take a proper history in syncope, and once you do that, a detailed history of the background also is necessary.
Thanks, JP. I think an account from the eyewitness would also be similarly helpful.
Absolutely.
So I think we'll have more questions for you in the discussion. We'll move on with the session. I think the next presentation is by the master himself. Hygriv, you are not missing, I guess. Yeah.
I'm going to talk on a case with ECG in sinus node dysfunction. Can I have the slides? Yeah. Sinus node dysfunction is a very intriguing arrhythmia. On one extreme, you have patients who are actually given pacemakers unnecessarily because people are scared, there's a pause. On the other extreme are people who get missed because their symptoms or ECGs are not very typical. This is the second part of the story that we are going to see here. 65-year-old lady physician, effort intolerance for past 1.5 years or so. Her ECG are only sinus bradycardia. Her echocardiogram was normal. She went to many cardiologists. One of them invariably did an angiogram to see her effort intolerance. It was normal coronary. Now, the problem why this patient had a delayed decision making was, this lady was well-heeled, well-connected in the medical circle. She went to many cardiologists, And she had insurance both here in the United States. She was evaluated in the US too. In the US, she even underwent a ELR for 3 months. The problem was the delayed decision making occurred because none of the symptoms fit in the common way that physicians perceive. There was no syncope, there was no pre-syncope. And second thing was the ILR. They were very meticulously seeing the pauses were only 2 seconds, never more than 2 seconds. They told her that you don't merit, according to the guidelines, you don't merit any further treatment, you have to live with it, and she was carrying on her life. Now she developed memory disturbances in her work. Her quality of life deteriorated. She started having difficulty in concentration work, periodic confusion, lethargy. Their family took her to a psychiatrist. They diagnosed either early Alzheimer's or probably some psychiatric situation. She already put on medicines. This is a situation where she came to Hyderabad for another opinion. So when I saw her, there's no more tests to be done. She has undergone so many tests, everything possible. So I just saw her ECG, resting ECG is bradycardia, just reviewed all the investigations. There is pauses, there is prima facie, there's enough reason to suspect a sinus node dysfunction clinically. Nothing more, we put a pacemaker for her, dual chamber. Basically atrial-based pacemaker. So the only thing I did was an NT-proBNP. NT-proBNP was elevated, and she had symptomatic neurocardiogenic, symptomatic sinus node dysfunction. Put her on a pacemaker. You can see that the atria are pacing and programmed in such a way that predominantly atria pacing was occurring. Her quality of life improved for the next so many months, and showing that the direction was right. Now, let us go into this ECG presentation of this condition. The ECG presentations of these are not just pauses, they are varied. The first ever description of sinus node dysfunction came from Short in 1954 in British Heart Journal. They described the classically what we taught in the MBBS as a tachy-brady syndrome. There are just 4 patients. He presented this is the first ever description of sinus node dysfunction. Now we do see these kind of situations. Now the other classical things that we are often associate sinus node dysfunction is the pauses. Now if you disappear pauses, various pauses, now the first one is patients who have syncope and they have atrial tachyarrhythmias like a flutter. Now what is to be remembered is that it is never the flutter that causes the syncope, but it is the pause that occurs at the termination of the atrial flutter. That is the cause of syncope. When you put a ELR for them, that's exactly where they develop the syncope. So the mechanism is the overdrive suppression, the flutter suppresses the sinus node, and when the stunned sinus node stops, and then leads to a pause. Now, this is a patient who has effort intolerance, occasional dizziness. Now, pause is definitely there, a short pause. More importantly, you can see the P waves. The P wave morphology is different from one beat to another beat. So when you have a varying P wave morphology, it means that the sinus node is not consistently firing, and there are other pacemakers in the atria which are helping the patients to run the heart. Now, there are electrophysiologically, you can call it a type 3 SA exit block or a sinus arrest. That is where the sinus node fires but doesn't come out, or the sinus fails to fire at all. The presentation is same. Both of them have pauses, and these are not an exact multiple of the sinus beats. That is how these two are differentiated. It is futile to make a diagnosis of either of them, electrophysiological diagnosis. It suffices to recognize the pause and associate with the sinus node. Now, sometimes you have the pause which is the exact multiple of the sinus beat, and that is typically called as a second degree SA exit block. Now, the second thing we see often in patients is junctional rhythm. Invariably, drugs, hyperkalemia, we always work up and we eliminate them to get rid of this. But what needs to be mechanistically recognized is that when you have a junctional rhythm, again, it is an indicator that sinus node is not firing. And it can be seen in the EP lab, it is very well demonstrated when you start pacing the atria, the nice atrial capture and ventricular conduction. So if you have a junctional rhythm persistently in a patient who is symptomatic, suspect sinus node dysfunction. Now, junctional beats also underestimate the duration of pause. Now, classically, these days, everybody looks at the Holter, ELR, and they write the reports, 2.5 second pause, 2 second pause, and all these things. Now, it is not suffice to just read the report. Now, look at it. This is a patient sinus beat, and a long pause, and the junctional beat. The junctional beat indicates that the sinus node never fired, and that is why the junctional beat came. So this pause, actually, like in the patient that I described, it underestimates. If you quickly just look at the report, it looks at a pause. You have to make a clinical assessment of the patient, showing that this patient has a pause and a junctional beat. Now, the 58-year-old lady, fatigue, syncope. Now, sometimes these pauses can result in dangerous arrhythmias like this. You can see 4 beats of broad curious tachycardia, VT, and these morphologies are different from each other. Now, this patient had syncope not because of the pause, but because of the ventricular arrhythmia. And this is also one of the reasons why a patient can have syncope in these patients. Now, the other way is the other aspect is chronotropic incompetence. Patients who have sinus node dysfunction, they have bradycardia, they never have pauses. If you see carefully, they afford intervals. We make them walk, make them run, their heart rates don't improve. This is particular concept is a chronotropic incompetence, where a sinus node doesn't respond to the needs, physiological needs of the patient. So typically a stress test is done. A practical way I would suggest, if you don't want to do stress test for everybody, is when you put a ELR Holter, please tell the patient not to sit silent at one corner of the room. Tell them to do everything that they do normally. Encourage them to walk upstairs, walk fast, walk slow. What happens is when you analyze the ELR in these patients, you get a fair idea. When the patient is running, what is the heart rate? When the patient is sleeping, what is the heart rate? There is an indirect way you can do a treadmill test. But of course, if you objectively want 220 minus age and you want to see 80% of the predicted heart rate, yes, a treadmill should be done. But remember that many people, because of arthritis and other things, they may not be able to do a treadmill. Now, another thing is the patient has an AF and a slow ventricular rate like this. It is still AF. It is not a complete heart block where it is a regular QRS. So irregular QRS, narrow QRS, but still slow ventricular rate without medications, without digoxin and other things, suspect sinus node dysfunction. Now, this is one of the patient who had a ELR. This is very intriguing. ELR was put on this patient. We had a potpourri of arrhythmias in these patients. The important thing for the physician is, if you look at each of these arrhythmias, each of them are pathological. Please don't treat each of them individually. Look at the picture as a whole and diagnose this patient. Now, this patient on day 1 had a brief run of AF. So the AF, pause, and second thing, he had ectopic atrial activity, as I showed. All the ECGs I showed were there in this patient. Patient had his bradycardia, and the P waves were different morphologies, and then there was a junctional beats in between. Again, all this inference is that sinus node is not functioning. The patient had a run of atrial tachycardia, and then patient had a pause after atrial tachycardia, as I showed, because of the stunned SA node, which I showed in the first case. So a plethora of arrhythmias in a single patient on a single ELR. Now, this is the last slide is also very, very important. It was sometime taught to me long time in DM, but I rarely see this, but one has to keep your eyes open. That is presentations of sinus node that need clinical judgment. They don't come out of the textbook. Patients with sinus node have a hypoperfusion. They not just have syncope, but have memory loss. They're misjudged as dementia. They have palpitations, angina, and they have periodic oliguria. These are very rare. Fatigue. So if you have neuropsychiatric manifestations in elderly patients, do not always label them as some Alzheimer's or dementia. Always also consider sinus node dysfunction, because pacing will help them. So in conclusions, ladies and gentlemen, varied ECG presentations can be seen in sinus node dysfunction, varying from sinus bradycardia pauses to VT. Clinical judgment is often needed when assessing a patient with bradycardia. It is not always reports which will help us make a diagnosis. It's an overall clinical judgment. Avoid temptation to treat each ECG abnormality separately, like an AF, AT, or pause. Look holistically at the patient's symptoms and make a diagnosis in this patient. Treatment for symptomatic sinus node dysfunction is permanent pacemaker. Thank you very much.
Thanks, Hygriv. You chose a rare presentation of sinus node dysfunction to discuss, and of course we'll have a lot of questions again, but 1 or 2 questions, burning questions from the audience and or from the chair, and then
Thank you. That was great presentation. So this is one of the things which we see very commonly. As a matter of fact, I was just seeing somebody like this a couple of days ago. This age group where around 60 and all these sort of things usually happen. Their usual complaints are this tiredness, lethargy, and all those things. As I said, hypoperfusion is something which we all tend to ignore most of the situations. So memory loss or tiredness, weakness, and all these patients, Holter sometimes actually does not pick up. So this is the situation where we end up doing repeated Holters a couple of months later and all. And unfortunately, once you say implantable loop recorder, it costs a fair amount of money, and most of the patients actually back off. So good point.
Correct.
And
As
that,
I was taught more than 20 years back, in patients with bradycardia and sinus node dysfunction, it is clinical assessment one has to make a decision rather than on a Holter or a ECG. There's a question here. Yeah, go ahead.
In an asymptomatic person with significant pauses on Holter.
A very important question. I'm sure it will come to discussion. The pauses are a very important thing that are sometimes there is an overreaction for patients. So what actually one must see is when you have a pauses on Holter, first of all, you should ask yourself why you are doing a Holter in a symptomatic patient. That is the first question one must ask. So most of the time the problems comes with because we over-investigate patients. So once we clinically feel the requirement to do a Holter and we do a Holter, when you have a pause, the first thing that you need to see is when is the pause occurring. Now, if a patient has a pause, even whatever the duration is, if it is occurring in deep sleep or when the patient is not active, the significance is not the same as the patient is awake and walking around. Because the interpretation is that there is intense vagotonia and this is causing the pause. So the interpretation is not the same. In other words, they are not clinically significant. The second thing is the pause, if the patient has some symptoms and we do a Holter to understand the symptoms, when you have a pause, you need to ask the patient if the symptoms are replicated during the pause. So these both clinical situations help us to understand. And needless to say, in awake, if the patient has a pause more than 3.5 seconds, and if you say there are no symptoms, you generally mean no symptoms, clinicians mean no syncope, no presyncope. This was the exact situation in this patient. So if you have such long pauses, you need to interrogate. Is the patient having symptoms apart from syncope? Second thing is, are there heart failure symptoms? And you sometimes need to do an NT-proBNP in these patients to see if there is a diastolic heart failure. All these will help you to make a decision whether you need to implant a pacemaker.
What is the gold standard for diagnosis of sinus node dysfunction? Is there still a role of sinus node recovery time? The
invasive EP studies are over the period of time becoming less and less important. It was initially done frequently for diagnosis of sinus node dysfunction. As I said, now clinicians do not want, it should not end at diagnosis of sinus node dysfunction. We diagnose sinus node dysfunction quite frequently. But the issue is it therapeutically relevant? Do we need to put a pacemaker? That is what the clinician needs to see. Now, for that purpose, a clinical judgment based on all the things that I said are more important than a particular situation.
Hygriv, can I make a few comments, please? Yeah. The first description of sick sinus was when they cardioverted a patient with AF, there was a pause. And that was when they started calling it. It was way back in the first report. It was actually called sick sinus. But the word sick sinus syndrome was coined by Irene Ferrer in 1968. It has come out in JAMA. Then she wrote a very nice review, which came out, I think, in 1982 or something in Circulation. So she was the one who described it. Now there are two parts to it. If a patient has got sinus node dysfunction plus symptoms, then it is called sick sinus syndrome. If you just have asymptomatic patient, then it is called sinus node dysfunction. Because for a syndrome, you have to have minimum two components. One is the ECG component, the second one is the symptoms. So when you have those two, it becomes sick sinus syndrome. Sick sinus syndrome encompasses a large number of group of things. One is it can be tachybrady syndrome, or it could be SA exit blocks. SA exit blocks are conduction problems, while as sinus pauses, without any AFib or AT, if they have long pause, that is a problem of impulse formation. So it can be problem of impulse formation or problem of impulse conduction. So all these encompass sick sinus syndrome.
Thank you, sir.
And the second thing is, in mildly symptomatic patient, there is a very fine paper called TheoPace study. You can use theophylline in these patients to accelerate the heart rate. Number two, asymptomatic bradycardias. Patients who have asymptomatic bradycardias live longer than patients who have sinus tachycardia. The longest living animal has only 2 beats. That's the tortoise.
Just one comment from Dr. Krishnaraju before because time is up.
No, I had a very interesting clinical scenarios, which is not actually six-sinus syndrome, but resembling six-sinus syndrome. Thyroid masses, the neck tumors, neck radiation, and carotid sinus glomus tumor. They have sinus bradycardia and sinus pauses. If you take care of this thing, everything disappears.
Correct. Very correct. I think.
Thanks, Hygriv. I think nowadays every pacing symposium moves towards the leadless pacemaker, and that's what everybody is keen to understand from Dr. Vanitha Arora as to where should they implanted, where they should be implanted, where they might be implanted, and things like that. And I'm sure Hygriv's charm has got Vanitha Arora here to Hyderabad and on the podium. Vanitha, we don't see you that often, so I'm interested in listening to you.
You should ask the reason why I'm not seen around so often, right? Anyway, anytime anybody invites me from heart and that person is my friend, I definitely be there.
Sure, please.
And thank you, Dr. Hygriv, for inviting me here to your beautiful city of Hyderabad. It's a pleasure always being here, and I mean, it's very nostalgic too, because I really enjoy in a very different way, because two of my examiners are sitting right in front of me, my DNB examiners. Both of them are sitting with you, Ashish. So it's enjoyable in a different way.
Great.
And following such beautiful talks that we had in the morning, I'm just going to try to justify the question that was asked to me by Dr. Hygriv. This is going to be a little technical talk, and because it involves a technology which is very, very recent in last 10 years. So he has given me a clinical scenario of 70-year-old man who was implanted with the DDR pacemaker for complete heart block. 1 month later, he developed infection. He was given antibiotics. It did not improve. The dual chamber pacemaker was it was explanted. Sorry, it was not implanted. It was explanted. And now, what do we do in this such a situation? Leadless pacemakers have come up in a very good way for such scenario. But is it the only indication, or can we go past that and see where we are today and how we can help more patients with this technology? People who are doing pacemakers have seen this kind of complication occurring despite their best of efforts, whether it is form of infection, the pocket extrusions, or the lead breakage, or Twiddler syndrome. All these, they come in. We have all seen this. And about 56% reduction in complication has been seen where the data comes for with the leadless pacemaker as compared to transvenous complications in the long run. So this is a data which was published to about 1,500 patients where follow-up was done for more than 5 years, and the complication rate was around 12.4% as a whole in patients who have transvenous pacing. Please don't think I'm going against transvenous pacing. I love it. I do it every day. But this is what data is showing. So we have to look at it in a right perspective and see what we can do about it. And our seniors saw it very, very early. This is a paper from 1970. 1958 was the first time the implant was done for a pacemaker. 1970 was the first prototype of the leadless pacemaker which was developed. So something was not right. Something was touchy about it. We were not ready for leadless pacemaker then, but we were looking at it. And it did become a reality in 2016 when Medtronic introduced the first leadless pacemaker, but it was a single chamber pacemaker. 2016, we were already moving towards dual chamber pacing. We were talking about conduction system pacing. So leadless pacemaker came as a solace for a very small group of patients where there was infection, where there was lead breakage, where there had to be an explantation of the device, and where the patient was on dialysis, had fistulas, the access problem was there, or past surgeries where access was not there in the upper limbs, so in those patients. Finally, we went on to developing a VDD pacemaker, which was atrial sensed ventricular paced. We had it for the complete heart block patients, where we had to only sense the atria, pace the ventricle, and we had the Micra AV. Then the longevity became an issue, that probably the longevity is not that good. They worked on the battery life. The longevity became better from 7 to 10 years. It became about 15 to 17 years. The AV synchrony became a challenge because AV synchrony, for that AV synchrony to be maintained for more than 80% in AV Micra, we had to keep the sinus rate around 70-75 beats per minute. So the patient had to be on a good dose of beta blockers. But then in AV2, Micra AV2, they improved the AV synchrony. They placed a better accelerometer, and then the AV synchrony was not that much of a problem, and the even upper rate was increased, so upper higher tracking rate was given in this pacemaker. So development occurred. So we were taken care of with AFib with CHB and complication thing plus AV blocks. Some patients were could be handled with leadless pacemaker, so the group increased. Now, Abbott introduced another prototype, and this was later on stage from NanoStim. Initially, it was introduced in the world as NanoStim. NanoStim came as the first leadless trial in human being, was started in 2012, but it was a havoc. Why it was a havoc? Because they gave it to anybody and everybody without giving a proper training, without having a good hand in implanting the pacemaker. The leadless pacemaker needs a different thinking rather than the conventional pacemaker, which we have been doing for years together. So there were so many complications with NanoStim that FDA withdrew it, and it was explanted, and Micra was put in many patients all over the world. Then finally, NanoStim company was taken over by Abbott, and then Aware came into picture with the change in the technology, with the change in design, with the total different mindset. It was introduced, and the first IDE trial started in 2022. Further on, we had a single chamber Aware pacemaker, leadless pacemaker, with the actual screw at the tip, which we were attaching in the right ventricle. Well, it went ahead to getting a single chamber pacemaker for the atria also. So atrial Aware came into picture in 2024, and thus it completed the journey of leadless pacemaker as a dual chamber leadless pacemaker available with us. I will come to that why was that still not enough? I will just come to that. In 2021, ESC guidelines gave it a 2A indication for leadless pacemaker. Remember that at that time we were having only a single chamber or a AV Micra as a implant. The AHA-ACC guidelines in 2024 came up as a class 1 indication for, again, the same group, single chamber, like permanent atrial fibrillation with CHB, infection, lead dislodgements, and if you have an access problem. That was the class 1 indications in 2024. Now, this we have discussed that the platform was completed by putting in a atrial leadless pacemaker also. Now came in the 2026 HRS guidelines. Now here what they have written is that in patients who require bradycardia pacing support, shared decision making is recommended to choose the type of pacemaker based on a patient-centered approach. So they have widened the things. They have said that patient need to have a right to information, discuss it with the family. In India, cost is a big issue. So I never tell patient to sell their house and come and get a leadless pacemaker implanted. Our conventional, traditional pacemakers are still doing very, very well, and the price is still 3 times that of conventional pacemaker. But the patient needs to have a right of information. We need to discuss, and this has been accepted as a good technology. Whatever data I have is this, that there is a comparison data of 760 patients to 77,000 patients who were implanted in a dual chamber conventional mode. This was presented at APHRS 2025. Well, a leadless pacemaker does have its benefits in lowering the all chronic complication, device-related problems. This Arrhythmia study was presented at EHRA. I just have a short synopsis of that, which shows that the atrial single-chamber leadless pacemaker compared to the transvenous, there is a 1-year complication rate was 60% less with the leadless pacemaker. So the phase 2 IDE study did show safety and efficacy to be very good. And I don't know how they have written 0 dislodgements in that. We have seen dislodgements. And I am coming to know about the data from people that there are some dislodgements in the untrained hands. So I again insist it has to be done in trained hands. The eye-to-eye communication is between the two leadless pacemakers, and this is very, very good to maintain AV synchrony from atria to ventricle and ventricle to atria. The talk that the two devices have is very, very good. And the longevity, they have improved on the longevity. The projected longevity is about 17 years for a ventricular leadless pacemaker and around 13 years for an atrial leadless pacemaker. But I found in the clinical implants that I have done, the longevity to be much better. The long-term retrieval is possible with AWARE device because they have a very good snare. And I've had the opportunity to use this. Trust me, it is a very good snare and it takes out the device very nicely. Now, I'm going to give you a clinical scenario, and I want actually your input. What should we have done in this patient? A 65-year-old male. He had symptomatic bradycardia, giddiness, syncope, pre-syncope, feeling out of breath, going into almost like a failure again and again because of slow heartbeat. His medical history was that he had a pancreatic jejunostomy done. In 1998, he developed fungal infection of the tricuspid valve following this, and the scraping up of the entire valve was done in 2000. So he had a cardiac surgery in 2000. The free TR was left alone till he became symptomatic with that. And in 2018, one of our surgical colleagues did put an Arrhythmia on Onyx 31 millimeter metallic valve on the tricuspid valve. Now he developed sinus nose dysfunction, he had AV conduction disease. What do we do?
A pacemaker with leads with a lead in the RA and the ventricle being paced from the coronary sinus lead.
Beautiful. Excellent. The first choice. I do agree with you, Ashish, 101%. Anything else? Epicardial lead, surgical epicardial, if this is not possible, surgical epicardial lead, but then third cardiac surgery, right? They are, of course. Okay. So I will give you the picture of, you wanted to say something?
AVR.
Okay, these are the images. So one of my colleagues did try cannulating the coronary sinus. See this. The patient went into failure on table. Tell me why. I will play it once more and then we'll discuss. Okay.
One of the disc is moving less? No.
Correct. Why? So what our dear surgeon had done was that when he implanted the device, he actually did it above the coronary sinus. So coronary sinus os opens into the right atrium. It's the most posterior structure of the cardiac structure, and it opens into the right atrium. But this, the catheter, if you see, it is actually going into the coronary sinus is in the ventricle. So he has put the valve, he has ventricularized the coronary sinus. So while, when my colleague was doing this, apparently he was not aware that this has been done. I saw these images after this was tried and the patient came to me looking for an answer. So I analyzed, reanalyzed, and if you look at it, he was able to cannulate the coronary sinus. There is a branch also which most of us will be able to put in a lead, but he could not go ahead and put the thing because one of the leaflet got stuck while he was doing it, and he had to cross the valve to go into the coronary sinus. Now what do we do? So I saw this, I told the patient, I will do leadless pacemaker. He said, how are you going to do? Nobody has been able to suggest us this. I said, yeah, I agree, nobody has done it. Then let's try it, we will do it. Now, because otherwise his answer has to be epicardial. Nothing else can be done, what else can be done? So I went ahead and did the cannulation, I'll skip this part. So the actual challenge was mapping the ventricle and crossing the valve. I had to make multiple, initial discussion, we went around, for 2 days, we went around discussing how to approach this patient. The valve anatomy, I found out from the Arrhythmia people, how to go about it. So there were two, it was a bileaflet valve and there was an area of the rim. Now area of the rim was actually, from the leaflet to rim, that was a larger area. And I compared it to the size of the device, the girth of the leadless pacemaker, and I found that I should not go between the two leaflets, I should go above over the rims. And that is what I was trying to map. In the different views, I checked that I was approaching the right ventricle through that, and then once we did it, it was a trick and a very gentle mechanism that I did, and we were able to slide the device. While keeping it on one of the leaflets, I just let it slide by and go inside the ventricle. And once it went inside the ventricle, I was very careful not to put pressure on the leaflet. Yeah, 5 seconds more. And then we were able to implant it. I did the mapping, did the tug test. You see, the catheter is very free. I have not put any pressure on the catheter, and while doing that, we have been able to do implant first the ventricle, then I went ahead and put the atrial. Atrial was pretty much picture book. There was nothing much I had to do in that, but we were able to give him the answer. So I will stop here. There was another case. I will stop here. The only thing I will say is that CSP has come in a very big way in the pacing field. We do have a prototype of pacemaker which has been presented in HRS. 20 cases human implants have been done. It is promising, but it needs a lot of work still. So let's see. As of today, well, it's a balance we have to maintain. But maybe tomorrow we'll have a better prototype and we will be able to give this therapy maybe to all patients. Thank you so much for your patience.
Thanks, Vanita. And Hygriv can tell us how much more time we can take on this session. But Vanita, if you stay on the stage, we can start with you and then go along with other speakers. I'll request all the speakers to give crisp answers so that we can have more questions discussed. So why do leadless pacemakers have less chance of getting infected, and how soon can they be implanted in a pacemaker dependent patient after an extraction, and why? Yeah.
I think the answer to your first question, Ashish, is that it is a closed system. You see, when you are putting a lead, when you are putting a device, foreign body through the skin, you are opening up the wound, you are taking time to manage the things, and the infection always goes from, I have seen infection going from skin to inside, right? When you are doing a leadless pacemaker, actually you're doing through femoral or jugular, whichever site you choose, that is a closed system which you have implanted inside. There is no communication with the outside. So probably that keeps that leadless pacemaker safe. And the answer to your second question is that I have done implants in dependent patients. I've done the explantation in a patient who was Staph aureus positive. totally dependent. Instead of keeping him on a TPI for a longer time, I did the implant, cleaned the whole pocket there and then, explanted and implanted the pacemaker there and then only. And they have done fine. They have done absolutely okay. There has not been any infection there.
So does it have to
I think if you leave infection on the leads, when you are explanting, you don't do a complete explant like using the extraction tools and everything. If you leave infection inside, then there can be a problem. If you are taking out everything, there is no infection on the leads, and you are taking out the leads and the device, then you can implant at the
So
same
does it
time.
have to do with the surface area of the leadless being much less than the
Yes.
whole lead? Yeah.
Yeah, the leads have a lesser surface area, but it is the communication probably. So,
See, if there is an infection and you have done an extraction, so there is lead, when you're taking out the leads, there are three terms we use. One is lead removal. That means you can either explant it, which is a lead with a shorter duration, you use only this stylets, implant stylets, or you use specialized tools, which is extraction, which is necessary in older patients. In such, if you have done extraction and you have done a lot of damage to the internal tissue, I would not be in a hurry to implant the leadless. Number two, if you want to keep the patient on temporary, you can do what is known as a temporary permanent pacemaker from the internal
yeah,
jugular.
I've heard people doing this, yes sir. Right.
I do it routinely.
So Vanita, a quick question, since you speak from the heart. Can you enumerate when do you use Micra and when do you use Avier?
See, if I have a patient with the AV block, I prefer to use Micra. If I have sinus node dysfunction and AV conduction disease, then I prefer to use Avier. And in totally sinus node dysfunction alone, I use Avier single chamber. I don't put ventricle. I explain the patient that I will be able to upgrade it at a later stage. So that's about it. See, there is a difference in price of Micra AV and Avier dual chamber. So you should, if you don't have sinus node disease, it's better to stick on to Micra. Both of them are very good technologies. Please know that. I really like, both of them are very good technologies, but I again say, it should be done in trained hands. It should not be done otherwise.
Yeah.
I've had a havoc, I've seen a patient's havoc, in untrained hands.
Yeah, sure. Thanks, Vanita. Let's move on to Hygriv. I mean, Hygriv, when you start implanting pacemakers in believing that the sinus node dysfunction is responsible for the cognitive problems, the patients are often going to, or the relatives are going to ask you whether this cognitive function will improve by doing a pacemaker. And you usually would have done some neuroimaging in a 70-year-old guy and find some age-related changes in the cortex, and then how do you weigh that neurodegenerative versus a sinus node dysfunction, and how do you arrive at a decision?
Actually, a very pertinent question. The answer to it cannot be given as a generalized form. It has to be individualized. See, for example, this particular patient which in question which we were discussing, she already had a neuro and a psychiatric both evaluation extensively. She had an MRI of the brain, and as you rightly said, some changes were fine. So it is very imperative that we have to make a clinical judgment on individualized basis. This particular patient, if you feel that if you look back into the history, patient was really doing well, and it is just 1 year patient developed so many things, it's extremely unlikely that an Alzheimer or any neurodegenerative would go so fast, and which is disproportionate to the MRI findings. So in that case, you need to have a very important, careful family discussion. That in this case, as you can see, patient had gone to US and they had not said pacemaker. So it took almost a month, many sessions for me to make them understand that there's a possibility. I said there's a possibility that this patient will improve, and my gut feeling is there is a good chance given the clinical scenario. So I think you have to involve the family, and that's how it happens.
So some discrete answers, I agree. When you have a Trachy-Brady syndrome, how do you prioritize treatment of AF versus sinus node dysfunction?
Correct. See, again, it depends upon what is the presentation. Now, there are patients who have sinus node dysfunction but predominantly present with flutters. So these are the patients you ablate the flutter. Now, when you ablate this flutter or atrial tachycardias, very important that we tell the patient's family that most likely this patient after this ablation would require a pacing, not as a complication of the procedure, but as a part and parcel of the. though that judgment again has to be made on which is the predominant symptom. For example, I showed you a patient who had a flutter followed by a pause. So it is if you take care of the flutter in the patient, the pause also likely to disappear.
Right, thanks. JP, all your cases were very interesting. Can you discuss how aortic root abscess also gives rise to, one of your case was infection and heart block and which recovered. So when do you suspect, how do you diagnose, and how does aortic root abscess lead to heart block?
I did not present any case of aortic root abscess in my this thing. The first one was long QT, the second was Lyme's disease, the third one was CPVT, and the fourth one was short coupled VPC. So,
no, any just an extension on effective causes of complete heart block.
If the aortic root abscess is there, it can impinge on the AV node and cause AV block. Or if the surgeon is going to excise it, he can create an AV block, and probably that is the time when you will require pacemaker. You come off on a temporary pacemaker, and later you can implant a dual chamber pacemaker as and when necessary.
Dr. Hygriv, one question for you. A patient has a 50 to 60-year-old male has got a chronotropic incompetence. The heart rate never goes beyond 50 or 55, even with activity, and has the only complaint as fatigue. What would be your suggestion?
Again, these are the classical patients whom I describe as an atypical presentation of sinus node dysfunction who will likely to benefit from pacing. So these are the patients who take deep history. What is their natural walking and activity in the past, and how has it changed over a period of time? And then NT-proBNP helps in these patients sometimes, because diastolic heart failure is one of the manifestations of patients who are fatigued and so you make again clinical judgment. If your history suggests that this patient was doing well and now on walking is unable to, and you have no other reason to explain the effort intolerance. Coronaries are normal, nothing else, and no other cause of heart failure. Like for example, they do not have OSA, obesity, and other things you obviously excluded. And then you feel this is the only possible thing that could, then you make a clinical decision and implant a pacemaker in that.
I have a comment to make. If you have such a patient, one of the things you can try, as I told you, I mentioned the TheoPace trial. So you can use theophylline 400 milligrams twice daily, long-acting one, and see many a times these mildly symptomatic patients become better. There is already a trial in this, in such patients.
I agree. We have time for one or two questions. So, well, one question for Daljit. Daljit, are you still there? Yeah. Most of these 2:1 AV blocks will usually have a heart rate 50 or less, and it is very difficult to believe that if they are persistently at that rate that they would not be symptomatic. My question is, can you ever avoid a pacemaker in a 2:1 AV block?
पूछा था आपने पहले मुझसे शायद. So if you make them walk on the treadmill, and if their heart rate improves and their exercise tolerance is very good, you can avoid. And you're very clear it's an AV nodal and asymptomatic. My talk was asymptomatic. Any kind of symptoms in the form of fatigue, tiredness, blackout, pre-syncope, decreasing the effort tolerance, you should 2:1. I'm talking about proper 2:1. No AV Venki back and all. We are not talking about AV Venki back here. So you
one comment about before we close.
I think you should have asked sir question.
No, one comment I want to make about drug-induced AV block. This is the last comment. Now there is a very fine paper which has come out in JSCC 2009 from Sammy Wiskin's group. Now they have looked at almost 160 or 170 patients with so-called drug-induced AV block induced by therapeutic doses of beta blockers, verapamil or diltiazem, and these were withdrawn. And over a course of 1 year, almost 85% of the patients required pacemaker. So if a patient is on therapeutic dose and develops an AV block, then it is quite likely that it is only uncovering an underlying AV block disease. Only 15% did not receive a pacemaker in that group. So we have to be looking at, if you are giving 2 drugs which can cause AV block and then you withdraw it, that's fine. If you are giving a single drug in a therapeutic dose, let us say long-acting metoprolol 25 milligrams, you give AV block develops, then that is uncovering a underlying AV conduction disease. It's a very beautiful paper. I think you should, all of you should read it. It has come out in JSCC 2009.
I think we'll close this session now. Thank you.
Thank you very much for all the chairpersons, anchor and the speakers for their effort, time and their willingness to share the knowledge with all the delegates. I am Dr. Jyoti, Deputy Medical Superintendent at KIMS Secunderabad here. So we'll move on to a quick inaugural session. But before that, please give all the speakers, the anchor and the chairpersons a very big round of applause. Some of them came from, as far as from Mumbai, Delhi, and also from Bangalore. So we really appreciate their commitment and dedication towards cardiology and electrophysiology. So as a lamp lights up the darkness of ignorance and takes us towards knowledge, we will start this inaugural program with the lamp lighting session. So I call upon Dr. Sethi, senior most guest faculty from Delhi Heart Lung Institute, and Art Society Office Bearers, that is Arrhythmia Research and Training Society Office Bearers, Dr. Ram Raju, Dr. C.S. Raju, Dr. Krishna Mohan, sir, to come on to the stage to light the lamp, along with our medical director, Dr. Sambit Sahu, and our course director, Dr. Hygriv. Please come on to the stage to light the lamp. Thank you, sir. I request Dr. Hygriv, Dr. Sambit Sahu, and Dr. Sethi to take their seats on the stage. I request Dr. Sethi, Dr. Hygriv Rao, and Dr. Sambit to take their seats on the stage. I request our course director and chief of division of pacing and electrophysiology at our KIMS Secunderabad to address the gathering.
Before I start the proceedings, I'd like, on behalf of Autism Society, KIMS Hospital, and the electrophysiology groups, to few minutes of condolences to our dear friend, Dr. Ullas Pandurangi from Madras Medical Mission, who tragically ended his life a few days before his 60th birthday. An eminent electrophysiology. He was actually a faculty who was supposed to come here today, and a passionate teacher of ECG, a cheerful person, and a friend of all. Great loss to the electrophysiology community. So I request you to maintain 1 minute silence in his honor and memoriam. Thank you. I welcome you all to this Arrhythmia Symposium 2026. Particularly, to all the attendees, I'm particularly grateful to the faculty who have come from different parts of the country. And also a special thanks to Dr. Venkat, who will be joining us. He actually came on a vacation from Minnesota, and we actually practically caught him, LBW, and brought him here to this, and he was nice enough to accept our invitation today. He'll be joining us on the way to the airport. The Arrhythmia Society has been conducting various activities, which include the symposium, a number of research activities, CPR symposiums across the twin states of Telangana and Andhra Pradesh over the years. And each year we have been having a theme for this conference, and many of the faculty have come here many times. And I think we have only Dr. Sethi and Dr. Ajay Naik, our Heart Rhythm Society president, who have been here for the first time. Well, warm welcome to both of them. And coming to the theme, every time we, as I said, the theme, this time we had a theme we thought about as the clinical decision making. Now, over the years, and particularly this particular topic of clinical decision making and this issue of clinical decision making has no more important now as it has been ever before. And the importance is increasing by the year and day. The reasons are many. First thing is, we are living in an era where there is a bombardment of technology on us, both diagnostics and therapeutic. And these diagnostic and therapeutics not only are there, they are very easily accessible and available. There is no learning curve. Any person with a small cath lab can get the best technological procedures done in there. So there is an imperative that there is a need for decision making. As I tell my students, there are three important things that make a cardiologist great or a very important cardiologist. One that must be acquired. One is the clinical assessment. The second is the prioritizing the clinical issue, and third is the decision making. Unfortunately, there is a vacuum of these skills and tools, not only in physicians, but also as a growing teaching that we are doing to the younger generation today. And this issue is not just Indian, it is global. A patient came to me recently from the United States. She went on a vacation to Minnesota, unfortunately did not have insurance. She had a syncope and was admitted. She was admitted for 8 or 10 days in the hospital, investigated thoroughly, without obviously any conclusion. She came back. I just asked her, how much did you pay for it? She said, sir, please do not ask. I could have just bought one flat in Jubilee Hills. So, and she didn't want to mention. So, the reason is not bad intentions at all, because the technology is so expensive and so easily available, and this can happen everywhere. Nowadays, a small indiscretion on a ambivalence or indiscretion on the part of a physician who is treating a patient, a few lines he writes can cost a few lakh rupees to the patient. So it is extremely important that you make a clinical decision making on embarking on expensive tools of investigations and therapy. This time we particularly chose topics. Each of these cases are things that we have seen in the past 1.5 years in our institution. And these cases, instead of just projecting how we treated them, I gave to experts. Now our faculty are experts and what I would call them as very high net worth intellectuals, HNIs in our community, and who have hordes of publications and are speaking for ages. And we brought them to discuss these cases and analyze, as you have seen in the first session, how they bring out the various aspects and also the aspects which are not there in the case. So it's a great opportunity for all of you to interact, learn, and we have specially put 15 minutes extra for each session, which we didn't do last time, because the feedback was that there's not enough discussion after hi-fi discussion of topics. So this is the purpose of the symposium today. Now, we are all what we are because of our teachers. And throughout my journey, academic journey, all my life, I have learned so many things from so many teachers, and I'm grateful at heart to each of them. And teachers teach, they impart skills, and they make us what we are. But there are some teachers also who create a character of practice, which is ingrained in us, how we practice day to day. And also, they create a template on which we embark on clinical decision making and how we make decisions. And one such teacher is Dr. Professor K.K. Sethi, who is here. And he has been, I met him first as a student in 1996 in GB Pant. And over the years, he has been my mentor on various clinical situations. And needless to say, he, not a day passes, even now in the cath lab or outside, that I do not think of him, about the way my hands move, the way I think. So, many of my students have heard his name, and some of them are seeing him for the first time. He is a man who has practices cardiology with grace, charm, and dignity. And that is what we students have felt over the years of time. And it is my opportunity today to honor him and felicitate him for all that he has contributed to people like me over the period of years. I request Dr. Professor Sethi to have his chair, Dr. Sambit. And a token of appreciation from Hyderabad, in grateful appreciation to Professor K.K. Sethi, a teacher and mentor. Can I request all faculty for a photograph here, please, on the stage? All the faculty, please. Everyone, I can't call each one by name. Please come. Everyone. And our KIMS faculty, DNB students, please join me. Any DNB students of KIMS who are here, please come. Past and future. Come, Shirish. Request Professor Sethi to say a few words before we go on to the next session.
Yeah, Aman is a very good friend.
Well, ladies and gentlemen, I don't know what to really say, but I like to say one thing for sure. I'm greatly humbled and honored by this surprise inclusion into this ceremony, and also for giving me the opportunity to be here today among so many friends and senior faculty members of this meeting whom I have known for several decades. I have known Dr. Hygriv Rao since 1996, if I remember the year correctly, when he joined with us as a DM student. And I have seen him grow since then into a very mature and responsible cardiologist. He chose to become an electrophysiologist, something very few people used to do in those days. In fact, when electrophysiology started in this country, it was year 1975 when I was an MD student and I saw the first His bundle being recorded with the help of Dr. Melvin Scheinman in our catheter lab. And since then I somehow got very impressed and interested. And as I finished my cardiology training, I started looking at electrophysiology as a very important portion of the rest of the work that I was doing. For many years from the country, I was a sole crusader in many international meetings, including the then NASP and now Heart Rhythm Society of the United States of America. And I have seen people growing. Today, the electrophysiology in India has grown so much that we are nearly at par with what most countries are doing abroad. And that all comes with the hard work of all these young people who are sitting here as faculty and years of training and toiling in the catheter lab. I'm very happy that such meetings are conducted regularly in this hospital, not only on cardiology, but on various other branches of medicine. Relatively small groups, short meetings, which allow people to listen to the stalwarts in a very simplified manner, making clinical decisions on day-to-day problems. And let me re-emphasize what Hygriv said a little while ago. It's a little unfortunate that clinical medicine is fast disappearing from the scene. Nobody wants to talk to patients. Everybody is treating the investigations rather than the individual. And I think that is something that we need to reflect upon ourselves, because without a good clinical decision and keeping the patient's interest in mind as a foremost priority, it is never a satisfactory response in so many situations. And it's always more gratifying when you are yourself satisfied that whatever I have done is correct for the patient, is financially feasible, and is going to give a long-term benefit to the patient itself. So once again, I would like to congratulate the organizers here, the senior management of the hospital and the institution for allowing such kind of an activity to take place, and to thank all the faculty who is here, who joined with me in the photograph, and also all the people in this hall for giving me this opportunity to be here today. Thank you very much, ladies and gentlemen, and please enjoy the rest of the meeting.
Thank you very much to Dr. Hygriv sir for that lovely introduction to the program. And in our Indian philosophy and spirituality, we place the teacher at the highest altar. That is Sri Gurubhyo Namaha. And we are really honored to have Dr. Sethi here and also spend the day with him and share the stage with him today. So with this, I would like to call upon our medical director and HOD of critical care, Dr. Sambit Sahu, to give a message to the delegates.
Good morning, all. So, esteemed course director, Dr. Hygriv Rao, distinguished faculties, and as Dr. Hygriv Rao said, these are all high net worth intellectuals. And it's actually a fact, because for lesser mortal physicians like us and people not sitting in the front row, you know what's the most dreaded thing that we face is when a attender, a well-wisher, a friend sends you on WhatsApp an ECG and asks you, please read and tell me, is it all normal? Am I right? And that is when you see that all the years of that you have practiced medicine, you have no clue what to answer. So that's where the electrophysiologists and sitting here are very different from all us physicians. So initially I used to send it to Dr. Hygriv Rao, then how many ECGs can you send? So right now, the VIP patients, I send it to him. Non-VIP, I send it to the juniors. Then I thought maybe this Perplexity, Google, ChatGPT. I started putting those things in that and then trying to read an answer, but absolutely none of them can match. But you should try putting that in Google Gemini. It gives slightly better answers than at least us. Now, coming here now, this symposium it's been a decade that Dr. Hygriv Rao has been doing it. It's become the standard of symposium now. And if you look at it, it's unlike other conferences, symposiums that you entered. This is a world of creative content economy. So here you see the content is already in front of you. Very rarely you will find symposiums where the content that is going to be discussed are not taken from books. They are taken from real life, real life world. And we try not to just, what he has tried to do here is start a debate, put in front of us what we daily see in our ICUs, in our wards, and the problems, the dilemmas that we face, and try and go beyond the theory and go beyond the guidelines and get the clinical perspective of doctors. And that is what this symposium actually sets it apart. Now, Dr. Hygriv Rao, sir, has been, kind of so passionate. He's not, I've been interacting with him a lot. I learned a lot of, I wouldn't say electrophysiology, but a bird's eye view, a 30,000 degree view of electrophysiology, because right now he's behind me to get a pulse field PFA and to be the first in Hyderabad to get a PFA. So most likely we shall be getting that and being the first hospital in Hyderabad to have a pulse field ablation. So these are all latest technologies that we do. He's also beyond a very good electrophysiology. I get to know that we have done around more than 2,000 ablations. He's also a great researcher, a great publisher, a great academic, and also very passionate about sudden cardiac death. So he does a lot of things. I've been keenly associated with him for his works on sudden cardiac death. You would be like, it would be of interest for all of you to know that, when it comes to sudden cardiac death, his work, his population level work that he has done, where he has found that 10% of all the deaths are because of sudden cardiac deaths, and more so if in the STEMI cohort, 50% of them are sudden cardiac death. And all of them, they cluster around that 1 month duration. So these are some fantastic findings that he gets from his studies. He also is an extremely good mentor, a good publisher. He's an editor-in-chief for a lot of journals. So is many worlds in one man, and that's where we can see that he brings a lot of expertise to KIMS, and KIMS actually is indebted to him. So with all this, I wish that today's function, today's symposium is actually very clinically challenging, clinically inspiring, and personally inspiring to all of you. And it's my privilege to welcome all of you to KIMS and enjoy these sessions. I get to know that there were 1,200 registrations for this symposium, 1,200 registrations, and that's the reason it is open on YouTube now. And that tells you about the quality of the symposium. So welcome again, all of you, and enjoy the sessions. Thank you.
Thank you very much for the beautiful message, sir. Now we will take a photograph with all the delegates. So I request all of you to come to the center section, and our photographer will take a photograph. So people from the left and the right sections, please get up, come to the center section. So some of you can stand on the staircase here. So I think we all can come in one frame. Can the doctors from the right and left section please get up and come to the center section, please? This is to show that this is the biggest conglomeration of all the cardiologists in India under one roof today morning. Welcome back to everybody for another exciting session, 2 with 4 speakers for 75 minutes. So the topics for this session is ventricular tachycardia and sudden cardiac death. So sudden cardiac death is taxing on everybody, both on patient and the physicians. And in this session, we'll see the risks for sudden cardiac death and what investigations can be done, what precautions, measures, or procedures can be done to save the patients. So for this, I call upon the chairpersons onto the stage to occupy the chairs. Dr. Srinivas Kumar, Dr. Ramraju sir from Rajahmundry KIMS, Dr. Krishnam Raju sir as a chairpersons, and we have anchor Dr. Jaiprakash Center from Bangalore Fortis, and the speakers will be Dr. John Roshan from CMC Vellore, Dr. Ashish Nabar, Dr. Raja Selvaraj from JIPMER Pondicherry, and Dr. Vivek Chaturvedi from Delhi. So I'll hand over the podium to the chairpersons and the speakers. I call upon Dr. John Roshan onto the stage.
Good morning, everybody. And at the outset, I'm very impressed with these lovely clinical vignettes that have been put together by Dr. Hygriv, which is a lot of thought that has gone into it in making these very nice case scenarios which are quite challenging. So the patient I'm going to be discussing is pertaining to having syncope after having a TAVR procedure. So the case goes like this. It's a 70-year-old lady who had a TAVR procedure 4 years ago for severe aortic stenosis. She has had 2 episodes of syncope, one of which needed cardiopulmonary resuscitation. She now comes to us and her ECG is absolutely normal, her echocardiogram is normal, and she's had a head up tilt test done which is also normal. So we have a patient who's come to us with history of syncope and having nearly died, and all her investigations are normal. So how do we take it forward? So I just broadly thought that there are 4 differentials to this. Firstly, a probable bradyarrhythmia, because she's had a TAVR procedure and the conduction system is not far from where the valve is placed. So there could be some kind of AV conduction disturbance which could be the reason for the syncope. The second possibility is a tachyarrhythmia, some kind of ventricular tachycardia secondary to irritation by the valve having been placed there. Thirdly, something structural related to the mechanical valve that is put in there. And fourthly, a reflex syncope. However, the fact that she's had cardiopulmonary resuscitation required during one of her episodes of syncope makes me think reflex syncope is the least likely diagnosis. Now, moving on to these 4 possible differentials. The first one, which I thought was bradyarrhythmic. It's an increasingly common presentation now, particularly with more and more monitoring that's happening. We're finding that patients post-TAVR can develop heart blocks even later. Sometimes it can present even months after. We actually have case reports of people presenting with heart block about 11 months post-TAVR procedure. And the incidence is about 3.7% of a delayed heart block in patients post-TAVR. And if you actually include studies which look at ambulatory monitoring, the incidence goes up to about 4.6%. Now, why do we have this kind of heart block happening? The reason primarily is that apart from the immediate edema and hematoma formation that can happen around the conduction system when the valve is deployed, you have a persistent interaction between this valve, particularly if it's an expanding valve, against where the conduction system runs. And so it's not a one-time contact, it's a persistent mechanical contact which can disrupt the conduction system from its natural performance. So here, if you have a look at this picture over here, this is the right coronary cusp, this is the non-coronary cusp, and below that comes the membranous septum. Now, in this membranous septum, through this membranous septum comes the penetrating bundle of His, which gives off the left bundle branch and the right bundle branch. Now, when you place your tower valve, the valve that is placed extends not just into the tubular portion of the aorta or across the sinuses, but even into the LV outflow tract, which means this area where the membranous septum is, which is where our left bundle branch takes off, is going to be under significant pressure when this valve is deployed over here. And this is not a one-time thing, it's a constant pressure, particularly when you have an expandable valve that continues to expand. So, obviously, apart from edema, hematoma, and immediate injury, you have this chronic radial force that can cause progressive fibrosis and lead to this problem. So here you can see a section where you have the interventricular septum, and this is the membranous part of the interventricular septum. The membranous part of the interventricular septum is divided by the septal leaflet of the tricuspid valve into an atrioventricular portion and an interventricular portion. And in this lower part of this membranous septum, what you see here is the bundle of His, which is giving off the left bundle branch, which is traveling along the crest of the interventricular septum. Now, when you deploy your aortic valve, it is going to extend from the aorta over here down till over here, and hence there's definitely going to be pressure over your left bundle branch that is coming off the penetrating bundle of His. So, again, in a different view here, you have the non-coronary cusp, you have the right coronary cusp, and you have the membranous septum, and your aortic valve is definitely going to be deployed till this region. Now, obviously, if you got a large membranous septum, we know that the left bundle branch sort of takes off from the penetrating bundle of His in the lower part of this membranous septum. So if you've got a large membranous septum that sort of extends down till somewhere over here, there's a possibility that your left bundle branch will escape this valve that is being deployed. But if you've got a short membranous septum, then it's very likely that it is not going to escape and it's going to be compressed by this valve. Similarly, if you deploy your valve lower down, the lower you go, the higher is the chance that you're going to catch the conduction system. So looking at the factors that predispose patients post-TAVI to having conduction disturbances, apart from some studies which suggest male patients and patients who have a long PR interval, where the PR more than 240 milliseconds suggests a higher risk of needing a pacing, the other things are a pre-existing right bundle branch block. And this is a very important risk factor with multiple studies suggesting that if you have a pre-existing right bundle branch block, the chance of you needing pacing post-deployment of this valve, which is going to press on the left bundle branch block, resulting in a complete heart block, is very high. And the incidence from various studies ranges from as low as 3.7% to as high as 40%. However, when you look at just patients with right bundle branch block post-TAVR procedure, about 60% of them did not need pacing. So the point is that not everybody post-TAVR is going to need a pacing even if they had a right bundle branch block. Now, a new onset left bundle branch block, again, where the QRS duration goes more than 160, is very likely to need pacing. Calcification involving the aortic valve region, involving the outflow tract region and the mitral annulus region, particularly the non-coronary cusp region, has a high risk for causing the need for pacing. Now, you would understand very well that your non-coronary cusp and your right coronary cusp are sitting over here, and like I'd shown you in the previous picture, your membranous septum is sitting over here. So if you've got calcification over here and then you deploy this valve, it's going to push that chunk of calcium onto the conduction system. It's like a rock hitting this conduction system, which is obviously going to cause conduction problems. A short membranous septum, like I already highlighted, and a balloon predilatation are things which again predispose you to having a heart block. Now, a balloon predilatation results in what's called a double hit. The first hit is the balloon being expanded, and the second hit is the valve frame progressively expanding. So it's a double hit on the conduction system over there. Self-expanding valves, like I told you, are valves which continue to expand after being placed, and these things continue to exert pressure, causing fibrosis and injury to where the conduction system is. The deeper you implant your valve, the higher the chance of having a conduction problem, and this increases with each 1 millimeter that you go further down into the outflow tract. So if you go 5 to 7 millimeters below the aortic valve into the outflow tract, you are almost certain that you're going to affect the conduction system. Again, oversizing or over-expanding a valve in relation to the size of the outflow tract is again going to lead to damage to the conduction system. So finally, and most importantly, a negative workup does not rule out AV block. And when I say a negative workup, it refers to you having monitored the patient on telemetry. Like this case that we have has a normal ECG. You monitor her on telemetry and you find it is still normal. That does not mean there was no AV block, because these things can be paroxysmal, they can be episodic, they don't need to be manifested all the time. One thing that's often done is an EP study, but you could still get a normal EP study with normal HV intervals and still have this problem manifesting itself at a different point of time. Some people have advocated using drugs along with the EP study. The drugs that have been recommended are flecainide and procainamide. Flecainide can't be used in this patient because this patient has got structural heart disease where you have ventricular hypertrophy secondary to the aortic stenosis. But procainamide can be tried, unfortunately not available in our country. Procainamide is known to bring out the conduction problems in these patients. Now moving on from there to our second differential. The second differential is a tachyarrhythmia, and the tachyarrhythmia is ventricular tachycardia. So it's possible that the patient had a ventricular tachycardia which caused her syncope. Now why should somebody have a ventricular tachycardia? The reason is because you've deployed this aortic valve over there. This aortic valve is exerting pressure. The pressure causes fibrosis, scarring, and that scarring could result in irritation leading to an automatic focus or a micro re-entry leading to VT. Now do we have evidence about this? Yes, we do have evidence. There are multiple case reports that have suggested this problem. It's often felt that it is underreported. In fact, if you look at ambulatory monitoring, they have picked up non-sustained VT in about 6% of individuals post-TAVI. Generally, if you had VTs earlier and you had a TAVI, the incidence of VT comes down. But placing an aortic valve over there, which is progressively expanding, can cause scarring and can cause VT, and this has been well documented. Now, the region from where this VT usually comes is the aortomitral continuity region, which is where your non-coronary cusp, left coronary cusp, and your mitral valve sort of come close to each other. This is different from your LV summit region, which is quite close by, but a little bit more anteriorly located. So, there is a case report of a patient who presented 6 weeks post-TAVR for a regular checkup, was having the echo done, and while the echo was being done, the patient got breathless. It was noticed that the patient had at high rate. They did an ECG, which you can see is a ECG suggests to a VT coming from the aortomitral continuity region. And they went ahead and started the patient initially on amiodarone, stabilized the patient, later on took the patient to the lab. They mapped, they found scarring in this region, and they went ahead and ablated, and the VT was thereafter no longer inducible. The patient has been doing well on follow-up. There's another case report, 2 cases of patients having had VT post-TAVR. One was detected about 5 days post-procedure, the other was detected 5 months post-procedure, both of whom were managed with IV amiodarone. We also have bundle branch re-entry, which is relatively common post-TAVR because you're expanding this valve, it compresses on the left bundle branch, causing the left bundle branch to get damaged, becomes slower in conduction compared to the right bundle branch, setting up a possible re-entrant circuit. In this situation, you go ahead, identify the arrhythmia, ablate the bundle branch, which is weaker. These patients usually end up needing pacing once the bundle branch has been ablated. Moving on from there to structural causes. Now, structural causes are something we need to rule out. In this particular case, we've been told the echo is normal, but it is possible for the echo to miss things. So you could have a subclinical leaflet thrombosis, which can be missed on the echo and is better picked up on the CT scan. You could also have structural valve deterioration. You could sometimes have coronary obstruction. There's a case report of the valve having been deployed, causing a chunk of calcium to cause obstruction to the coronary artery, leading to the patient having VT. And they actually took the patient up for a VT ablation and then found that the patient actually had a chunk of calcium obstructing the coronary, which was the reason for the VT. So, and the last thing is a prosthetic valve endocarditis, which is unlikely in this case because we don't have any history of fever or any new murmurs that have developed. And finally, the fourth differential is the reflex syncope. Now, reflex syncope usually will never present in a situation where the patient needs cardiopulmonary resuscitation. But in our country, you may have somebody having had a reflex syncope, somebody may have gone and attempted to start pressing the chest and the patient may have promptly recovered, and they may end up giving you that wrong history, thereby misleading you. However, the other thing here to note is that this patient has had a heart test which has been negative, but we've not done a carotid sinus massage, which is important, and that would be advisable to be performed to rule out carotid sinus hypersensitivity. And same way, situational syncope is something that could happen, which need not necessarily be picked up on a heart test. And it is important to go into the history in detail to find out what was the patient doing when the patient had syncope. So now looking at the syncope, now this patient, when we look at syncope, we have to decide is it a high-risk syncope or a low-risk syncope. And there are certain features that suggest a syncope is of high risk. So if you have syncope when you're exerting yourself, or you're having syncope while you're at absolute rest, like lying on the bed, then that would be a high-risk syncope. If you have a syncope associated with an arrhythmia that has been documented, then again, that is a high-risk syncope. If you have syncope without much of a prodrome, then again, that is likely to be high risk. If there's a family history of sudden cardiac death in somebody who's got a syncope, then it has to be looked at with importance. And then, if you've got structural heart disease and you've got syncope, you would be worried if it could be some arrhythmia-related syncope. And lastly, if syncope leads to severe trauma, like for example, somebody is driving a car or driving a bike and has syncope and crashes, then that's very likely to be significant. Same way, a syncope requiring resuscitation. Now, from these things, we know this patient has got two issues. One is she had syncope requiring resuscitation. The other is she's got structural heart disease because she's post-TAVI, definitely had aortic stenosis causing ventricular hypertrophy. So we have two reasons why this is a high-risk syncope. Now, how do we go ahead? Most important thing is to go into the history, take a very detailed history of how the syncope happened, what was the prodrome, what was the patient doing when the syncope occurred. You may need to repeat the imaging, repeat the echo in case something was missed, and even consider doing a CT scan in case there's some leaflet thrombus that could have been missed, causing a dynamic obstruction which could have caused the syncope. Prolonged ambulatory monitoring and ILR are something always considered, and it helps a great deal in picking up AV blocks post-TAVI. The longer you monitor, the more likely you're going to pick up an AV block. Doing an EP study is also something that we may consider. If the HV interval increases by more than 13 milliseconds from baseline, or the HV is more than 75 milliseconds, it suggests that the patient has got definite conduction system damage warranting pacing. And a cardiac MRI, which will help us delineate if there's any scar, which could explain the reason for a tachyarrhythmia. These scars can be small and can be missed on echo, but can be picked up on an MRI. EP study versus an ILR, like I just mentioned, EP study helps you get a quick answer, but an EP study doesn't always give you the answer because you can have a problem and your EP study can come back as negative. An ILR will definitely give you the answer if the patient has an episode while on ILR, but that requires a long wait. And it sometimes may not be advisable in a patient who's had a syncope that required CPR. So essentially, if this patient with further investigation proves to have an AV conduction disease, I would go ahead and implant a pacemaker. If the patient on EP study or on evaluation was actually found to have a ventricular arrhythmia, then we would consider an ablation. If there's a focus that's seen, particularly if you identify it on the MRI, EP study as repeatedly inducible arrhythmia, then ablation would be considered. If all our evaluation comes back as negative, then I would still play safe and consider putting in a dual chamber ICD. And lastly, if there's a valve-related cause that is confirmed structurally, then that needs to be fixed. So my take-home messages essentially would be that when you have syncope that's requiring cardiopulmonary resuscitation, you can't brush it aside. It is something significant that definitely needs evaluation. Secondly, post-TAVR, you can have AV block that can happen much later than when the procedure happens. We have reports of it being a presentation about 11 months after the procedure. Thirdly, ventricular tachyarrhythmia is seldom thought of as a possibility, but is definitely a possibility. There are reports that suggest ventricular tachyarrhythmia can happen post-TAVR due to scar once the valve has been deployed. Fourthly, an EP study being negative does not mean all is well. And prolonged ambulatory monitoring often helps us pick up these AV blocks which are paroxysmal. And lastly, you should have a low threshold for placing an ICD in somebody who has been resuscitated and whose life has been saved. So unless there are strong indications, I would have a low threshold towards placing an ICD in this patient if all my other evaluation draws a blank. Thank you.
Thank you, John, for an excellent exposition on this topic. I think you have covered most of it. Since we are short of time, we'll have the questions and answers at the end of the
Thank you.
As the speaker is getting ready, basically, he discussed everything very clearly. Hygriv also framed it very nicely. But the rarer conditions are luckily rarer in the sense that the scenarios what is created is generally a little less common because most of these patients would have some evidence of some AV block happening, widening of QRS like LVB or intermittent blocks and occasionally. But other important thing we should not forget is the associated coronary artery disease. Patients could develop new coronary artery disease, and that itself could manifest with these things. And today's era, I feel if it is done properly, you need not be worried too much about AV blocks, because we come to single digits, especially if it's placed properly. And then probably if it is a balloon expandable valve, chance of getting into trouble is less. But if it's not placed properly, you put it deeper and do multiple dilatations, all that cannot be told as the reason for AV block. But yes, we are that possibility, even initial ECG being normal, later presenting is well taken. But most commonly, they manifest with the left bundle block initially, which could later degenerate and patient could get into trouble. I think the low threshold to have a good EP colleague like Hygriv and sending these patients would go a long way in saving patients' life. Thank you.
Ashish, can you start, please?
Yeah, thank you. Great attendance, a great view from the rear window of the Hussain Sagar, but we are all here. Very important topic by Hygriv. He always puts a lot of responsibility with a clinical scenario to which you have to speak and focus, and not the textbook for arrhythmology. So, respected chairpersons, anchor Dr. Shantar, let's start. So this is the typical history that he provided me was primary PCI done for acute anterior wall MI in a relatively young male, 50 years old. And the immediate ejection fraction was 33%, not immediate, 2 months later. And he got an MRI done where the scar burden was 15%, and he was started on GDMT, may not be the correct statement, maybe 2 months he was optimized at that time. And 3 months later his EF, further 3 months, I guess it's 5 months from the infarct, improved to 42%, so a 10 percentage point jump. And with no change in scar burden is a little difficult to qualify a statement, because I guess he did not do an MRI again to quantify that, but we will effectively say that scar burden was same 15%. He is asymptomatic, so he is NYHA class 1, and he's not asking whether I should implant an ICD. The patient probably, as you heard earlier in this session, they look at ChatGPT and whatnot. So I guess he wants to discuss the risk of sudden cardiac death. Now there are certain other features which are important before I get to the crux of the matter, is whether only a culprit PCI was done, culprit vessel PCI. Did he have a multivessel disease? Is there a residual ischemia? Because that would have some, or these will have implications in deciding whether he is prone to get a ventricular arrhythmia and therefore sudden cardiac death. How is the LV ejection fraction evaluated? Echo, many times we do visually, especially the second and fourth time that you screen. But there is a certain discrepancy in the MRI and the echo reported ejection fraction, so that also merits some consideration. Guideline-directed medical therapy does not necessarily mean that it is optimized, so you have to go to the maximum tolerated doses, and that could be limited. Particularly for blood pressure, you can't optimize the ARNIs and beta blockers. For the heart rate, you can't optimize the beta blockers. And a history of UTI makes you a little suspicious to give the SGLT2Is again. Scar burden has not changed, but probably we need to discuss more about scar features also. Only saying a scar burden might be insufficient. And then finally, ICD indication is a different issue than risk stratification, because it is a matter of physician and patient risk perception. So number of things that will go in real life before you decide to implant an ICD, but for a while we'll leave these and come to what probably he has in mind. Primary prevention ICD is what we are talking about, because this patient has not had an episode of or is not resuscitated or nothing like that. So the indications from the 2017 American guidelines are pretty clear. If the patient has heart failure symptoms, then 35% is taken as the cutoff ejection fraction. Whereas in an asymptomatic patient, you slightly tighten up the ejection fraction to 30%, and then they are supposed to be the post-infarct LV dysfunction patients are supposed to be candidates for ICD. Only you have to take care that they will have a survival for 1 year, and that they will not have death related to maybe non-cardiac or cardiac causes, which might make implantation of the ICD a little superfluous. So the patient given to me is actually in that green box where his risk of sudden cardiac death is supposed to be less. But if you look on the right side of the bar diagram, you can see that actually the absolute number of people who die are these patients who have relatively good ejection fraction. Let me remind you, the ejection fraction had improved to some 44%, so it doesn't fall into that primary prevention cutoff that the ACC-AHA gave some 10 years ago. Now these are the numbers that will help you to understand the paradox a little better. Actually, people above 35%, almost 70% of them, amongst the people who had sudden cardiac death, if you were to retrospectively look at the ejection fraction, almost 70% had the ejection fraction of 35%. That's the same point that I made in the previous slide. And if you implanted in people who had ejection fraction less than 35%, if you took that as a gospel, then you can see that at 12 years, only 36% of ICDs were used, so the number needed to treat was pretty large. And when you look at the patients who got CRTD, again, only 37% had had a therapy when the next device was to be replaced. So again, there is a cost-benefit consideration. So should you start implanting everybody who has a scar because of previous infarct, even if their ejection fraction of 35%, if you were to do that, then there would be a lot of over-treatment. So it is correct that we started with the idea that ejection fraction is a good indicator of who is at risk of sudden cardiac death, because the risk monotonically increases as the ejection fraction decreases. What we did not look at for a long number of time is, because MRIs were not so developed or so available, is that scar more than 5% means a risk of sudden cardiac death. It may not increase progressively with more scar, but above 5% there is a risk of sudden cardiac death. What all should you see when you look in the MRI for the scar? So scar in MRI is equal to late gadolinium enhancement, and what you should see is whether there is a scar, what is the size of the scar, and there is something called as gray zone, which I didn't have in that history, which might also indicate who is at a risk of sudden cardiac death, because the isthmuses of the VT reentrant circuits are in these scar areas. And therefore, the question is that if this patient has a ejection fraction which is reasonably good and an NYHA class which is 1, is it still at a risk of sudden cardiac death based on the information that you get from the MRI, and therefore do they become candidates for ICD? Look at the state-of-the-art review written by none less than Dr. Francis Marchelinski, and he has pleaded that it's time that we move away from LV ejection fraction as the criteria to implant an ICDs. That means incorporate the MRI findings in your decision making. Now, MRI findings have been pretty well established in hypertrophic cardiomyopathy, where 15% scar is a cutoff to decide primary prevention ICD implantation. Has also been very well proven in dilated cardiomyopathy, where it is superior to ejection fraction alone to decide the ICD indication. But in coronary artery disease, probably we have more observational studies where the extent of the scar and the gray zone is what we have to look at, and this is still not in the guidelines. So it is not in the guidelines. Why? Because we do not have randomized controlled trials. But that does not mean that at this time in 2026 we can overlook the fact. So look at this publication from 2016, not too far long ago. 3,000 patients followed up for 3 years. And what one found in these patients who were post-infarct LV dysfunction. So mind you, this is particular patient that we are talking of. And people who had an late gadolinium enhancement or the positivity, just a positivity. So those who showed a late gadolinium enhancement had a much higher composite arrhythmic endpoint of 23 or 24% and almost 8.6% per year. So they were more likely to have sudden cardiac death than those who were LG negative. Yes, ejection fraction did matter. Those less than 30% were at still higher risk, but the presence of scar itself imposed a risk of sudden cardiac death. And what were these composite endpoints? Sudden death, aborted sudden death, VT, VF, appropriate ICD therapy, or who received even ATPs, anti-tachycardia pacing. So scar presence did matter to the risk of sudden cardiac death. And this is not only one study. Here is a follow-up of 3 years in good number of studies. There are at least 6 studies in this list where the ejection fraction is 30% plus, something that relates to our patient. And here are 3 more studies where the ejection fraction is more than 34%. And if you analyze the scar characteristics on the MRI, these people do have a risk of sudden cardiac death, and they do get either ICD therapies or have had sudden cardiac death and things like that. Now, even this information is extended to 6-year follow-up. So when you have a scar, we have data that up to 6 years, this risk of sudden cardiac death is there, and this is no mean information. For example, what you have to understand is hierarchy. No scar is less risky than scar. Large scar is more risky than small scar. And gray zone area, larger gray zone area is more risky than lesser, smaller gray zone area. So this is the hierarchy in which the MRI should be read and should be analyzed, because these conduction channels which form the re-entry circuits for the VT are in these scar areas. So here is a publication where a very small study, but very, very seminal study. 137 patients, it's not large number. What was done in this study was the decision to implant an ICD was taken clinically. So it was not dependent on the MRI findings. The MRI was done as a research requirement. So all these patients underwent an MRI, but the decision making was not done based on the MRI findings. So look at these 3 patients and you'll understand why Dr. Hygriv wants this point to be discussed. Ejection fraction 33%. So within the range of, and the scar percent is 22%, also very high. So this patient in this study got both parameters concordant for high risk, got an ICD discharge after getting an ICD obviously. So he had an appropriate ICD discharge. Look at a second patient where the ejection fraction is 28%. So he becomes a candidate for the ICD by the current guidelines, but has no scar. But based on the ejection fraction, he did get an ICD. And what happened for 29 months, so almost for 2.5 years, there is no shock. And this is the third patient where the malady lies. The ejection fraction is 46%, scar is 17%, but because the ejection fraction is good, this patient did not get an ICD and he had a sudden cardiac death 18 months later. So this is the paradox that we want to resolve. And what came out of this study was that people with ejection fraction more than 30% probably are equal to people who have ejection fraction less than 35% and a smaller scar. So larger scar does mean risk, but if you have a ejection fraction of more than 30%, then you do have a risk as much as ejection fraction less than 30% with scar. And death, IC discharge, sudden cardiac death, all was relevant. But this is our patient, where you have an ejection fraction of 30%. So by current guidelines, you would probably not easily talk of an ICD. But this patient with ejection fraction more than 30%, if he has a scar of more than 5%, then he is as much as risk as a patient who has ejection fraction less than 30%. So this is the point to be driven home, is that MRI has given this added value in patients who have good ejection fraction. If the scar burden is more, then the risk of sudden cardiac death is as much as when the ejection fraction is less than 30%. So therefore, MRI scar or MRI LG strongly predicts the risk of sudden cardiac death and appropriate ICD therapy, particularly when the scar size is more than 5%. In fact, it predicts the inducibility of monomorphic VT, and it may be even superior to doing an EP study. So the question is, you have to ejection fraction, you have EP study, and you have MRI. It is difficult to use EP study in every patient who is a primary prevention candidate. Here you have a non-invasive method beyond ejection fraction, which you should adopt based on the scar features, whether it requires an ICD. So here is something more. It is not only about presence of scar and extent of the scar, but it is also about analyzing the gray zone, as it is called, which is the border zone. So scar is a dense scar, you have a border zone, and then you have a healthy myocardium. This border zone is, we know from electrophysiology or 3D mapping studies, that this is where the circuits lie. Can you look at them in the MRIs? And this particular region is called gray zone. There is a way to define it. What is a black myocardium is null, 0. So if you have 2 standard deviations above that much whitening, it is a core or a dense scar. If you have 3 standard deviations above, it is the fibrotic area, or this is the gray zone area. Now this area should also be reported by your MRI consultant as to how much is the gray zone fibrosis area and what is the percentage of that denominated to the overall cardiac mass. So there is a seminal publication even on this, the gray zone fibrosis in people who have ejection fraction more than 35%. If you look at the endpoints, and they are the endpoints that you want to address, sudden cardiac death, VT-VF, if you try and look at the results, you see that gray zone fibrosis has the highest risk as compared to total scar area or LV ejection fraction. And if the gray zone fibrosis area is more than 5 gram, they still have a higher risk. So now we have learned to analyze 3 things on the MRI: presence of the scar, extent of the scar, and gray zone fibrosis in the scar. So if your MRI reports all these 3, you might be better positioned
to add that on the ejection fraction or substitute that for ejection fraction to decide the scar. Again, the condition here was that we don't still have it in the guidelines. We have to use this MRI findings appropriately because we don't have randomized control trials at this point in time. So here is a way how to go about it. LV ejection fraction more than 35% low risk, LV ejection fraction less than 35% high risk. You don't stop at that. You do a MRI and look at the myocardial fibrosis or the total scar, and you look at gray zone fibrosis, which is that particular border zone that we are talking of. So if the scar is absent, myocardial fibrosis, the scar is visually decided. So visual assessment of the scar. If the MRI visual assessment shows no scar, then they are at low risk. But if the visual assessment shows a scar, then dissect it further. If the gray zone fibrosis is more than a certain value, so 5 gram or a certain percentage, then you might be talking of a high risk. Again, that's not all. There are T1 mapping, T2 mapping. Just for the sake of time, I will not go into deep, but T1, T2 mapping, the values that are abnormal are center specific. So every center has to work out what with his device instrument is the right T1, T2 value to call it abnormal. They also portend certain features of pathology like fibrosis or extracellular volume. And finally, there are shortcomings to MRI, no doubt. It depends on when you give the contrast, when you read the delayed enhancement, and there are certain features of T1, T2 mapping. If the T2W stir is present, that it means that it is a transient myocardial edema. So there are certain limitations and there are certain advances that will come in MRI using the artificial intelligence to do the feature extraction better. But it is not that we can use ejection fraction as the only value based on which you can decide about the MRI, to decide about the ICD indication. So I do not have a concluding slide purely because it is time to individualize using the MRI in a patient who even has ejection fraction more than 35%, extract the features, whether there is a scar, what is the volume of the scar, how much is the gray zone fibrosis, and then discuss with your patient in this patient, I would particularly believe that this patient is probably at a high risk because his scar value is about 15%. So despite his ejection fraction improved, he will get all the conservative therapy, but SCD restratification, possible benefits of ICD in the long term in a 50-year-old, he has to live for 30 years with the scar. I think that should be discussed well. Sure. So that's my last comments, and we can take questions whenever.
We will take questions in the end because we don't have time.
Dr. Ashish?
Please.
What is the ideal time to assess a scar in the post-myocardial infarction?
Can we have the questions later?
Will there be any
Sir, can we have the questions because we are running short of time? In the end, anyway, we have to give time for the other speakers also.
Thank you.
So good afternoon. So like others have said, this is a very nice format of having case-based discussions, and we've learnt a lot. So this is a patient who has mitral valve prolapse and syncope, and this was the full presentation given. But basically, to summarize, this is a 38-year-old lady who has had 2 episodes of syncope, one mentioned as while sitting and one while walking, has T-wave inversion in the ECG leads, mild mitral valve prolapse with normal LV function on echocardiography, has had a 3-day external loop recorder which showed a low burden of asymptomatic ventricular ectopy, and a tilt table test was negative. So this is the presentation we are starting with. So what I'm going to discuss, we'll want to do in this patient is first review some of the things which have already been done. So I think a lot of people have already emphasized today how in a patient with syncope, history is the most important. So we would want to go back and take a detailed history. And I'll discuss what else we need to look for in the ECG, what else you want to do when you review the echo and in the ambulatory and in the loop recorder. And also what additional investigations we may want to do. In addition to the 3-day ELR data that we have, would we want to do an implantable loop recorder? Will we want to do a cardiac MR, and would an EP study be required? And finally, I'll discuss in terms of management, how I'm going to discuss the prognosis with the patient. What will I talk to her about the risk of sudden death? And we'll have to decide in discussion with the patient whether an ICD is required. And also, there are settings where an ablation might be required. So will we consider that in this patient? So to start off, I think, like I was saying, multiple people have already discussed the high-risk features during syncope. Very important to see if syncope occurred at rest during exertion, whether it occurred while supine. Was there a prodrome? Where there's injury? So absence of prodrome, fall and injury again usually indicates absence of prodrome, so that the patient did not have enough time to protect themselves. Always suggest that this is more likely to be a cardiac syncope. So again, like we said, a negative HUD does not mean that this is not a vasovagal syncope. A history often, if it's very strongly suggestive of vasovagal with a strong prodrome suggestive of that, then might indicate the need to even repeat a HUD with more provocative maneuvers, etc. The ECG was mentioned as showing T-wave inversion. So this kind of inferior wall T-wave inversion occurs in some patients with MVP, usually indicates that there is some amount of stress on the myocardium from the prolapsing mitral valves, is a marker of arrhythmic risk in these patients. What we would look for in addition to that is whether there are PVCs. Sometimes patients might have premature ventricular complexes. You also want to look for any depolarization abnormalities like a fragmented QRS, and those could indicate presence of scarring and again a higher risk of arrhythmias. The most important is going to be a careful review of the echocardiogram, because the echocardiogram is most important in patients with mitral valve prolapse. Mitral valve prolapse tends to get both underdiagnosed and overdiagnosed on echocardiography. So first is to confirm a diagnosis of MVP that it is present. If present, you characterize the MVP. Is it MVP with associated MR or not? Is it MVP with are the valve leaflets dysplastic? And then is it involving both the leaflets, what is called as bileaflet MVP, or a single leaflet? Assess for mitral annular dysplasia, quantify the MR, and look at the LV dimensions. So how is MVP diagnosed? You have to identify the annular attachments properly in the parasternal long axis view. And if you draw a line between the two annular attachments, you see how much the valve leaflets extend above the annular attachment during systole. And like I said, you also look for myxomatous degeneration of the valve leaflets, which may be present by measuring the valve leaflet thickness, and you also assess which leaflets are involved. So this is typically how it will look. You draw a line from the annulus attachment to the other side. You see that the the body of the leaflets prolapses into the atrium during systole. You can also look at the annular velocities with a tissue Doppler, and this sign, the Picolob sign, has been described, which basically resembles the spike on the Prussian helmet and indicates the jerky, rapid ventricular annulus motion due to the prolapse of the mitral valve. Now, also you note the velocity of this systolic motion that you see, and it has been shown that when this velocity is high, and a cutoff of 16 has been suggested, that it indicates a higher arrhythmic risk in these patients. Mitral annular disjunction, so normally the place where the leaflet attaches to the atrial muscle is the annulus, and this annulus is also attached to the ventricular muscle. Now, disjunction is a condition where this becomes detached from the ventricular muscle, and this results in loss of annular function. The annulus mobility becomes more and stresses are higher. So this is again, this is a patient with mitral valve prolapse. You can see with a line the mitral valve prolapses, but the annulus is attached to the ventricular muscle that you see to the top of the ventricular muscle. Whereas here we see a gap between the annulus attachment and the ventricular muscle. So this is called as mitral annular disjunction. So this disjunction is something that you have to carefully look for, and you may need to see multiple frames in a running echo to identify exactly where the valve attachment is, and then see whether this is attached to the ventricular muscle or detached from it. Presence of disjunction indicates the arrhythmic risk in a patient. ECG, like it was mentioned that an external loop recorder had already been used. Now, just looking at the report, we would like to review the whole recording, especially confirm the beat templates, make sure that the PVCs have been identified correctly. Sometimes you can have underestimation of the PVC count because PVCs were not identified correctly. You can also see whether all the PVCs were of the same morphology or if there are multiple morphologies. And you also look for couplets, non-sustained VT, or even sustained VT, which all increase the risk of arrhythmias. What are the additional investigations we'll want to do? Now, ILR definitely is a better way of assessing the arrhythmias, but in terms of arrhythmia load, the 3-day ELR would be fairly sufficient. But if you want to look for symptom rhythm correlation, this is a patient who's just had one episode of syncope, likely that she may not have another episode of syncope for months. And at that time, if it happens and you want to know what the rhythm was at that time, you need to have an implantable loop recorder. So this kind of patients with infrequent symptoms, to get symptom rhythm correlation, an implantable loop recorder would be very useful. And another is cardiac MR. We were discussing in the last one how an MR can be very useful in certain situations. Here, an echocardiogram is very useful. The MR does provide some additional value. One is the image confirms the findings of echocardiography in the sense that you can again assess for presence of mitral valve prolapse and for the presence of mitral annular disjunction. But the additional information it provides is assessment of fibrosis. So this is again how you can see in MR. You can do cine sequences, and it has been recommended that you do in 30-degree angles along the long axis of the ventricle so that you get 6 different cine sequences. And in each of them, you see the valve attachments, how much the valve prolapses, and the presence of mitral annular disjunction, which may be more in the posterior wall, and this is a mitral annular disjunction. But the MR is also especially useful to assess fibrosis. Fibrosis may be focal fibrosis identified with late gadolinium enhancement. It can also be diffuse interstitial fibrosis, which may be identified with T1 mapping. Now, EP study in this setting probably is not required. There's no good data suggesting that EP study helps in either identifying the cause of syncope in this patient or in risk stratifying for sudden death. So first thing in management is to talk to the patient about how serious her condition is and what is the prognosis. I think with conditions like this, which are overall relatively common, but there is a small subset at increased risk, it is important to tell the patient that overall the condition is common. A lot of people have mitral valve prolapse. And in an unselected group of patients with mitral valve prolapse, the prognosis is generally benign if they don't have significant MR. But it is true that a small subset have an increased risk of ventricular arrhythmias and sudden cardiac death. And of course, the key, the primary objective of our evaluation of this patient is to see if this patient belongs to this subset or not. Most of the sudden deaths have been known for long that these are related to arrhythmias. So the relationship between MVP and sudden deaths came from early autopsy series of patients who died suddenly, where they found that a large proportion of these people had mitral valve prolapse. And if some of them had antemortem ECGs, they saw that these ECGs had frequent PVCs, often polymorphic. But when you take a larger cohort of patients and follow them up prospectively, this is about 300 patients followed for about 6 years. The sudden deaths are not that much. But a lot of patients do develop ventricular arrhythmias, and so arrhythmic progression is one kind of clinical problem these patients have. The other is that problems because of the mitral regurgitation itself, requiring either mitral valve surgery or developing LV dysfunction and so on. Again, another large series from which shows that in about 600 patients, more than half of them either don't have arrhythmias or have very few PVCs, less than 5% here. And then the very severe forms who have sustained VT, which is fast, are significantly less common. And the mortality, when you follow these patients up, is strongly related to the initial arrhythmic load during evaluation. So the patients who had the severe arrhythmias, which means the fast VTs, had a 4-year mortality of about 14%, whereas those who had no PVCs or very less PVCs had only like an annual mortality just more than just about 1.5%, which was not different from a general population of the same age. Now, would drug therapy be required? In this patient, as far as we know, apart from the syncope, she had no symptoms, so may not be required. But if patients are symptomatic, beta blockers can help. If PVCs are symptomatic or causing LV dysfunction, you want to try and reduce the frequency of PVCs. Antiarrhythmic drugs can help. Flecainide, propafenone would be good choices if there is not significant fibrosis. Otherwise, amiodarone can also be used. And quinidine, some of these patients, apart from areas of scar in the ventricle due to the mitral valve prolapse, also tend to have Purkinje-related ectopy, probably again from the stretch and stresses on the ventricular myocardium, and these can respond well to quinidine. Again, this kind of Purkinje-related PVCs might induce repeated VF, which may require ablation. PVC-induced cardiomyopathy, if present again, might require ablation if it doesn't respond to drugs. And if a patient gets an ICD for VT and gets recurrent ICD therapies, again, may require ablation. And when patients are ablated, PVCs seem to arise a lot from the mitral valve apparatus, especially the papillary muscles. Sometimes the valves which strike the outflow tract can cause PVCs from there. And like I discussed, you can have Purkinje origin PVCs. As in this from Mayo Clinic, you can see the PVC when they map, you have the Purkinje potential preceding the PVCs. So now the causes of sudden death, and if you look at the substrate and the triggers, some of the most important things, one is presence of myocardial fibrosis, presence of myocardial stretch, which is more in mitral annular disjunction, presence of mechanical traction, which can be identified by the spiked configuration of the annular velocity, presence of complex ventricular ectopy, polymorphic PVCs, couplets, NSVT, etc., presence of bileaflet prolapse, female gender has also been suggested as a higher risk marker. So again, this is in out-of-hospital cardiac arrest patients who have an MVP, again from Mayo Clinic, they suggested that these patients who tend to have cardiac arrest have more often bileaflet MVP, have these inverted T waves in the ECG, have more PVCs, more bigeminy in the Holter, and often also have PVCs coming from both the outflow tract and from papillary or papillary muscles or fascicular origin. So what are the indications for ICD? The standard indications apply, so that if patient has had a previous cardiac arrest, they'll qualify for a secondary prevention ICD. If patients have an EF less than 35, they'll qualify for primary prevention by the other SCADEF criteria. But for patients with unexplained syncope like our patient, you look for other risk markers. If they have high-risk ventricular arrhythmias, or if they have what are called as high-risk phenotypic features, which include MAD, mitral annular disjunction, or late gadolinium enhancement, there may be an indication for ICD. So to summarize, in this patient, what would I do? I'll take a detailed history again to assess for the cause of syncope. If it is truly unexplained, or if there are features like absence of prodrome suggesting a true cardiac cause of syncope, it will really increase the threshold. It will definitely lower the threshold for more aggressive treatment. A careful review of echo is essential to see if it is bileaflet, if there is associated mitral annular disjunction. An MRI of the heart and presence of fibrosis would indicate the higher risk in this patient. So with unexplained syncope, if there are other high-risk features like mitral annular disjunction or presence of significant fibrosis, I would recommend an ICD in this patient. If these features are not present and we are not implanting an ICD, I would still strongly recommend an ILR, so that if she has recurrence of symptoms, we will have a symptom-rhythm correlation. And to generally summarize in terms of MVP, in general it is common, benign, but there is a subset at a higher risk of arrhythmias and sudden death. Unexplained syncope, as in this patient, is a high-risk marker, should be taken seriously, and it should prompt aggressive evaluation, especially with careful echo, MRI, and long-term ECG recording. And if required, we discuss about the requirement of an ICD with the patient. Thank you.
Thank you, Dr. Raja, for a nice exposition on this very important topic. Can I now ask Vivek to finish his talk so that we can have questions and discussion at the end?
I'd like to thank Dr. Hygriv and KIMS for inviting me here. So, as usual, Dr. Hygriv has given a very challenging situation for me to cover. And so the case given to me is that there's a young woman who has come with history of breathlessness on exertion, and she has ectopics on her ECG. And the echocardiogram has showing global hypokinesia with EF about 35%. And the cardiologist who is seeing her now refers to an electrophysiologist, I presume, that whether she's a candidate for an ablation or whether she merits an ICD given her breathlessness and an EF of 35%. So this is a difficult situation because this is always kind of an evolving scenario. What do we know already about this case, which we presume that has already been worked up? We know that PVCs are very common in general practice, whether for a physician or for a cardiologist. They have multiple etiologies, and a lot of them are actually reversible causes like ischemia or some metabolic problems or thyroid problems. And I presume that these have already been ruled out before sending the patient across. If you are seeing even 2 or 3 PVCs on an ECG, it means that the burden is quite sufficient in terms of the total burden, because an ECG probably has 10 or 12 beats in a strip. She also has heart failure, no doubt, because she is symptomatic and she has LV dysfunction. And given her age, gender, and the global hypokinesia, I will assume that this is a non-ischemic cardiomyopathy. Although in India we are prone to coronary artery disease, I may be wrong, but probably she has non-ischemic cardiomyopathy. We also know that PVCs and NSVTs carry a bad prognosis in severe LV dysfunction, irrespective of the etiology. We are also aware of some recent data like the Danish trial, which was a pivotal trial in 15, which was a negative trial for primary prevention ICD implantation in non-ischemic cardiomyopathy. And I assume that the cardiologist has already started this patient on a beta blocker, which is rightly so. No wonder there is some kind of a dilemma in the cardiologist's mind about ICD, because we have a little bit of a different or conflicting evidence as far as the literature is concerned. So look at this sub-study from the Danish trial, and it clearly shows that while PVCs were associated with the total mortality, they were somehow not associated with sudden cardiac death in this trial. Further, implantation of an ICD did not really change the prognosis in patients who had frequent VPCs in the Danish trial. On the other hand, a large study which was done, including in India, and a lot of us were a part of it, called the IMPROVE SCA trial, which looked kind of in a broad way at how an ICD impacts sudden death in patients who have LV dysfunction. And they had evolved a category called 1.5 prevention. So this category kind of sits in between primary prevention, where there's no VT, and secondary prevention, where there has been a VT. And the primary prevention, high-risk primary prevention, that is 1.5, consists of either very poor LV function of 25%, presence of NSVTs, presence of frequent PVCs, or a history of syncope. And we can clearly see that the increased mortality, including sudden death, and benefit with ICD were significantly higher in patients who had high-risk primary prevention, that is 1.5 primary prevention cohort. Mind you, this trial had more benefit in South Asians, and it had more non-ischemics than ischemic cardiomyopathies. So the evidence here is a little bit conflicting. And the guidelines have evolved over time. So already, I think for primary prevention in non-ischemic cardiomyopathy, the ESC has downgraded the recommendation from 1 to 2A, and it has included another things which has already been mentioned by the previous speaker of SCAR, even in patients who have EF above 35%. But we should not forget the fine print, which always mentions that the reversible causes should be excluded. And I hope to convince you that PVCs are a reversible cause of cardiomyopathy. We need to know a little bit more details from this patient, and as has been spoken each time by every speaker, the history is very important. We need to know what is causing this PVC. We do know that certain types of conditions have more malignant VPCs in terms of sudden death, and these are inflammatory cardiomyopathies like sarcoidosis and genetic cardiomyopathies. So both for sarcoid, where increasing PVCs imply increasing certain mortality, as well as the genetic cardiomyopathies, clearly where the presence of PVCs implies a higher risk of events as compared to non-genetic cardiomyopathies, and the burden of PVCs is almost linearly associated with the number of events which are seen. What else do we need to ask and evaluate before we subject this patient to further investigations? Well, asymptomatic nature of PVCs somehow is correlated with PVC-associated cardiomyopathy, which in a roundabout way means that if somebody has no symptoms of PVC but the EF is low, we can assume that the EF low is of long-standing and probably is of PVC-associated only. Syncope or near syncope are ominous features which should not be disregarded because purely PVCs are unlikely to cause that. It is probably sustained VA which has caused this. The duration of LV function is also, dysfunction is important. If it is recent, then it is ominous, as I mentioned earlier. Other organ involvement suggests something like sarcoid, which could be there. And then the characteristics of the PVCs itself, which could be either multiform or maybe the QRS is more prolonged. Importantly, the sinus QRS is also important. If there is conduction blocks or fragmented QRS, they kind of point to an inflammatory or a genetic focus for this PVC. Coming to echo, we do know that if the LV is not too dilated, likely that the dysfunction is because of PVC alone and not because of any other structural heart problem. The burden of PVCs matters a lot. As I said before, there's a linear association of the PVC burden with the LV function and other events. So how much of burden? Well, there is no consensus about this, but broadly speaking, in my own practice, I think 15 to 20% and more are probably significant enough to merit attention in terms of development of future LV dysfunction. How do we decide this burden? There are plenty of studies which have shown that a single or 2-day Holter are not sufficient for quantifying this burden because it can vary from day to day. So probably something like 7 days or more is a more reasonable way to estimate the actual burden of these PVCs. As I mentioned, that multiform PVCs and the duration of the PVC, as I also probably give some incremental information besides the burden, and a right bundle branch morphology are more likely to be related to a scar. So once this is done, in my own view, I think I would still go ahead and go do an angiography in this patient because it will give me two things. It will exclude coronary artery disease. Secondly, it will help me in deciding about the antiarrhythmic drugs should I not go ahead with the ablation. I think the foundational pillar, which has again been repeatedly here been mentioned, is the cardiac MRI with delayed enhancement, which is a foundational pillar for non-ischemic cardiomyopathy management. It rules out structural heart disease like unappreciated hypertrophic cardiomyopathy or diverticular or early ARVC, which may have been missed on an echo. It further tells us about edema or characteristic scar patterns, so for example, for granulomatous myocarditis. Also, this scar burden, as has been mentioned by the previous speaker, of 15% is something which denotes increased susceptibility to sudden death. That can also be quantified. Important to remember that in presence of frequent PVCs, probably an echo is a better estimate of EF as compared to a MRI. And then a PET FDG, I think, is increasingly becoming very important in our practice, where we pick up MRI abnormalities in patients with PVCs to rule out a suspected granulomatous myocarditis. And though this is not for patients with LV dysfunction, but even for patients with idiopathic PVCs with normal echo, this large study from UPenn group showed that 16% had MRI abnormalities, and those with MRI abnormalities had significantly increased event rates. So once we have all this information, we know that PVCs with LV dysfunction have worse outcomes, and now we have possibly three categories. One is a PVC, pure PVC-induced cardiomyopathy, or we could have a cardiomyopathy with presence of PVCs which are there because of the cardiomyopathy and the scar, and the PVCs have worsened the ejection fraction, or we could have a cardiomyopathy where PVCs are just incidental to the actual EF, probably because the PVC burden is quite low. So in my view, after this, even before we go ahead and decide what kind of cardiomyopathy is this, if this patient has sufficient burden of PVCs, as I mentioned, then radiofrequency ablation is the preferred treatment of choice going ahead. It is a definitive treatment for PVC-induced cardiomyopathy, and it also gives a meaningful increase in LVEF even in patients who have PVC-worsened cardiomyopathy. PVC-induced cardiomyopathy is actually a diagnosis of retrospect, because once you have controlled the PVCs with a successful sustained ablation or with antiarrhythmic therapy and the EF improves to normal, then only you can say that yes, in retrospect, this was a pure PVC-induced cardiomyopathy. Certain clues do exist from beforehand when we can say that yes, we are dealing with a substrate which is probably a pure PVC-induced cardiomyopathy. And that means that the heart is not too dilated, which I mentioned before. There is a high PVC burden. Typically, in this, there is one group in Spain which has published a lot, and in their view, probably 13 to 15% is the ballpark figure where you start thinking that below this, if you ablate, it probably will not lead to a normalization of the heart function. And if your QRS, the sinus QRS, not the PVC QRS, the sinus QRS is more than 130, then likelihood is there that this is not a pure PVC-associated cardiomyopathy. But as I said before, and you can clearly see in this diagram here, that even in patients who do not have a pure PVC-associated cardiomyopathy, ablation does increase the LV function. It does normalize the neurohormonal activation as seen by reduction in anti-proBNP and the NYHA class. Even if there is a structural heart disease found in MRI, it is now seen clearly that an ablation of the PVC, if it is successful and sustained in the long run over, let us say, a period of 6 months, then it causes a meaningful increase in the presence of ejection fraction, NYHA class, and reduction in anti-proBNP. So now coming back to the question of whether ICD implant is required or no. So this exact question was addressed in this study, again from Spain, where there were 66 patients, 17% with IHT, and who were meeting the primary prevention criteria for ICD implantation. And these patients had PVCs. After the ablation, only 1/3 had indications for ICD remaining at the time of 6 months. And again, the PVC burden and the presence of sustained successful ablation were the only two markers which said that yes, with this person will go off the list for a primary prevention ICD. So you can see that 66% ICDs were avoided because you had successfully ablated this PVC in these patients. Can I give drugs instead of ablation? Ablation is definitely superior, although it has its own limitations in terms of a difficult or a risky substrate. It is probably avoidable in inflammatory and perhaps genetic arrhythmias also. So in these kind of conditions, there is evidence, clear evidence of benefit of drugs. And like I mentioned, that I would like to start with a safe thing like sotalol. And if my coronaries are clean, then probably flecainide has also been shown. Even if there is a little bit of a scar, it doesn't matter. We can still go ahead with class 1C drugs. And obviously, amiodarone is a very effective drug. Multiple trials have shown meaningful reduction in PVCs and increase in EF with amiodarone. Obviously, it has its own problems in long run. When do I think of an ICD in this substrate? If there is cardiac sarcoid, I do think of ICD. If there are specific arrhythmic cardiomyopathies which are very high risk, like lamin, probably I'll go ahead and put an ICD. And if the ablation fails to improve EF, I would go ahead and do it. So just quickly go across some illustrations of few of these scenarios. So this is a 27-year-old physician with 48% PVC burden with severe LV dysfunction. And you can see that how, just snapshot of ECG or Holter. This lady did not have any NSVTs, but the moment we took her on table, she had runs of these NSVT. We ablated in the right free wall, RV free wall, and her ventricle function normalized. It's been 10 years since then. This is a radiologist who came with PVCs and palpitations. There were some subtle findings in the echo. Holter suggested PVCs from RV, but the morphologies were changing. And while being admitted for further evaluation, he had an unwitnessed syncope in the hospital. So an EPS followed by cardiac MR and further investigation revealed active sarcoid. We immediately implanted an ICD. Since then, he has had 2 appropriate shocks due to rapid VT. I'll just take 1 minute more. So this is another case of a 40-year-old male who's NYHA2 with EF of 40%, with significant scar on MRI, but the PET was negative. There was a large PVC burden of 35% with wide QRS. We tried ablation. It finally partially successful in the great cardiac vein. The burden reduced, but the increased again with a different kind of a morphology. And the Holter burden now since 2 years varies from 10 to 25% at different time points. But recently, his EF has worsened now to 30%. So the advice is of RFA followed by ICD. And finally,
Can we?
Yeah, I think I'll stop here. Thank you.
I thank all the speakers for having delivered a good lecture. Now we'll open this up for questions. Please address the question to the correct person.
This is for Dr. Ashish. Yeah. When do you subject the patient for MRI to exactly assess the scar burden after how many weeks of my index myocardial infarction? And will there be any change in the gray zone area as the days goes on?
So I think the straightforward answer to the first part is that primary prevention post-infarct is considered after 3 months or so. So it doesn't make sense to re-stratify early. You can go by the ejection fraction at 3 months, and if at that point in time it is beyond what is the recommended guideline, recommended ICD indication, then that is the point you can consider an MRI in the present era, and then based on that you can move further. So 3 months would be the answer. Well, I guess the substrate is always evolving. There is a negative remodeling, there is a positive remodeling, depending on how aggressively you have used the optimal medical therapy. And so obviously the substrate is evolving, and I would expect naturally that you should see a difference at certain time intervals, like 6 months, 1 year, but it is purely speculation. And I don't think we have any guidelines to say as to when should be your next MRI or whatever. I think you will go by the worsening of LV function or worsening of the NYHA class, which might itself make an indication for ICD. So there is no good answer to when would you repeat a next MRI or something.
Can I request the speakers to keep the answers brief and to the point? Next question, anybody? Anybody from the floor?
No question, but there are a few comments which I would like to make regarding the TAVR with syncope presented by Dr. Roshan. So I think there is no mention of amyloidosis because it is very well known now. The aortic valve stenosis, about 5 to 8% have amyloidosis. So the so-called arrhythmia could be related to not due to TAVR, but directly, but maybe due to amyloidosis. Second thing is aspirin related. We have had patients where they had syncope following years later after TAVR. Aspirin produced subdural hematoma or anemia due to GI bleed. That is the second thing which I would like to add. Third is if there is an infective endocarditis of the implanted valve, an abscess, annular abscess formation producing the heart block, or long mobile vegetation blocking the ostia of the left main. So that is another situation where syncopes could happen long after TAVR.
My question to Dr. Rajesh Selvaraj, because MVP is a general routine clinical diagnosis what we make. In a patient, young patient who presented with a syncope and incidentally found to have an MVP, is there any way we can differentiate within a primary arrhythmogenic cardiomyopathy and whether management strategy or evaluation strategy differs between an arrhythmogenic mitral prolapse versus primary arrhythmogenic cardiomyopathy? Like early ARVD, which we may not detect on routine tests early.
So you're asking whether MVP was just coincidentally present, but there is another underlying structural heart disease. So I think, like others, we would probably evaluate, like you would evaluate somebody with a echocardiogram looking normal, but we might sometimes consider a possibility of granulomatous heart disease, do a PET in that case, or do a MRI which can reveal abnormality. So if there are findings suggestive of possible underlying structural heart disease, we will evaluate for those.
Originally, there was a classification of MVP called primary MVP and secondary MVP. So secondary MVP is possible associated with any other disease, including rheumatic valvular heart disease.
No, my question is, suppose if a patient with a recurrent syncope has incidentally seen as a mitral prolapse, can we routinely attribute to MVP arrhythmogenic mitral prolapse, or how do you exclude arrhythmogenic IRVD or something like that in early stages, which is very difficult to diagnose?
No, like
is there
said,
any difference in the management between these two strategies?
No, if MVP there was a discussion on MAD, mitral annular disjunction. MAD with curling of the septum during ventricular systole is considered to be more important than MAD without curling.
See, the cardiac MRI and LV ejection fraction, this issue in stratification of sudden death is being increasingly seen. Now, Venkat, I wanted to know how American perspective is there, how much importance SCAR is being given now in evaluation of risk of sudden death.
Thank you so much. First of all, excellent speakers, everybody, and hello to Dr. JP. The important thing is this, you may probably recollect, SCAD MRI study was started and never really progressed anywhere. And that was the intention that ejection fraction has never been a real marker to really associate the sudden cardiac death issue. I think it is growingly becoming more and more. And Natalia Trainova recently published some article actually looking more in terms of the ventricular arrhythmia mapping and potentially doing an ablation. But if you take this into a different context, I think MRI with identification of the scar burden may be possibly be the next marker. But having said that, Shiv Kumar always talks about two aspects of sudden cardiac death. One is the structure and the function, the denomo of structure and function. This is going back to Meyerberg's time. The concept of having the sudden cardiac death. What really makes these patients develop, a risk for developing the sudden cardiac death is still unknown. There is some evolution in the process. I think there is a lot of AI-based algorithms being developed right now, where we actually not only look at the point of the scar, but also point of what really there is some sort of early markers that possibly may have started already, which actually lead to the sudden cardiac death. And we need to also do some population-based studies, partly because there may be some not homogeneity with respect to what really happens in different sets of population. I think that is an equally important part as well.
Any other questions? I have one question for John Roshan. Is he here? John, you didn't mention anything about doing an MRI to find any scar, because these patients usually have concentric LVH. If they have a large scar burden, it would mean that this patient would have had a possibility of a VT.
Sir, I actually mentioned it. So, in imaging, I had mentioned about doing an MRI, particularly in post-TAVI. It has been well documented that they have scar, and the scar is usually in the iotromitral region. And hence, it's important to do the MRI to see whether there are any foci which could cause VT.
Now, the other question for you is, would you do an MRI before you do a TAVR to find out whether there's a scar burden existing before? Because these patients have quite significant, LVH. Just like hypertrophic cardiomyopathy, they too can have scars. Would you consider that?
That's a good thought, sir. I never thought of it earlier. But people have actually looked at patients who had ventricular arrhythmias, and TAVR has actually reduced the amount of ventricular arrhythmias. That has been well documented. So in somebody who actually has ventricular arrhythmias, we would probably do it.
But prophylactically doing an MRI as such, particularly in a country like ours where the patients have to pay, needs some.
Probably patients with LV dysfunction and patients who have echogenic, very highly echogenic myocardium on the echo, those are subsets where I think where you have high suspicion of amyloidosis, especially elderly people. I think there we can do MRI, but not routinely.
Question for Ashish. Ashish, would you do MRI for all patients with myocardial infarction?
Well, I think that one study where I showed to how to use it is probably that you evaluate the ejection fraction at 3 months. If it is already in the primary ICD guidelines, then you ought to discuss with the patient. And
in the present situation, you do MRI in all patients?
so probably not when it is already less than 30%, it's ICD indication, because finally you are doing to decide that. But if it is more than 35%, then it makes sense. But you would also discuss this with patient why you are doing a MRI. The idea is that you want to decide whether you have a strong ICD indication or not. Here is where you will get opinion from the patient or a remark from the patient that he is keen about it or not. In a person who is not keen about it, there is no point opening a Pandora's box doing an MRI.
You are saying it should be a shared decision making.
Yes, precisely. That's the word, that's the sophisticated word for doing this discussion in clinic.
So if there are no questions, we'll close the session. Thank you all.
We are grateful for all the speakers, the chairperson and the anchors for their presence here today and sharing their experience and knowledge with all the delegates here. The heartbeat continues. Just before the lunch break, we have a very short session of one speaker and few chairpersons. So I call upon the chairpersons, Dr. A.K. Shivprasad sir, Dr. Shyam Sundar Reddy sir and Ravi Shankar sir, all from Hyderabad, to come on to the stage. And the speaker will be none other than the guest of honor, the senior faculty, Dr. Sethi sir. So please give him a very big round of applause.
Thank you, chairpersons. Now let's shift gears and move from complex and complicated electrophysiology to some clinical decision making. As I was talking previously, that this is an art which is not very well practiced in most parts of the world today. Anyway, we're shifting to heart failure now. And we all know that in spite of the fact that large-scale randomized trials have shown great benefits of giving guideline-directed medical therapy to patients with heart failure, implementation is still poor because of several reasons. One of the most important problem that comes in the mind of treating physicians is the tolerability issues of the medicines, particularly patients with low blood pressure, low or high heart rates, impaired renal function, hyperkalemia, or presence of congestion. Then there are other usually talked about but important reasons like physician inertia, not trying to increase the dose, thinking that the patient is relatively stable and doesn't need any increase the dose, low socioeconomic status, poor medical adherence. Also, up to 50% of the patients with heart failure and reduced ejection fraction have CKD, which actually doubles the risk of death. There are many profiles which are not included in the randomized control trials, and we often see them like older patients, women, frail, and multi-morbid individuals. Now, in the standard guidelines that have been published and being followed for many years, there is a particular sequencing of drugs for treatment of heart failure. All these drugs that are shown in this slide have shown tremendous improvement in prognosis of patients. And when given together, they are known as foundational therapies for heart failure reduced ejection fraction. Now, this particular sequence desires that we start the medicines in a hierarchical manner, one after the other, and reach the maximum tolerated dose or the maximum guideline directed dose first before the next medicine is added. This is a tedious and a prolonged process, and a lot of us have given this up because it's not very practical for reasons that I will talk in a little while. But it delays addition of therapies one after the other. It has been based on the presumption that the therapies that were developed or tested earlier or first are the most effective, such as the ACE inhibitors or ARNIs. The complete guideline-directed target dose is required in most people to get the maximum benefit out of them. But these two facts are not necessarily true, as we'll be talking in the next few slides. Now, this is the data that shows that combination of treatments shows much more increase in the ejection fraction, much more improvement in the prognosis of patients than continuing to double or increase the dose of a single drug and then going to the next one. Most importantly, in all these randomized controlled trials, all patients were not on maximally targeted doses or maximally recommended doses of any of these drugs. In fact, majority of them were not on the maximally prescribed doses. Most of them were on sub-target doses of these drugs. Secondly, before increasing the dose, addition of another drug or more than one drug has much more beneficial effects than increasing the dose of a single medical therapy that we are continuing. And as you can see here, as we keep on adding these therapies, the prognosis keeps on becoming better. So as when we combine ARB with a beta blocker with a MRA and SGLT2, the hazard ratio drops to 0.36. However, when these trials were conducted, it is also important to note that all patients in whom a new drug was tested were not necessarily on all the background therapies that have been recommended here. In fact, many patients were not getting one or the other drug, particularly MRAs, for example. Not more than 50 or 75% of the patients in any trial were getting MRAs. Similarly, SGLT2s have come later. So many of these studies with ARNI have been done without the addition of the SGLT2s, and therefore it is always better to try to combine drugs as early as possible. We also know now that low dose of medicines also have significant beneficial effects as far as prognosis of these patients are concerned. For example, this is the data from ATLAS study which particularly looked at a low dose versus high dose lisinopril in patients with heart failure. And notice here that a low dose of about 5 milligrams per day was compared with a high dose of 32 to 35 milligrams per day. And see, the curves are absolutely superimposed in each other. And it is only later in the time course of this follow-up, which roughly extends to about 5 years, that there was a very, very modest further improvement in prognosis consisting of risk of death or hospitalization. Actually, there was no particular difference as far as mortality was concerned. So one has to be aware of this, that it doesn't mean that we become complacent and not increase the doses, because some of the modern medicines are far more effective than what we have seen in these older studies. The second thing is that the beneficial effects of many of these drugs come very early. This is the data from SOLVE trial that shows early effects of starting doses of enalapril, and this is the analysis of first 30 days after enalapril was started. The enalapril was started in a dose of 5 to 10 milligrams and was planned to be increased to 20 milligrams per day, which was the target dose on day 14. But notice that even before day 14, there is a marked reduction in heart failure hospitalization plus all-cause mortality, bringing the hazard ratio down to 0.65. And then when the therapy was up titrated to 20 milligrams per day, mind you, that was possible only in 48% of the patients. There was a further improvement, the hazard ratio going down to 0.49. Now, similarly, this data is on a Plarinone from FSS study. Just 25 milligrams per day started average of 7 days after a myocardial infarction with reduced ejection fraction produced not only a 31% reduction in all-cause mortality, but also a 37% reduction in the incidence of sudden cardiac death as early as 30 days after starting the treatment. Next is effects of carvedilol in severe chronic heart failure in the Copernicus study, and this data pertains to the first 8 weeks of treatment. In the entire group, you can notice that within the first 4 weeks of treatment, the curves start separating as far as all-cause mortality is concerned, and also a combination of death, hospitalization, or study drug withdrawal. And notice that there is a significant reduction in the event rates with hazard ratio of 0.75 as early as about 4 weeks after starting carvedilol. And in high-risk patients, which were defined as those with recurrent heart failure hospitalization or ejection fraction of less than 15%, this benefit was actually much more as early as 4 weeks after starting the carvedilol. And obviously at the 4 weeks, carvedilol will be in a relatively low dose, just going up to perhaps 6.25 or 12.5 milligrams 2 times a day. And notice the massive improvement that has come up. The next thing is which deters people from starting medical therapies in these is a low blood pressure of patients. And here is data of influence of pre-treatment systolic blood pressure on the effect of carvedilol. Here, this is the baseline data, and this is being divided into 5 categories. The lowest curve here is the people with pre-treatment systolic blood pressure between 85 to 95 millimeters of mercury, and then the higher levels of pressure, the maximum more than 125 milligrams of mercury systolic. And time to all-cause mortality obviously was maximum in those with the lowest blood pressure, and similarly, time to death or hospitalization was also the worst in patients with the lowest level of blood pressure, then comes between 95 and 105, and as we go up, the incidence rate becomes less. Now, what happens when we give them carvedilol? This is Copernicus data again in a separate publication that looked at the change in systolic blood pressure from baseline in patients with the lowest blood pressure range, that is 85 to 95 milligrams of mercury. And this is on the upper side is carvedilol and placebo, and see that actually speaking within about 6 months of starting therapy, there is a steady increase in the blood pressure in most of these patients by 8 to 10 millimeters of mercury, which does not happen in the placebo group. And this is data on all patients, the entire trial, where you can see that initially there is a drop because all levels of blood pressure were included in this, including the highest level of blood pressure, and then gradually the blood pressure recovers to the pre-treatment level in about 10 months' time. So patience is very important here. If the patient does not have symptomatic hypotension, we don't need to decrease or back away with the drugs. Also very importantly, see here that those in the 85 to 95 systolic pressure, at about 45% of them were able to tolerate the maximum recommended dose of carvedilol, which is 25 milligrams 2 times a day. And as the blood pressures became higher at the beginning of the study, more and more people obviously were able to tolerate the recommended highest doses. Also, is there a relationship between the effect of carvedilol on pre-treatment in different groups? And notice that all blood pressure groups had absolutely similar benefit from carvedilol, and there was no interaction of the effect of drug on in terms of the results, whether it was all-cause mortality or death or hospitalization. The hazard ratios are less than 1, consistent in all subgroups by systolic blood pressure, and there is no interaction at all, with p-value being non-significant. Now let us look at some case examples. Low blood pressure and high heart rate. Generally, one would consider less than 90 millimeters of mercury as a low blood pressure, and in coronary artery disease, one should remember that pressure slightly higher than this would be important, because low diastolic pressures can actually affect the perfusion of the coronary arteries. But when we find such a case, most important thing to do is to check for hypovolemia, any bleeding from anywhere, or evidence of infection in the body. Then importantly, remove all non-heart failure medications if possible. Stop nitrates because they have no prognostic benefit. Calcium blockers if possible. Check if the patient is euvolemic or not. If the patient is euvolemic, you can reduce the diuretic or completely eliminate the diuretic, and they most of the times do very well without a diuretic. Modify the guideline-directed medical therapy only if the patient has symptomatic hypotension. The best heart rate in people with heart failure and reduced ejection fraction is about 60 beats per minute to have the maximum effects. Up to 55 beats per minute is also acceptable, and therefore one should try to uptitrate beta blocker to maximally tolerated dose. If we have a patient who does not tolerate beta blockers, substitute by ivabradine. MRAs and SGLT2 inhibitors are generally well tolerated because they do not reduce blood pressures very significantly. One should avoid ARNI if starting blood pressure is less than 100, and test with an ARB first, which would be valsartan in this particular case. And by repeated dosing, often the blood pressure would resolve, and then one can withdraw the ARB and add the neprilysin inhibitor in addition to valsartan. Now, patients with atrial fibrillation form a very specific group in this kind of patients, particularly patients with atrial fibrillation. The optimal heart rate to be achieved in heart failure reduced ejection fraction has not been very well defined. So one tends to get the heart rate between 60 to 80 beats per minute, in contrast with sinus rhythm, where heart rate in atrial fibrillation is not a predictor of mortality. In sinus rhythm, it is very much a predictor of mortality. As I told you, the best results would be obtained when heart rate is around 60 beats per minute. There is no clear benefit, or there is no clear evidence of a prognostic benefit of beta blockers in atrial fibrillation with heart failure. Up-titrating beta blockers to heart rate of less than 70 may actually be detrimental in this situation, and one should never forget to anticoagulate these patients to reduce mortality because of stroke and systemic embolism. Now, in patients with atrial fibrillation and low blood pressure, beta blockers should be reduced or even discontinued if necessary. Substitute with digitalis and maintain heart rate of more than 70. One can up-titrate ACE inhibitors or ARNI, whatever the patient is getting. Continue with an MRA and an SGLT2 inhibitor, and again anticoagulate them. Optimization of medical therapy in patients with chronic kidney disease is extremely important and should be very well understood, because CKD is actually a stronger predictive of death than left ventricular ejection fraction is. Mostly, there is a misinterpretation of evaluation of eGFR in these patients. For example, there is an expected decrease in eGFR with diuretic, but if the patient is improving in terms of his heart failure status, then one should not too much worry about it, because it will recover in a few weeks in future. Similarly, a decrease in GFR is expected during up-titration of most GDMTs in chronic heart failure, and one has to carefully look at that. For example, a RAS inhibitor should not be withheld unless increase in the creatinine is more than 100%, or the potassium is increased to more than 5.5 milliequivalents per liter. One should reduce a RAS inhibitor dose if creatinine increases by about 50% above the baseline, but is still less than 3 with the eGFR of more than 25, and re-administration is advised, as heart failure patients have a lower mortality on these drugs despite a lower GFR. Now, most RCTs have actually excluded patients with severe CKD. All drugs can be used till a eGFR of 30 or even less in some situations. One should stop ACE inhibitor or ARNI only if creatinine increased by 100% or to more than 3.5 milligrams per deciliter, or if the eGFR is less than 20. Between eGFR of 15 to 30, SGLT2, and give me just 1 minute, I'm going to finish. SGLT2 and vericiguat are very much usable. Beta blockers are safe till eGFR of 30 with a clear benefit in mortality. Now lastly, one always wonders what happens with MRAs, and here is influence of baseline and worsening renal function on efficacy of spironolactone in patients with severe heart failure. The first thing is that those patients who have eGFR of less than 60 have much higher mortality as it is in the baseline than those who have an eGFR of more than 60, and this applies to both all-cause mortality as well as a combination of death or heart failure hospitalization. And absolute benefit of spironolactone was greatest in patients with reduced eGFR. As you can see here, that all-cause mortality or heart failure hospitalization in patients with reduced GFR was actually improved much more than patients with normal GFR in terms of absolute benefit by administration of spironolactone or any MRA for that matter. And lastly, up to a eGFR of 30, if potassium is less than 5 milliequivalent and if there is no relevant rise in creatinine, one should continue with MRAs, check serum potassium at 1 week and at 4 weeks after starting or increasing an MRA and periodically thereafter. Avoid non-steroidal anti-inflammatory drugs. K binders reduce the potassium in patients with RAS inhibitors but have no evidence of prognostic benefit. As far as SGLT2 is concerned, they are useful in CKD with heart failure, as we all already know. So in conclusion, ladies and gentlemen, a personalized approach for planning GDMT allows better and more comprehensive therapy. Magnitude of benefit of each drug class is independent of the other and much greater than up titration of an existing drug. Low doses of ACE inhibitors and beta blockers and plerixone reduce death or heart failure hospitalization very early. Neprilysin inhibition and SGLT2 inhibition reduce the risk of renal insufficiency and hyperkalemia with ARVs and with MRAs, and achieve all foundational therapies within 4 weeks and up titrate to maximally tolerated within 2 months, because larger is the number of drugs that we include in their treatment, more is the ultimate benefit. Thank you very much for your kind attention.
Thank you, sir. We are running out of time, actually. May I call upon Dr. Mohit?
Just one question.
Yeah. We will take the questions after this.
Do I go there?
Mohit Gupta? Okay. I think only one speaker. Right. So, Dr. Mohit Gupta, sir, is not available.
Good, then we can take questions now.
Yeah. Would you, sir, like to comment on the dose of, on the value of iron supplementation and flu vaccine?
Yeah, the question is iron supplementation and flu vaccine. Okay, now iron supplementation is an absolute yes in these patients. And every patient of heart failure with reduced ejection fraction must have his iron checked irrespective of the hemoglobin level. There are people who have hemoglobin of 13, 13.5, still have significant iron deficiency, and one has to replenish that. That is one. However, having said that, heart failure, iron therapy results in reduction of cardiovascular mortality and improvement in symptomatic status of the patients. Till now, we do not have data that shows that it reduces all-cause mortality. So that is a caveat, but there are a number of randomized controlled trials that are available with the various preparations of iron and have been found to improve prognosis. The second thing, of course, is the flu and the pneumonia vaccine cannot be underemphasized, and they must be done. But since our discussion was on guideline-directed medical therapy, and the time was relatively limited, I did not include them in the presentation.
One more question, sir.
What do you take on patients who have blood pressure of 90 by 40, 90 by 50, and a coronary perfusion pressure? Because they are concentrating only on symptomatic hypotension. But most of these patients have a very low diastolic pressure, and half of them have a coronary artery disease with intermediate lesion or a borderline lesions. What would be the coronary perfusion pressure? What would be the impact on myocardial ischemia when you drop your blood pressure to 90 by 40 or 90 by 50? Thank you, sir.
See, I gave you the perspective of people with 85 to 95. That is the same category that you are talking about. My first question to you is, what do you use for measurement of blood pressure? Do you use that automated cuff, or you actually use the mercury manometer?
Both.
Both. Now, when you see people with very low diastolic pressure with the automated cuff,
It's erroneous.
most of you must check it with a mercury manometer, because many times they give falsely low diastolic pressures in many elderly people I have seen. Secondly, if the patient has genuinely stiffened vessels and a low diastolic pressure, then there is a problem, because giving any drug, not to these patients can lower the pressure further, at least temporarily. And in patients with chronic coronary artery disease, one has to be particularly careful. First, don't go with neprilysin inhibitor and ARNI, because that is likely to reduce the blood pressure most. And in that situation, personally, I would like to add a combination of SGLT2 inhibition with a small dose of beta blocker to start with, allow the blood pressure to get better. The SGLT2 inhibitor has an inherent property of causing diuresis in the beginning, so that will reduce the chance of getting the patient into worsening heart failure situation. Studies have shown that it doesn't really matter whether you start AC inhibitor first, or it was CBS2 particularly looked at this with bisoprolol. The end results were absolutely similar. It didn't matter whether you start the AC inhibitor first or the beta blocker first. So I would go with beta blocker, combination of SGLT2 inhibitor. The next thing would be a small dose of an MRA. And once the patient stabilizes, the blood pressure starts coming up, which could take a few weeks to a few months. I would then come back and see if the diastolic pressure permits. We will like to add ARNI or ACE inhibitor or whatever. And in that situation, I would experiment with a valsartan first, without the neprilysin inhibition, because neprilysin is the major reason for causing the drop in the blood pressure in these patients. Otherwise, you may have to work without all the other drugs. It is not necessary that you have to use all these drugs. You can use a combination of beta blocker, SGLT2 inhibitor, and this MRA, and then add ivabradine if required, which will help both ways, because that has no significant effect on the blood pressure or hemodynamics.
Most of the RCT, they exclude the complex multimodalities patients. In our clinical scenario, we see these patients only.
Yes.
They are borderline BP, CKD, borderline high, potassium is 5.5. You have presented one slide actually. Once I start the ARNI and MRA, eGFR will come down, potassium will rise. What is your threshold to
Not
stop?
necessarily. Yeah, I'm coming to that. It's not necessary that potassium will rise. The eGFR and the potassium oftentimes go independent of each other, but they can go together. So one has to watch the potassium. My threshold to up to 5.5, I will not stop, certainly, because that is not very serious hyperkalemia. You can continue to watch the patient maybe every 15 days, make sure that he does not get any other drug which will increase potassium. Particularly the non-steroidal anti-inflammatory drugs, the patient should not get dehydrated. I would look at the diuretics, because people often dehydrate them and then they start getting worsening of their GFR. So that is very important. And then make sure that the dietary intake of potassium containing foods is taken care of, because when you start asking them, they think that this orange juice, gives a lot of strength to them. So many of them are taking coconut water or orange juice, bananas, all these things. And once you remove them, oftentimes the potassium settles down.
When to stop?
If it exceeds 5.5, you stop.
Most of the guidelines says that you stop after 6. You reduce the dose 5.5 to 6.
So it comes to the same thing,
okay,
that you reduce the dose.
Sir, any?
think the statement that you have to stop the drug has to be revised. There are a lot of trials showing that administration of potassium chelating agents should be done and the other drugs have to be continued. Because once you stop the drugs, the event rates are very high, hospitalization is also very high. There's one trial called Patyromers. It's called some trial where the Patyromer was used as a chelating agent and the events were much better in those patients who were taking Patyromer as compared to those people who stopped the drugs. So the current...
I have answered that question already in my slide.
No.
That you can use them, but an improvement in prognosis has not been shown with them. Of course, it makes the drug more usable. The guideline-directed drug more usable. So you can use potassium bounders and then continue with the drugs.
Yeah.
But if it goes to 6 and above, I will be a little hesitant to continue. The first thing to do is not necessarily to withdraw the drug. 5.5 or 5.6, you reduce the dose. And then look at the other things. Most of the time that will solve. One other issue with potassium, which is very, very important, is that you must repeat the sample. Because sampling is a very frequent error as far as potassium measurement is concerned. If the needle is thin and not positioned in the vein properly, it causes hemolysis while the sample is being drawn, or somebody pushes it with a great speed into the bottle which is going for the testing, you will get hyperkalemia. And we have seen that you repeat the sample in an emergency in the hospital, 1 hour later you get the report potassium is normal. So that should always be double checked, and that is a standard principle which everyone should follow.
In the era of the sodium zircon silicate, the role of stopping the drugs is probably limited now. We have been actually using that sodium zirconium silicate to overcome the possible hyperkalemia and then allow you to continue the drugs, especially the ARNI, if the hyperkalemia is the only problem that is preventing your usage.
That is too costly, sir. That is the only...
Sorry? No.
Cost is the cost is...
Zirconium is very expensive.
Very expensive, sir. But how long they have to take? I have given 1 month, 2 months. It's a socioeconomic status is low, then he is discontinuing that. Otherwise, that's a good drug. If any other questions?
The other possibility is use of finerenone, which is supposed to cause less hyperkalemia as compared to MRAs, but we do not have prognostic data in patients with heart failure reduced ejection fraction. We only have the prognostic data in those with mid-range ejection fraction and preserved ejection fraction with finerenone. However, if you are against the wall, it is always good to add something which is an MRA, and finerenone would be a good choice, 10 milligrams a day in this situation.
If no more questions, thank you, sir.
Sethi sir, I wanted to ask you if in Delhi, if you are still using the mercury sphygmomanometers, because I think it is now the people are telling we cannot use it, and because of the mercury hazards, even NABH when they come for inspection, they check if we are still using
Government has
mercury.
Because it's echoing there, so can you repeat it, please?
Okay. The mercury sphygmomanometers, are you still using
it's not
in
available,
Delhi?
Yes.
So they are slowly getting outdated.
That's a good question. Let me answer that. See, mercury sphygmomanometers were removed from clinical practice in 2004. That was because of environmental pollution. So officially they are not permitted. But it is always permitted to keep 1 or 2 instruments in the hospital locked, because when you have to calibrate your instruments, at that time it is required to put it against the mercury. Also, sometimes, as I said, that there are some clinical situations where you need to check it by 2 different methods to make sure that we are actually looking at the correct diastolic pressure. So, it is a problem. Most of us are using only the automatic instruments these days, but we have 1 or 2 instruments in the hospital which are kept under lock.
No, I think it has to be, statement has to be modified, because there's an improved version of the mercury. Instead of mercury, they are using LED lights, which corresponds to the non-mercury sphygmomanometer. You can use by same old Korotkov method. It is still an accepted method, not necessarily using mercury.
Okay, thank you.
We had the tips on management, on the importance of clinical decision making and how to manage heart failure cases from the horse's mouth, Dr. Sethi sir. We are grateful, and our gratitude to all the chairpersons, the anchors, the speakers for sacrificing their Sunday, their family time, their break, and coming here and contributing to continuing our clinical medical education program. So this was a feast for our brains. Now Sumter's meal feast is waiting for all of us. So let's break for a half-an-hour lunch break. We should be back by 2:30. So the faculty on to the left and the delegates on to the right. Thank you.
No, fundamentally, the concept is wrong. Stopping. Scientifically, it is not correct. You are not supposed to stop the drugs, and you are supposed to use a potassium-sparing drugs.
A very good afternoon and welcome back to another enriching post-lunch session by the high net worth intellectuals. So the next two sessions are all about irregular heartbeat or the atrial fibrillation and its treatment, AF ablation. After two presentations, we'll have a panel discussion to keep you all awake. So for this, I call upon the chairpersons onto the stage. Dr. Raja Selvaraj sir, Dr. Vivek Chaturvedi, Dr. Darshan Krishnappa sir from Bangalore. And the first speaker will be Dr. Narasimhan sir, who will be the panelist later for the panel discussion. And the second speaker will be Dr. Venkatakrishna sir. After that, we'll have a panel discussion. Look at our front.
Good afternoon, chairpersons, ladies and gentlemen. I was tasked to speak about the status of atrial fibrillation in 2026. As they get the slides loaded, I'd just like to recapitulate an analogy. If you had taken about 25, 30 years ago, the rich actors, ministers who have had triple vessel disease, they used to fly to US for bypass surgery. Because very few centers were doing it, the outcome was uncertain, and therefore there used to be a very selective referral process. Whereas as the technology evolved, it has become safer, predictable, and the long-term results are pretty good. That's what has happened in atrial fibrillation. We all knew that AFib is bad, but there is an evolution of technology which has made it the treatment simpler and the understanding of disease has improved over years. This is from Framingham, Emilia Benjamin and others have looked at data. Several of them repeatedly have shown that the onset of atrial fibrillation over the next 3 years, there is significant increase in stroke, heart failure, dementia and death in several of these patients. So about 2 decades ago, the primary modality of therapy for atrial fibrillation was either control the rate by giving AV nodal blocking agents like beta blocker or calcium antagonist, or give a more atrial specific therapy like flecainide or amiodarone to restore sinus rhythm. And I'm not going into this. There is a little confusion in the way the data was analyzed. But if you actually look at the number of people who maintained sinus rhythm throughout the study, they had a survival advantage of about 40% reduction in mortality when sinus rhythm was restored. This was not possible despite using several drugs, and mainly most of the antiarrhythmic drugs that we used, either class 3 drugs or class 1 drugs, while they achieved sinus rhythm in the atrium, they increased the proarrhythmia in the ventricle, and therefore the risk of sudden death significantly increased. And we learned that continued use of anticoagulant is important. Now, how soon should we do this? Should we wait for 6 months, 8 months, 1 year in atrial fibrillation? This is what the German trialists looked at, whether within the first 3 or 4 months of atrial fibrillation, whether we should achieve early rhythm control versus a little more lenient rate control over a period of time, and over a long period of 8 years follow-up, patients who have achieved rhythm control had a significant reduction in cardiovascular endpoints. This was more so among patients with heart failure. So let's understand why there is a problem. As a common, this is a very common condition. So when you have a patient presenting with atrial, this is a 72-year-old lady, we presented with atrial fibrillation, symptomatic, was on metoprolol and amiodarone, was on apixaban, and she presented with increasing symptoms for the last 1 week. palpitation followed by chest heaviness. Dose of beta blocker was increased and she was sent back home. And 2 days later, she presents with this. So how a drug interacts, at what level the AV block will happen or sinus arrest happens, none of us know. In our anxiety to restore sinus rhythm, when we increase the drugs, at a particular therapeutic level of a drug, sinus rhythm is restored, but the dosage of the drug that restores sinus rhythm is poisoned the AV node and the sinus node. There will be such a long pause in some of these patients, they develop significant bradyarrhythmia. Second is a patient, again, patient with coronary disease, presents with atrial fibrillation and heart failure, and then started on IV amiodarone, and soon after a torsades comes in. Amiodarone-induced torsades does occur, especially in patients with sick hearts and heart failure. Similarly, a patient with proximal atrial fibrillation couldn't be continued on amiodarone, therefore switched to flecainide because of hyperthyroidism, presents with flecainide-induced proarrhythmia. So repeatedly, time and again, we see this not in immediate follow-up, but when the patient goes back home 3 months later, 4 months later, when the patient develops a respiratory illness, patient develops a mild fall in GFR, that is when these problems are more likely to show up. One thing we have understood, thanks to the group from Adelaide, is an aggressive control of risk factors, physical fitness, exercise, weight loss, treatment of obstructive sleep apnea, strict alcohol abstinence are very, very important. There's almost a dose-response relationship. With increasing number of drinks that a person consumes, there is increasing risk factor of atrial fibrillation. Now, what happens when you don't treat atrial fibrillation is, several of these patients who continue to have atrial fibrillation in paroxysms of a few months apart can develop persistent atrial fibrillation in a cohort of patients. Now, persistent atrial fibrillation has a higher risk of mortality compared to patients with paroxysmal atrial fibrillation. So earlier intervention to treat paroxysmal atrial fibrillation prevents progression of disease to persistent atrial fibrillation. I am not saying it's ablation. If the patient has mitral valve disease, address the mitral valve disease. If this should lower your threshold for sending a patient for mitral valve surgery. If a patient has a moderately severe mitral regurgitation, onset of atrial fibrillation, your threshold for considering surgery should be lower. And if the patient doesn't have any reversible factors, compared to pharmacological therapy, if you have a non-pharmacological therapy, the progression to persistent atrial fibrillation comes down over a period of time. Now, there is a little confusion about literature why there is no mortality benefit in atrial fibrillation. A patient with atrial fibrillation is generally elderly, has got mild CKD, has multiple comorbidities. So if you want to show a reduction in mortality, it should be predominantly due to cardiovascular causes, heart failure, ischemic stroke, and it does not address several of the non-cardiovascular comorbid illnesses these patients have. This is the reason why we need to understand that AF has AF-related mortality, and therefore that can significantly come down when you restore sinus rhythm. On the other hand, AF-associated mortality is very often obesity, HFpEF, fall in GFR. These are comorbid conditions. 1 in 4 patients with atrial fibrillation, the mortality is due to malignancy. So if a person with atrial fibrillation comes to you with weight loss and thyroid is normal, you should screen for malignancy, especially if the hemoglobin is low. So this is again, from PLOS 1, this was looked at how did a person with atrial fibrillation, suppose index atrial fibrillation in 2015, 4 years later you look at all the deaths. What is the cause of deaths? About 40% of the deaths, what you see in blue, is related to cardiovascular mortality. This is the one that you would address by restoring sinus rhythm. Almost 25 to 30% of the mortality is related to malignancy, and a significant percentage of them have respiratory illness compounded due to long-term use of amiodarone. Please remember, amiodarone-induced toxicity is not very well brought out by PFT unless you do diffusion capacity DLCO in these patients. So for years, as EPs, we have been struggling with this AFib ablation of isolating pulmonary veins electrically. There are problems with with the evolution of technology, this has become simpler. Instead of doing a point-by-point ablation, it has become simpler to isolate the pulmonary veins with one-shot devices like either a cryoballoon, and with cryoballoon it's highly effective. The AFib terminates as you are ablating. Even in persistent atrial fibrillation, sinus rhythm comes down. Just to illustrate the interaction of heart failure and atrial fibrillation, this is a patient, is a physician who came from Pune, has a ICD 70-year-old person, recurrent hospitalization for heart failure, gets admitted with severe heart failure, rise in creatinine, one episode of heart failure here, and then gets into ICU, almost requiring a ventilation. Each of these admission of heart failure was due to atrial fibrillation. He was class 2 otherwise. And here is when AFib ablation is done, and then you can see that this is the burden of atrial fibrillation. 100% of the time he was in atrial fibrillation. This was about 50-60% of the day he was in atrial fibrillation. Here is where it becomes persistent. So this is what I use in practice. One isolated atrial fibrillation, if a person has, I tend to pause and see if there anything reversible in this person. Is it obesity? Is it sleep apnea? Is there something I'm missing? One of the common things is chronic PPI use and a low magnesium in these patients. So that is a well-known cause, and PPIs are used like water in our country, and that's one of the things, especially if a person is on a concomitant diuretic, you will have this problem. The other technology that has made it further simpler is this thing called as a PFA, where high voltage electricity is given for few milliseconds between two electrodes, and they isolate the pulmonary veins much faster. And they do it by disrupting the cellular membrane permeability. All of us know we have a hydrophobic pore, and when they give a high voltage electricity, pore formation happens within the cell wall, and the water seeps in, and the cell undergoes apoptosis. The importance of this is when you give a very brief high voltage current, it does not heat the tissue. So the thermal damage is what causes thrombosis, thermal damage is what causes collateral damage to the esophagus, and so on and so forth. They are all completely avoided, and that is the importance of using this technology, and they are highly effective in isolating the pulmonary veins. And if a person has sources other than pulmonary veins, you need to consider touch-up with RF in these patients. This is the reason why, more than anything, for years as physicians we knew that AFib in a subset of patients, especially with heart failure, is a very bad disease and worsens heart failure, but we didn't have very efficient tools. With the evolution of technology, it has become much more predictable and safer, but it doesn't mitigate, or it doesn't take away the role of a physician of controlling the risk factors. I would again like to emphasize this. If you have a patient with atrial fibrillation who continues to be obese, whose respiratory tidal volumes are low, and he is having diabetes uncontrolled, he is going to come back with atrial fibrillation, but from coronary sinus, from SVC, from right atrium. Other areas may start firing. You may isolate the pulmonary veins, but the job is not over. It's like coronary disease. You need to consider lifestyle management in these patients. Obstructive sleep apnea, whatever you have, you need to do that. And as of now, in 2026, if you have patients with paroxysmal atrial fibrillation, I tried drug therapy and control of risk factors for a while. If the patient develops severe nocturnal bradycardia, and someone was last discussion, Dr. Sethi was pointing out very well about hyperkalemia. When you have a heart failure patient and he has bifascicular block or prolonged PR interval, in the night he is developing episodes of 2-to-1 or 3-to-1 Wenckebach. Those are patients, they don't tolerate hyperkalemia. I'll have a very low threshold for aggressively treating the hyperkalemia. You don't need to use zirconium. Good old K-bind K-xylate is good enough. Because it has a longer half-life, use it 2 days a week, that is good enough. So persistent atrial fibrillation and heart failure, please remember, for AFib to cause heart failure, it is generally not paroxysmal. It has to be persistent. Rates are not important. Rates may be well controlled, but it's the irregular cycle length which causes heart failure. So even if the rate is well controlled and the patient has persistent atrial fibrillation for a while, I strongly suggest you at least cardiovert this patient and reassess. If the patient's heart failure is improving, patient's indices are becoming better, then you may consider ablation. For persistent atrial fibrillation, there may be other sources other than pulmonary veins for considering. So always have a backup for touch-up with RFA. My colleague Dr. Daljit is looking at this. Several of patients who are referred for PFA, they have additional sources in the coronary sinus. They have non-coronary atrial tachycardia. So if you don't do a complete job, you're likely to have greater recurrences. And never, because in our population, we looked at it almost 20 years ago as a part of Realize AF study, compared to Western population where valvular atrial fibrillation is about 15%. In India, especially among indigenous population, the percentage of valvular AF continues to be as high as 40%. So if you have a person with mitral valvular disease who is going for surgery or hypertrophic cardiomyopathy, please make sure that the surgeon takes out the appendage properly and does mini maze, at least isolate the pulmonary veins and comes out, and we can touch up the right side if required later on. And a lot of our success is because of understanding of the disease as a physician. Who are the patients at high risk? Where does it decompensate? Where is the greatest benefit for this procedure? And technology has come in to rescue, to salvage several of these patients with safer, predictable energies for isolating the pulmonary veins. Thank you very much for the patient listening. We have questions at the end.
Shall we have the questions at the end? Excellent summarizing of the evidence, sir. I had a question for you. This comes from the Kerala AF registry. It was a peculiar registry in the sense that, at the end of 1 year, while strokes were like, okay, just like in Western countries, the cardiovascular mortality was shockingly almost 10 times. I think if I'm not wrong, it was something like 12 to 13% in 1 year. So what do you think is really happening here? Is it just a marker of more vascular diseases, or is it really causing so much of...
I'm glad you brought this. In fact, this is not seen only with Kerala AF. Asia Pacific Heart Rhythm Society data again suggests Asians have a higher impact with atrial fibrillation, and their mortality goes up much more compared to Western population. Mainly because it's something similar to our sarcopenic obesity that we see in diabetes, and our BMI threshold comes down to 25. So atrial fibrillation in a person who is thin and lean suggests a more severe form of atrial disease and cardiovascular disease. We need to be a lot more aggressive, and Kerala AF again is concurrent with several of the Asian registries that you have seen. Yes. Can you pass on the mic to Dr. Sudhakar, please? Think we can hear you by the time they set it up. Yeah, go ahead. You can talk. Yes, in fact, there is a trial which looks at it. There are two trials, large trials I am aware of. One is among patients. I'm glad you asked this question. There's a guy called Bando who's done about 800 patients undergoing mitral valve surgery. I'll take this first. This was published almost 10 years ago in Thoracic Surgical Journal. All of them underwent LA appendage excision as a part of mitral valve surgery. And then 8-year follow-up, they followed up for mainly strokes. What predicted the freedom from stroke is not LA appendage ligation, but maintenance of sinus rhythm. So that's a very important thing from surgical data. Second is, the Laos registry, which looked at in circulation, it was published. Among non-valvular atrial fibrillation, surgical occlusion or excision of the appendage does reduce both atrial fibrillation as well as reduce the risk of stroke. But I think the risk benefit is you need to consider it's not a benign procedure. Instead of offering for all comers, I would say if a person had a prior AFib and is going for bypass surgery, we would consider doing that. If de novo, when patient doesn't have anything, whether we can offer, I'm not sure. Because whatever, for a surgeon, it's simple. But all of them carry a finite risk. I'll be a little cautious about it.
Sir, I have two questions. Sir. One thing is, I think as EPs, we tend to evaluate ventricular arrhythmias better or more seriously. In atria, if there is a tachyarrhythmia, either you put drugs or you ablate. Do not look for inflammation, scarring and all these things. And much more with this cryo and PFA, you're less likely to map the scars and other things. So do you think that we are missing a lot of the substrates which we do in ventricular arrhythmias?
Very correct. In fact, we have looked at about young patients below 45 years, unexplained atrial fibrillation with elevated HSCRP. So they don't have risk factors. They are not diabetic, hypertensives. They come with atrial fibrillation and CRP is elevated. We evaluated about 60 patients or so. 15 out of these 60 patients, about 25% of them have granulomatous myocarditis, affecting the atrium, isolated atrial myocarditis. In fact, there is a series from Mayo which looked at patients on autopsy, reported a series of 15 patients. They present as unexplained atrial standstill in young or atrial arrhythmia. And more often their representation was giant cell myocarditis selectively affecting the atria. Whether there is a rheumatic carditis isolated in the atrium, the JP study which he looked at in, there is an ongoing inflammation in the atrium, even among patients who go for mitral valve surgery. So that is an unexplored answer. Main problem to study this is you need a grant. We are looking at some of the cytokine markers. IL-17 seems to predict that it's going up in autoimmune myocarditis compared to the rest.
Second thing is like heart failure. You have guideline directed medical management before you consider devices. Now, do you do like that? Suppose you correct sleep apnea first before considering AF ablation. You wait for months. You know, obesity, sleep apnea are not going to vanish in a few days or few weeks. Do you wait for them, all these reversible things for years, you bring them back? Is that the way you do?
So the thing is, generally we take about 2 to 3 months to evaluate and give them a therapy. There is a greater push for aggressive weight reduction, diet restriction, exercise, and in patients who cannot tolerate a little bit of GLP-1. We do everything possible, and despite that, there is a problem, especially if the BNP is persistently elevated. And if you find E by E prime is going up, these are the thresholds where the patient has far gone into the disease. I have a lower threshold for considering an ablation. You do a minimal post-exercise E by E prime, it shoots up to 16, 18. Patient is symptomatic or exercise-induced MR. MR becomes more severe with atrial fibrillation. Those are patients I have a lower threshold. So we are currently looking at it. So just like left bundle branch block, by increasing the left ventricular dilatation, increases ventricular arrhythmia. When there's a delayed activation of the left ventricle dilates, ventricular arrhythmia increases, left ventricular mechanical function comes down. Same thing happens in the atria. When there is a delayed left atrial contraction, there is a significant elevated in LA pressure, AFib increases. In fact, Fontan patients, some of them, you pace from Bachman bundle, the LA pressure dramatically comes down by 15 to 20 millimeter. So for patients with interatrial block, that is when the P wave is very wide already, more than 120 millisecond, if you pace from the right atrium, you worsen. Right atrium is the worst site for an atrial lead placement. We have been placing it because that's more convenient. But when you start pacing the atrium, for sensing it's all right. But when you think the patient is going to require atrial pacing, when you pace from the right atrium, On an average, the follow-up data indicates 40% of them develop atrial fibrillation in the next 2 years. Whereas when you pace from Bachman bundle, the incidence comes to less than 8%.
Thank you, Dr. Narasimhan.
Thank you.
I think we'll move to the next talk. So Dr. Venkat is going to speak on PFA for atrial fibrillation.
Good afternoon, ladies and gentlemen. Chairman, thank you. Thank you, Hygriv and Arrhythmia 360 organizers for inviting me to share my thoughts on pulse field ablation for atrial fibrillation. Is it a game changer? So these are my disclosures. So we just heard from Dr. Narasimhan about the why AF management turned from rate to rhythm control to some extent. I just stress upon that. There is a little bit of background before we consider why PFA or any other type of sources of atrial fibrillation management in the form of rhythm management is taking upper hand. Positives and negatives of the thermal ablation, and then why pulse field ablation is gaining interest, and what do we understand about PFA. I put in 3 question marks, we'll talk about it. So you heard this, I didn't want to really belabor talking much about it. We know that early intervention seems to be a good way, as opposed to what we were kind of brooding about the RACE and AFFIRM trial for several years, and it was also very difficult to convince anybody that we can actually do better by doing a rhythm management. So this slide is kind of put in a concoction of everything put together, why rhythm is management is important. So as we know that delayed after depolarization is one of the methods that, mechanisms that actually starts the pulmonary vein triggers to be active. And this is a vicious circle, the heart failure particularly with the reduced ejection fraction, as also the heart failure with preserved ejection fraction. This is a very nice article from Barry Borlaug, which looks at normal left atrial function. You can see the, the pressure volume loops and the filling pattern. As the myopathy sets in, it just moves towards the right and top, and then when atrial fibrillation comes on, it gets worse. So this tells you a lot about the atrial fibrillation and heart failure relationship, which is a very important aspect of it. And this is one of the reasons why the guidelines say there is a frame shift as far as when you want to really intervene for atrial fibrillation management. So it moved towards more towards the 1 category, particularly in heart failure, and a 2A for the patients who have preserved ejection fraction. As you can see here, 7 out of 9 trials of heart failure trials with persistent atrial fibrillation and heart failure favored rhythm management among these group of patients. So when it comes to rhythm management, what is a better method to do a rhythm management? Is it drug? Now drugs come up with various levels of problems. One is the type of drug you want to choose based on the patient's morbidity, and also the tolerance, and also the side effects. So and also the efficacy of the drug itself is concerned. So all these things are always been a challenge. So hence we move towards the RF ablation, where the RF ablation seems to be a little bit of a problem with respect to certain aspects of it. So the PFA is it really a game changer? The mechanism is different. We heard from Narasimhan as well. This is nothing but delivery of high voltage pulses, and in the form of micro currently, and the nano is coming in the future. The voltage ranges anywhere between 500 to 10,000 volts per centimeters, and it can be synchronous, depends on which system you use, with the heart and the QRS versus non-asynchronous, and bipolar versus monopolar. There are different forms of waveforms which is titratable, and based on that different mechanisms what you actually pick, the catheters what you actually pick, they have different patterns, and then hence they have different advantages and disadvantages, overlap, underlap, decay, and the different forms of the pulses. So at the end of the day, it causes irreversible electroporation. So when it does the irreversible electroporation, you create, as you can see in this particular picture, anatomical picture, this is a control as opposed to PFA. The structure is maintained. That is one of the key things to think about. The structure doesn't alter much like the way that you see with radio frequency. then there is a very clear demarcation, if you look at the Cox staining, that when you actually deliver PFA, so you know that there is a hard stop as far as how the lesion actually tends to happen. With that, so you can have a more predictable type of lesion, depending upon how you actually deliver and what footprint you have, the catheters wise, and also the structure being maintained. So why PFA emerged? One thing is we need to see some alternatives with respect to abating the problem of the collateral damage. We know that radiofrequency or the cryoballoon, in other words, the thermal ablation, has got limitation with respect to the collateral damage in the form of esophageal thermal injury. Although we have somewhat conquered by actually creating ourselves some method to actually eliminate the incidence itself is relatively low, mainly because we monitor them heavily, and sometimes esophageal cooling devices came on, so on and so forth. But we are not completely immune from the problem. Phrenic nerve injury is a potential problem, and the pulmonary vein stenosis depends on how you do the ablation. And the efficacy overall is plateaued. It hasn't really gotten any better over a period of time. On the other hand, the electroporation is non-thermal, although in a biological sense there is 1 to 2 degrees temperature rise in that area, depends on what type of configuration you use, but it's not harmful, in other words. Then tissue selective thresholds are very interesting aspects, although we know that pulse field ablation is a very old type of energy source used in oncology and various other urological fields. It came to cardiology quite late in a way, but still it has, because of the tissue specificity, it seems to be have predilections for the myocytes as opposed to the collateral tissues. And the other aspects is the shorter procedure time. That's actually equally important. As you mentioned, when Dr. Narasimhan talked about the heart failure part, where the heart failure patients tend to get most benefit. If you wanted to put them in a procedure for a long period of time using an RF or some other form of energy source, it could also be a detriment or difficulty. You may, procedure-related issues, you may have to deal with them as well. So the 1 year PFA outcomes on the 3 trials which were done, as you can see in this particular picture, which shows one of the things which doesn't affect is the vasculature around or the nerves, in other words, the esophagus. So it has got a very specific aspect of it. Based on that, the safety of this trial showed the esophageal damage was 0%, dysmotility, fistula, all the things around what we were actually struggling with in the form of complications with RF or the thermal energy has been completely negated. The efficacy-wise is comparable with RF. So far, the efficacy is similar. So there are many reasons why that could be the reason. But one thing is we have a very short history of PFA overall, as opposed to RF has a long history. So many things have developed over a period of time, and the lesions that we create, we don't have a feedback yet at this point of time very well. Then also, we are still understanding what the PFA is. So that is one of the reason, could be the reason why we are still struggling with that aspect. Now the other system, the Medtronic has the Affera system, Spear9. The trials showed very similar benefits. The PVI durability per patient is in the close to 90% range in the acute situation, and over a period of time, the 1 year, the outcomes are fairly similar to what the radiofrequency energy applications were. And the other aspect, once again, it's a very fast procedure when you are actually doing it. The balloon in basket concept Volt PFA system emerged, and it was presented as late breakers, and the trial showed acute effectiveness more than 99% of first pass isolation in the range of mid-90s to upper 90s, and at the end of the day the outcomes were fairly similar to the RF type of ablation. But the interesting aspect being, because the energy that is delivered is more towards the pulmonary veins, and the blood pool is less affected, less likely to cause other collateral damage. We'll talk a little bit about that aspect as well. So the other system which is currently under trials being investigated is the GLOBE system. This is both mapping and as well as ablation in the single platform, and you can actually selectively deliver energy based on which poles you want to select. In that way, it seems to be helpful. So our own experience, I can tell you in the last year and a half, 2 years, the number of patients you can do ablation is obviously increases dramatically. That's one thing, mainly because of the fact that the patient, you can do the procedures quite fast. That's one good reason. The second reason being you actually have a lower threshold to take a sicker patient, mainly because you are only subjecting the patient for a shorter procedural time. Our case mix overall is a much more of a PVI plus. I will tell you why. Because our patient population are fairly complex, sicker, older patients. That makes it a little bit harder that way. But the skin-to-skin time reduces quite significantly over a period of time. And there's a little bit of a learning curve, but as you know, and over a period of time, it consistently goes down, both PVI and PVI plus. So this is just a fast video of this procedure done on a patient with persistent atrial fibrillation with significant amount of scarring seen, and the ease of which the navigating the catheter and also delivering the energy of each application is a 2.5 second and 8 applications per vein. And then you have an isolation of the pulmonary vein. Acutely, you can see the electrogram disappearing. You can actually put the catheter further into the vein to assess, or you could also remap it. I tend to remap all these patients in general. That may be another reason it takes a little bit longer time. This is the wearables example. So that what we have seen in certain group of patients are there is a connection still there, mainly because of the fact that it has got some limitations how much it can penetrate. It's up to 5 millimeter based on what has been shown in the energy source for this particular catheter that has been developed. So sometimes you may have to use RF, depends on some certain areas like a ridge area, for instance, between the pulmonary veins and the appendage. This is a large center. We were also part of the study of the Manifest US registry, and over 40,000 patients were analyzed. And the study design consisted of 102 centers which basically participated, 41,968 patients. And then most of these patients, 56% were male, and most of them were 68 years old, and the first time ablation was about 73%, and 27 was reduced. Paroxysmal was 54, and 37 was the persistent category. The acute pulmonary vein isolation was found in was 92%, and the number of patients who underwent posterior wall left atrial ablation was 57%, and some people also underwent the KO tricuspid isthmus and the mitral isthmus with the same catheter system that was used. And the important thing is what you can see is the risk involved. The overall major adverse events were 0.63%, very low, and the minor were mostly because of vascular access and something like that. The mortality was low, 0.04%, and no patients had any problems what we encountered with collateral damage using RF ablation. So overall, non-inferior to thermal, but durable. That's a question which actually came up when these trials were initially addressed. Advent trial was initially done for a year duration. There was very comparable between the thermal, which is in the gray, and the red is in the PFA. The LTO registry, which came a little 4-year follow-up, which the PFA was slightly superior compared to the thermal group, and the single shot with the cryoablation was clearly seemed to be a little bit superior with the PFA group in the Champion trial. The meta-analysis showed overall relative risk reduction was 0.67, so indicative that there is a trend towards the PFA being slightly superior compared to the thermal energy. The PFA success rates in persistent atrial fibrillation in the initial phases of the trial to current situation has changed. In the manifest PF registry is 71.5%, and the Athena is also is very high, is getting better. Are we understanding it better? Are we able to manage with looking at these catheters better? Probably to some extent. Also addressing the specific triggers, those are the aspects I think always still in the management of atrial fibrillation also matters, apart from the other what we understand with Narasimhan address regarding general management of the patient is concerned. So PFA beyond pulmonary veins in persistent atrial fibrillation, does it cause stiff LA syndrome? This is a question which was addressed, Panoni, who actually visited us not too long ago, they looked at this particular data presented, showed they didn't see a whole lot of worsening of the LA stiffness. The reservoir and the conduit part of the LA with the strain imaging seems to be fairly good. But having said that, while I was in the airport, I just saw an article just came out in Heart Rhythm showing that they have some changes they have seen. The reservoir maintained, but the conduit was actually affected in single center study, which was shown. So still we have to really learn a little bit more about the pulmonary PFA. There was a question whether or not it interferes the devices. There was a paper, actually case report more on the Biotronic device, showed it actually cooked up the device with the ICD lead close by. But and the Prash Sanders actually showed that you can see some interference, especially in the acutely, but that overall they followed 3 months after, they didn't see any abnormality in the device because of the PFA application. Overall, the complication risks, the pericardial effusion, the PFA is represented, in the blue and the RF in the red, the orange. So slightly lower, and mainly because of the mechanical catheter issue. The vagal responses, hemolysis, and the coronary event are all a little bit on the higher side when it comes to the PFA. In part, I have had a patient with almost 54 seconds of asystole, and I had to pace him because of the extreme vagal response during left superior vein ablation, and also the ischemic stroke seems to be is a little bit of questionable based on this this particular paper. Remember, this is I forgot to tell you, this was from the MOD database, which has actually reported. So there's likely possibility there is a lot of underreporting. So that is one thing we need to keep that in mind as well. And overall, phrenic nerve damage is low, and the pulmonary vein stenosis is not reported. The other mechanical problems with the device was one of the things which has been reported in the MOD database. The Nemesis PFA trial, among all the trials so far we have had, was specifically addressed, and we were also part of it, to look for troponin rise in the hemolysis aspect of it. And clearly that was one of the things we can actually see the difference. Troponins for some reason is astronomically high among these patients who, when you do. Is it because of the amount of atrium that is being ablated, because of the footprint that you have with the catheters, or is it because it has got a diffuse activity and the microvascular spasm is unclear? So those are all the things I think still needs to be addressed. So the delayed, this is a very important paper which actually came out from Melanie from Germany, and she put together multi-center, 7 centers, and looked at 11 patients as a delayed 0 to 2 minutes all the way to 22 days effect. This includes the ST elevation, spasm, then the ventricular fibrillation, as well as 3 patients dying because of this reason. So we had a patient, sorry, I'll take another 30 seconds. We had a patient with right inferior pulmonary vein, while I doing the PFA, started to develop ST segment elevation, and became EMD. And then there is a suspicion that the other reasons why these patients can have issues is probably atrialization of the coronary arteries. That could also be one of the reasons they may be potentially affected as well. So the other aspects you probably heard from recently, specifically targeting certain aspects of atrial fibrillation in the form of looking at the trigger zones, which is coming back. The old cafe has been refined because we have more high density maps and a better way of actually analyzing these data. We looked at the ripple frequency maps and assessing those areas and targeting them specifically. Could also be, we can use the same technology of the PFA to address those issues. And we used the vector maps in some of these. There is a trial currently going on. We are part of the trial looking at addressing these patients who have had a reduce, or it could be a persistent atrial fibrillation. It actually creates a hot spot, and those areas, if you target specifically, seem to, you can actually potentially improve the outcomes. So in addition to the improvement in the safety aspect, you can also potentially improve the outcomes as well. We already know about the the CONVERGE trial, which actually addresses the epicardial ablation as well as the endocardial ablation. So one thing some people actually have described, it is not in the published literature, ablation of the endocardium with a PFA, epicardium, there's still connection. That's a question which needs to be answered because of the energy source what we currently have. Maybe I think the outcomes in this CONVERGE trial being always better, there must be a reason I think we may not be transmural as well. This is similar thing which showed with the AF trial with a better outcomes. So more than just the non-inferior so far is a relative risk based on the Advent AF, and there's a PFA sham trial which is just published in Circulation, showed clear evidence of a benefit with PFA, and the Champion trial showed a benefit over cryoablation. So is it a game changer? In one aspect of it, yes, I would say, mainly because one thing is short duration wise, and high-risk patients, you can do them much more easier. And collateral damage is an issue which is was always been a struggle. We don't need to. We stopped monitoring esophagus, stopped monitoring pharynx nerve. It seems to be one important thing. We still need to be very careful about aspects like hemolysis. It's not trivial. If gun is available, you could possibly fire a lot. At the end of the day, you may actually affect those things and still don't know about what is going to happen to the LA function. We need to keep that in mind. And as far as the tamponade and other routine aspects of it are potential still may occur. There is some question about the stroke data. The subclinical stroke seems to be on the higher side. That needs to be sorted out over a period of time. Thank you so much for your attention. Excellent, Dr. Venkat. Dr. Sethi, you wanted to ask?
Observation for some concern with PFA has been very large increases in troponins. The values 2,000, 3,000 are seen, and atrium is not such a thick muscle bundle, muscle mass as the left ventricle is. But yet the actual release of troponin is, I mean, this is one of the highest levels that I have heard. Even in large infarctions, you don't see levels up to that. So I don't know what is the long term, from where is it coming, first thing, because the lesions are very small and it's just around the, mouth of the pulmonary vein or ostium of the pulmonary vein. So from where is such a large, is there a damage at distance because of something, because troponin cannot get released from anywhere else except cardiac myocytes. So there is only one source.
Yeah, very good question. This is a question we are debating. One thing is, there are two aspects to it. One thing is the ease of using this PFA actually has a lot of operators they're going crazy about ablating everywhere. They see somewhere fractionation go ablate without rhyme or reason. Pulmonary veins, posterior wall, right atrial, everywhere. That's one aspect of it. The second aspect is, which we're not sure, is whether or not, as you said, it can cause coronary vasospasm, the bigger vessels, but can it also cause microvascular spasm, which we don't know that.
It may even do that. I think there must be some studies it needs to be seen. Some people believe this is the part of the reversible part of the electroporation, and that's not going to be anything, but there is no proof of it.
That is humble,
So,
I think.
yeah. So
That is
this is a
humble.
clear issue that I think we are still not sure.
But we need to have a look at the atria with MRI. We also need to have a look at ventricles with MRI.
Absolutely.
Because, we don't know what is causing it, and the circumflex artery spasm is not so common. I mean, there is a debate on that. Some people say it is very, very rare, maybe 2, 3, 4%. Microvascular spasm has been shown. But spasm alone generally is not sufficient to raise troponin to that kind of level. I mean, if there is some myocardial damage with it, but you give nitroglycerin in the coronary, it disappears most of the time.
No, the other aspect is if the microvascular spasm exists longer period of time, we don't know. That's another thing, because if there is a late spasm happening, like 22 days after, it be concerning, whether or not this is
correct. I think next day. I mean, you do the troponin, you find
right.
5,000.
No, I'm saying
4,000.
if the spasm can happen for a long time, we don't know how long the microvascular spasm can stay.
Venkat, simple questions. In your center, at what point in the natural history AF you take up for ablation? Second thing is, what are your endpoints of PFA ablation?
Oh, good question. So our threshold is, we are already referral center to some extent. I think most of these patients come to us, they're needing some form of therapy. The threshold for taking patients for atrial fibrillation ablation in heart failure is very low. Okay, partly because they tried everything possible and the patient has got atrial fibrillation. I think our threshold is low. As far as the first timers, we'll try a medical therapy as an option. Even if it takes an antiarrhythmic drug therapy, then if they need to be the case, then we actually do the same thing as like a shared decision-making process. At some point, discuss with the patient to say which way they want to go. We have had some patients with, especially I deal with a little bit older patients, their tolerance with medications issues. Those are the type of patients we tend to change. Other question you asked?
Endpoints of
the endpoints, yeah. No, the endpoints for the PFA, one thing is I want to make sure there's a pulmonary vein isolation. That's the first step. And some patients, I tend to do voltage map on everybody, okay? And also if there is a fractionation map, I'll tend to do that. Yeah, I started to do a lot of vector maps, and partly because I'm also part of the research study. So look at the hot spots, look at those specific triggers that I need to target them. After it is done, I re-verify by remapping them. So that's why it takes a little longer time compared to a lot of patients. In Europe, they don't remap necessarily. That's why they can do many patients. Sometimes some people don't even do the mapping. So it is based on the echo and other reasons they contact. But I think mapping made me think, it actually humbled me to some extent, saying that there is whatever we did as an ablation was not actually effective. So we had to go back and do something about it, whether it's an RF or it could be a redo on the PFA. At some point, you have to draw a line, how many RF PF ablations you want to really deliver. As Dr. Sethi was saying, is it worth challenging having so much troponin? That is the thing you need to really stop. One thing of note, this is completely out of topic. We are doing a lot of VT as well. The Farah point is, although small footprint, every time I've seen it, you do an ablation, it stunts the ventricle. You can see the EF goes down a little bit. You need to keep that in mind. LA, nobody knows about it, nobody pays attention, but ventricle is very important.
Yeah, so with so much renewed vigor about AF ablation, Dr. Hygriv had thought of doing this panel discussion. So I've thought of a few questions and I'll start firing them.
Hey,
but Professor Dayasagar will
panelists are still not there.
One of the mechanisms proposed for these elevated troponins has been the stunning of the LV myocardium that causes some LV dysfunction transiently and also causes release of troponin. It is one of the postulated mechanisms because the amount of muscle in the atrium is not that much to release. So it is been proposed as one of the mechanisms that it may be a myocardial stunning of the LV that transiently causes LV dysfunction and also release of troponin. Your comments on that?
No, I think I agree with you. There must be something. We still need to get some data, some form of imaging studies or the PET study, PET perfusion, so in order to understand this.
Relevant what was said. I think all of you would have seen after a DC shock for a patient for VT or AFib, you go back and check the echo, there'll be a transient stunning, ST elevation stunning. It's something like that that happens. So when you want... Yes, so I'm coming to that. So there are two ways that you can deliver PF. One way is between an electrode and a patch. That is, it's a unipolar fashion. The field at which it is spreading, it encompasses a large amount of myocardium. Whereas if you can restrict it between two bipoles, that is two closely spaced electrodes, you restrict the field to a very small area. That is one way of limiting it so that it doesn't go in unipolar fashion and cause collateral damage.
No, that's a good point.
Is it damage at distance?
Yes, damage at a distance will happen if you're putting a patch somewhere and delivering. So instead of that, just deliver between two electrodes alone. Around the ostia, you don't want anything collateral.
The FARA is very localized, similar to that, but the FARA is a much bigger footprint, just to give an idea.
Sure. So I'll start firing the questions. Maybe I'll ask Dr. Venkat the first one. With so much excitement about it, yeah. Sure.
Okay.
Oh, I am supposed to sit there? Oh. So with so much excitement, first question goes to Dr. Venkat. Who should not undergo AF ablation in the current era? Are there any patients where you think it's unnecessary risk, less likely to succeed, or you would try in everybody?
Very good question. I think one thing is the usual reason why we don't do an AF ablation, like a left atrium is super dilated, and the patient is relatively asymptomatic, even if the heart failure is present, and for the fact that the patients, the elderly, and where we don't see that the heart failure hospitalization is clinically not relevant. I mean, the threshold to do, if you see an atrial fibrillation, to put them in sinus rhythm in heart failure population is also there, a lot of in the community. Those are the kind of patients I would say.
Is there an upper age cutoff that you would think, okay, beyond that we are going to leave it alone?
That's
in your practice.
In our practice, it's not there. I would still think about it. Okay, and if there is a reason that I have to stop, I think I would probably stop. The oldest I've done is 88, I think, something like that.
Yeah. Dr. Narasimhan, who in India is the ideal candidate for AF ablation today? Should we catch it early in the disease or wait for multi-antiarrhythmics to fail? And which patient do you think is going to get the maximum benefit?
It's a very important question because it is a very useful therapy, but first of all, more antiarrhythmic to fail, broadly you need to investigate the cause of atrial fibrillation. That has been ignored. We were talking about it. Elderly person with risk factors, diabetes, hypertension, coronary disease is one subset. When CHAD 0 is there and the patient comes with atrial fibrillation, we now have a cohort of patients where it is an indication of a sarcomeric mutation. Sarcomeric mutations can present as atrial arrhythmias. So the whole thing depends on when the patient is in atrial fibrillation, whether the BNP goes up, whether there is some degree of D-dimer elevation. There are all indicators that the patient is not tolerating the atrial fibrillation well, both clinically, biochemically, by imaging. And if you are not able to restore sinus rhythm and maintain sinus rhythm, in spite of controlling the risk factors, not antiarrhythmic therapy, I'm talking about risk factors, then we would consider AF fibrillation.
I have one more thing I want to
Yes.
update. Darshan and I, we published together a paper a while ago. We have looked at autopsies data actually. About 4% of the patients have isolated atrial amyloidosis. So they have 48% higher incidence of atrial fibrillation. But if you ablate, the success rates are obviously, those kind of patients would be low. These are autopsy data. But anyway, it gives an idea to think about these things do exist. And what you mentioned earlier about the atrial inflammatory atrial myopathy, or some form of myopathies, maybe with so-called atrial fibrillation on top of it. It seems to be that if you go and do an ablation, the success rates are very low.
Just to add on to that, after that in Bangalore we did a clinical study of this. So we took all patients who are coming with atrial fibrillation, echo not showing anything suggestive of amyloid. So we screened them with the technician pyrophosphate imaging. This is back around 3-4 years back. Out of 120 patients, we saw around 22 of them had actually uptake with a scope beyond 1.5, which is significant uptake. And we saw that rhythm control with medications in them was much poorer compared to those without. So I think that's another factor, like Narasimhan sir mentioned. Myocarditis is an important thing we're missing out. Some amount of sarcomeric mutation. These are all things which we look for in patients with VT heart failure. But atrial arrhythmias, I think it's lagged behind.
But amyloid of 20%, that is a large number. Were these elderly patients?
Yeah.
80 plus, something like that?
Not 80 plus. The cutoff we used was everyone above 65. In fact, this we presented at the APHRS Young Investigator session.
So one of the clue for what Darshan is saying is, whenever you see a patient with atrial fibrillation, in sinus rhythm, his P wave is small but wide. So the height of the P wave is small but it's wide. That is indicative of, that's one of the signs of atrial amyloid. They have a higher intraatrial block. They don't generate enough voltages in the atrium. They have an increased intraatrial delay. So in these patients, generally don't go for AFib ablation. Even if you're going to go for a pacemaker, you should be prepared to have one atrial area, you may have a high threshold. You may have to search the atrium at different areas, and they have a higher tendency to develop atrial fibrillation in future also on follow-up.
So Dr. Chaturvedi, you have experience from India and abroad both, and what do you think, your insights, despite strong guideline recommendations and AF ablation being around for 25 plus years, why is it still not mainstream in India? Is there cost issue, delayed referrals, finance, or misconception about the procedure, or you yourself are not convinced?
So I think it's pretty much all of these things really. Finance is definitely a very big issue. So of all the people whom I recommend atrial fibrillation ablation, probably 10 to 15% only go through. Rest of them just deny affordability for the same. But I think the amount of AF we have in urban areas, at least now, the referral part is also very important. On an average, a general cardiologist or a physician does not put so much importance on AF as it should have been done. So to some extent, I think we are also responsible for not spreading the word enough that it's an important arrhythmia.
Let me ask a corollary. Look at the TAVI numbers. It was introduced like 3-4 years ago, and nobody seems to refuse a TAVI. It's going to cost anything from between 10 to 25 lakhs. Actually, and here we are talking about AF ablation, could be whatever, 3-5 lakhs.
I think it's a matter of poor convincing power of the EPs. You know?
So are you convinced enough to convince the patient, or you're not convinced enough to convince the patient?
Yeah, I mean, the thing is that, to be very frank, the moment you tell someone is 70% success rate for a single procedure, most of them would get put off. They would not, I'm sure no IC ever says that there is a 70% success rate for a TAVR, or there's going to be a 10% risk of a heart block. So.
And also, I think we've not stressed too much on the harmful effects of AF. I think we've had data more recently with heart failure, with Castle AF, Castle HTX, Cabana heart failure, and all of it. So I think that is going to encourage us more to adopt therapy and sinus rhythm, despite a failure rate of 20-30%.
Yeah. So I need to get this from Dr. Narasimhan. Are Indian patients with AF genuinely less symptomatic? Or are symptoms underrecognized, or they are underreported? Do our patients tolerate things better than those abroad?
See, that broadly applies to most Indian patients, whether coronary disease or heart failure, because most patients, for example, an average European plays enough in tennis. 70-year-old person is spending more time in the tennis or golf course or hiking and trekking, whereas it's very uncommon to see a 70-year-old person, Indian, doing 12,000 steps or climbing 4 flights of stairs, which is very common. I think we underreport symptoms because we don't exert ourselves too much. And that's why it's, as a physician, you go by other biomarker. Patient says, I'm all right. You do a biomarker and you see the BNP is 400, 500 and steadily going up. The atrium is dilating. He's developing an early onset of pulmonary hypertension. These are all indicative that the patient is not tolerating it well, at least inside, but he's not exerting and therefore he's not symptomatic.
Is it the
other thing is
Indian philosophical way of looking about aging?
No,
is it the
other
right thing
thing
to do,
is,
or do you want people to play tennis at 70, 80 years of age?
No, you go to the ICU, when a patient develops atrial fibrillation, one of the classic thing is their arterial pressure will come down, their jugular venous pressure will go up. So if you look at these patients, the cerebral perfusion pressure comes down. So when you ask a person in ICU which patient needs a cardioversion, with the onset of atrial fibrillation, go and click the button and see how the hemodynamics is. You see suddenly the arterial pressure comes down, but the venous pressure goes up. These are patients who will have silent white matter lesions, gliosis on their MRI. And there's clear evidence that dementia, cognitive decline worsens with atrial fibrillation. 24/7, if the cerebral perfusion is low, it's going to be abnormal. When you simply cardiovert them, do a re-imaging of the brain, the cerebral perfusion is better. Similarly, the same thing applies to your GFR. So all microcirculatory organs, end organs will have a lower perfusion in atrial fibrillation.
See, Dr. Darshan, you do a lot of AF ablations at your center. You used to do at Jayadeva. I'm going to ask the same question to you and to Dr. Venkat. How effective is AF ablation in real world practice? Not the ideal way of doing it in the best centers, in the trial places. Are expectations of cure realistic? And how do you counsel the patients regarding success, etc.?
Yeah, so frankly speaking, I think it starts off with how you select patients. You cannot take every patient and say, okay, no matter what happens, I'm going to ablate. LA and RA remodeling that's already happened, you need to factor that in. Frankly, real world, I just use a plaques. I assess what the LA diameter on plaques is. Anything beyond 5.2 centimeters, I'm going to say we've lost the battle. Patients with heart failure, you'd want to do an AV node ablation and then either a CRTP or a left bundle pacing. But otherwise, just continue with rate control. Well-selected patients, I think, at least what I've seen so far with my data, it's around anywhere between 70 to 75%. Is what we see in terms of preservation of sinus rhythm. And most of these patients, I take off antiarrhythmics after 3 months, exception being patients with HCM, in whom I do continue some amount of antiarrhythmics over time. But most of, again, I'm sure all of my panelists also will agree, that most of the AFs we ablate are patients with persistent AFs. There's very few paroxysmal AFs that are even referred to us. Most of them are physicians, or they say, okay, episode finished and I'm doing well, so why do I need a procedure? So that's something we need to factor in.
And Dr. Venkat, same question, and also I'd like to ask about this 30 minutes skin-to-skin PFA procedure versus what you described. That sounded more like 3 hours.
Yeah. Well,
so first, the question which I asked.
Yeah. So the question what Darshan actually answered is the outcomes overall is based on how much you want to spend time. That's what I always feel. That answers both questions in one way. So if you want to really spend without really looking too much, you can be 30 minutes. But if you want to really spend and get to the crux of the problem, you will spend time. There is no way, there is no other compromise. That's my feeling. The only thing what you have, the difference in the PFA that is done is each application is shortened. So you overall shorten the procedure time, but still you need to address all the mechanisms that you need to do. What we actually presented one of the data in AHA some time ago. Our outcomes are fairly good actually, even in the persistent categories up to 80-85%, based on if you address all the aspects. We were doing extensively vein of Marshall ablation, look at the Marshall plan, what Hasegar described, and everything into consideration. So if you do all those things, I think outcome seems to be better. How much is left atrial function is preserved, I'm not sure. One thing I always advise is not to touch the anterior wall completely, because I see anterior wall is probably the most important part of the compliance and as well as the contractility part of the atrium, because the Bachman is also a straight conducting zone in that location. Even if the posterior wall, posterior inferior location, it seems like at least in the persistent category, there is a lot of areas of, the fractionation seems to be the case, in at least in our cohort, what we have seen. So if you address all those things, that answers these both questions. Overall, I think you could improve the outcomes compared to what the real world even is suggesting, saying there is no difference between the RF and the PFA by addressing all the other mechanisms as well.
Has anybody studied the stiff LA syndrome in detail? I have read
limited. Well, the RF, there is
studies.
more data in it. The PFA, there is this is the second paper I just saw this morning. It just came out from the heart, in the heart rhythm.
Dr. Narasimhan, is AF ablation cost effective in the Indian healthcare settings? What do you think?
I think as of now, it's still quite expensive because the hardware is not produced in India. You look at the same drugs, because Indian pharma is manufacturing these drugs inside. Suppose we were supposed to import all the antiplatelets and statins, the cost of medical therapy would be humongous. The same thing is going to, the cost is very high because these equipment are all imported. If the catheters are made in India, it's going to become very cost effective. It is cost effective even now for selected patients, especially if they are coming to repeated hospitalization, ventilation, those kind of patients. Please, this one thing, if a patient deteriorates with atrial fibrillation and he goes into shock and heart failure, hemodynamic support doesn't work. You need to restore sinus rhythm, or at least ablate the AV node as an emergency and put in a device. Putting an ECMO and other things will only worsen the situation.
So this is an important point. Both Dr. Darshan and you spoke regarding AV node ablation and pacemaker or CRT. We don't hear much about it nowadays in the US. So what is this philosophy? Why is it different?
Yeah, actually I gave a talk in ECAS on the same concept. I think there is a bigger push. My own personal experience in the last 20 plus years, I've done maybe 3 times AV node ablation, and in partly because you spend a lot of time spending on the AF part. Yeah, there are few sets of patients where your options are limited, and particularly sick patients, very sick patients where they cannot tolerate procedures. They seem to do fairly, reasonable when you do an AV node, especially in the presence of a conduction system pacing. Then previously you have to think about CRT. CRT carries another thing. You have another problem whether or not you get a good synchronization. That was always the question. Now I think there is a little bit more option, large CRT or whatever you want to do. There is a better option to do that way so that you can actually have much more RR variability adjustment that you can do. Speaking of that one, you mentioned it. We published a paper a while ago, rate-controlled atrial fibrillation patients, why this heart failure worsen. That was all RR variability. We actually saw that one as well.
I think also largely, coming back to your question, it's also the referral times. In the US, you don't have considerable delays from diagnosis of AF to referral. In India, you get the referral only when patient has recurrent heart failures. By then, the atria is really remodeled. So I think that's why you hear more of AV node ablation and pacemakers here compared to.
So Dr. Venkat, after which redo number would you consider AV node ablation? After the 3rd redo, 4th redo?
Yeah, it depends on what I'm really ablating. For instance, first the 2 times if the patient comes for AFib, 3rd time comes back with atrial fibrillation alone, again, then I may be thinking about AV node ablation. If the patient comes back with atypical flutter, I will actually go, most of these patients post-AFib tachycardias, If you can chase them, I'll try to chase them. There are some patients with the LA, if I know by history, that's why I map them. If there is extensive scarring, I wouldn't go and do an ablation again. Yeah.
I think let me rephrase this slightly, this question of AV nodal ablation versus AFib ablation. When you restore sinus rhythm and relook at the patient's atrial contractile function, look at the E and A wave. If there is significant contribution of the atrial contractile function, I wouldn't go for AV nodal ablation and accept AFib as a long-term thing. If the atrial, despite restoring sinus rhythm, the atrial contractile function is very poor, in these patients, I am willing to just ablate the AV node and give them a pacemaker.
Would the atrial function take a few weeks to return?
Usually about 3
by then
weeks.
the patient may have a relapse into AF.
No,
is there
that's
a real
abscess.
way of really measuring
Not immediately, of course. You need to look at the old echoes. How was it just 2 weeks prior, 3 weeks previous? All the records are available. You put everything into the equation and see what is relevant for that patient.
So one thing I've seen practically with this thing is that a lot of these patients with huge LAs who have undergone AV node ablation, somehow over the period of 6-7 months, because the hemodynamic changes, actually you can cardiovert them back again into sinus rhythm. So,
in fact, we have written to challenging this thing of putting a single chamber pacemaker. 50% of the patients with very dilated LA in rheumatic atrial fibrillation, if you just maintain a constant RR interval by pacing, they revert to sinus and the atrial function comes back after 6 months.
I'm coming to a philosophical question. When we are practicing in India, we think each new technology is going to be the final answer to this. Whether it was RF or whether it was cryo coming in, making things simple, or making PFA now, which will probably solve all problems. But in the West, people think of it differently. They see it as an evolving science. With each new technology, they're learning something new. So are we in the wrong of, like our cardiac surgeon used to say, in India, you are born once, you are married once, you undergo cardiac surgery once. So, yes. So, but in US or in the West, it is considered okay. It's a part of process, and each time the patient will benefit a little more. What do you think about it? Am I summarizing that in the right way in the US? What is the feeling? How do patients get ready for a 4th or 5th procedure there?
I still feel that Indian clinical medicine is far superior. The overall, not that American system is good or bad, but the reimbursement system, the way it is RVUs or whatever, Venkat can highlight those things. They kind of dictate the way medicine is practiced. So I think the good mix will be to kind of have a hybrid of both for better outcomes. And it should be a good balance of clinical medicine and understanding the natural history of the disease and tailoring the technology to the needs of the patient.
There is no compromise in clinical care of a patient. I mean, thinking a patient as a holistic approach, what needs to be done. There's no question here. There is an intense pressure in a private setup particularly, and luckily I'm fortunate enough not to be like that, is the productivity. And that's why ambulatory surgical centers have been opened everywhere, and they do 8 to 10 AFib ablations a day. Partly because of the fact that they can do it, and if they can do it, they can generate, in other words. The question of generation. As far as adoption of newer technologies constantly, there is, it's like a new toy coming in, and there is an option that it gets approved in the society, and the society can afford it. There is a lot more to it. I think that's probably one of the reasons I think US is more open that way to newer technology as it comes.
Do you see patient hesitation, or they're open to it?
They're, if you discuss with them and show them, they actually also look at all they read up and come and talk to us about what's about the new thing, They're more open to looking into these new things as well.
Yeah. Dr. Vivek, if you could recommend one change that would improve AF management in India over next 5 years, what would it be? Early diagnosis, early referral, better education,
I think
more EP centers, improve reimbursement, all those problems out. You're not allowed to click all of the above. Pick up one, and I'm going to ask the same question to everybody else.
I think proper education of the healthcare provider is the most important thing.
Darshan, what do you think?
I agree, sir. Better education, because a lot of times we recommend an ablation. The second opinion is not from another EP, but it's from a cardiologist or a physician who said nothing is needed. So more education, more awareness about the pros and cons of sinus rhythm or rhythm restoration.
Dr. Hygriv, you have questions to the panel? We have 2 minutes more.
I had a question for Sir and Dr. Venkat. A lot of times you find that in persistent AF, and because we do more of persistent AF in India, if you keep them on a small bit of a drug after ablation, the success rates are actually more than 50-60 described in literature. So what is your opinion about that?
Typically my practice is I put them on antiarrhythmic drug for at least 3 months following. The blanking period in PFA is shortened to 2 months as opposed to 3 with RF. And I tend to still keep in the next follow-up visit, and they'll reassess the patient whether I can stop this medication. Sometimes I may taper even down to 100 milligrams amiodarone depends on how bad the persistent atrial fibrillation looks like. The goal or the intent of doing is eventually to eliminate the drug if I can. If it is not possible, sometimes they have to take the combination of both.
Last question from Dr. Hygriv, and then we'll close it. Thank you very much.
I'm going to reiterate one of the questions which Ajay Naik had asked about the patient perceptions. See, apart from 2 subsets, in my practice, the last so many years, PV tachycardia and AF with heart failure, these are the patients who perceive their problems are really a problem, and they comply with the AF ablation advice very easily. This apart, if you see a regular run-of-the-mill paroxysmal AFs with normal LV function, they have, say, 2 or 3 episodes or even less per year. They are okay with propafenone or even without amiodarone, propafenone, beta blockers. They are not very, and their symptoms they perceive as not very intense. So it is this subset of the patients, and as physicians we are so used to in India SVT ablations, rapid symptoms, one shot, complete cure, and we take all the credit from the patients. So both these things actually impair AF ablation, in my opinion. What he was actually asking the question. This is, in summary, this is the run-of-the-mill AF practice that we see, and that's the same thing with our cardiologists who refer. They are also perceived in the same way. He comes once in 6 months, he has one episode, they'll never refer because they don't perceive the need for this one. What do you think about these kind of?
So, I think this perception, underreporting of symptoms is very, very common here. And a lot of my patients, once they realize the cause, they suddenly start feeling better. Their symptoms disappear, and they say we'll manage fine with the drugs. So,
no, sir, I agree with you. I think we should look at AF like coronary artery disease. They don't put in a stent and then say, okay, off all medications. We've gotten used to it because we either implant a device or we do an SVT ablation and you stop medication. The goal of AF management is not an ablation, it's not a medication. It is restoration and preservation of sinus rhythm.
Thank you. We'll stop at that point of time. Thank you, panelists. Everybody is looking at me. Thank you.
Time is always short for concluding any panel discussions. There are so many questions, so much of curiosity, and it's very rare to get such stalwart experts under one platform, under one roof, on one platform. Please give a big round of applause, especially to Dr. Venkatramana Krishnan, who has flown all the way from Minneapolis, Minnesota, US, and from across the globe. And we are thankful for his time and his efforts to come down here and share his knowledge and experience with all of us. And due to paucity of time, we need to move ahead, and the discussion again continues on atrial fibrillation as to how to estimate the risk of stroke by AF episodes, effects of long-term oral anticoagulants, and no symposium is complete without we touching on AI, artificial intelligence. So it is the topic of the era or day. So we have Dr. Kumaraswamy from Bangalore who will be talking on AI. I welcome all the CPs to adore the stage. So the chairpersons for this session will be Dr. Sudhakar sir, Dr. Pramod Kumar, Dr. Dayasagar sir. I invite all the CPs onto the stage. We have Dr. Padmanabhan sir from our own hospital, Secunderabad, as the anchor. Anchor is supposed to sit on the front row, on the chair in the front row. Anchor will be here. So we are having 4 speakers in this session. I call upon Dr. Ajay Naik sir, who will be the first speaker, followed by Dr. Sauman, Dr. Kumar, and Dr. Kumaraswamy as the last speaker of this session. Thank you.
So the question Dr. Hygriv had posed to me was, 60-year-old lady diabetic with dual chamber pacemaker during a routine device check was found to have episodes of AF. She denies any symptoms of palpitations, pre-syncope, syncope. How to estimate risk of stroke by AF episodes? So this is what is called device detected or subclinical AF. And we need to identify it, we need to distinguish it from clinical AF. There are several trials about this. Let's talk about the AF burden, stroke risk, and what should we practically do clinically. So what is subclinical AF? First, what is clinical AF? Clinical AF is diagnosed by a 12-lead ECG or an ECG rhythm strip of at least 30 seconds. And subclinical AF are atrial high rate episodes detected by implanted devices with an atrial lead like a pacemaker, CRT, ICD, or nowadays a lot of people have smart watches or other wearables, and AF is detected on that. Usually these are asymptomatic short-lasting episodes, and there is no ECG documented AF like this. So previously we never talked about it, never gained attention because ECGs were recorded in health units and then AF would be picked up. But only because of these wearables and now these prevalent devices that we are talking about subclinical AF. So if you interrogate the device pacemaker ICD, you may pick up these atrial high rate episodes as are picked up from the atrial lead. At the same time, if you do an ECG and it shows AF, then it becomes documented AF. If there is no AF on ECG, then we call it subclinical AF. So then we go down this line. So about 10 to 30% of all patients with implanted devices may have these atrial high rate episodes, and it could very well include, apart from atrial fibrillation, atrial tachycardia, atrial flutter, generally increases with age. It often precedes clinical AF, so it's not totally innocuous. There may be some atrial cardiomyopathy, maybe some inflammation, fibrosis. AF burden, we have all heard, is both a marker and a mediator of stroke. Now this is what we need to understand. In neuro, we hear about cryptogenic stroke or embolic stroke of undetermined sources. The threshold for detection of AHRE are different in different devices. So in some devices it's picked up better, in some others it is not. Use of these devices is all pervading and increasing now. So subclinical AF we all need to understand. In cryptogenic stroke, we do not have a perfect definitive culpable diagnosis, but at least some of these strokes may be related to cardiac thromboembolism in presence of subclinical AF. So that is why this topic becomes important, because we need to take the decision of whether to anticoagulate these patients or not. So when we talk about device detected AF or subclinical AF, it seems to convey a lower risk of thromboembolism. The word subclinical AF makes you think it's of lower risk than a clinical AF, which is documented by a ECG. But whether it's symptomatic or asymptomatic, AF is likely to be, like I said, a mediator or marker for stroke. But initiating anticoagulation on the basis of subclinical AF, atrial high rate episode, is a substantial responsibility because of risk of bleeding associated with the anticoagulation. So subclinical AF can progress to clinical AF. The incidence is around, progression is around 10% per year. And if the CHADS-VASc score is higher, obviously the stroke risk is higher. Apart from CHADS-VASc score, if there's a previous stroke or previous embolism, if the AF burden or duration, what we are going to talk about, the LA volume, which we talked about in the panel discussion, the atrial disease, or if there is renal dysfunction or associated coronary artery disease, all these risks become higher. If the implanted devices has an atrial lead, it is likely to pick up true atrial fibrillation in this atrial high rate episodes. If a patient has an implantable loop recorder, again it may pick up, but there may be issues of noise, etc. Wearables like smartwatches, etc., they use photoplethysmography and they may not be as accurate and they are not prescribed by a medical professional. They are commonly used by common people. Compared to clinical AF, the subclinical AF is a much, much bigger number and likely to be more. What we need to do with subclinical AF, depending on different trials, it has been classified on whether the episodes last more than 5 or 6 minutes, because that is the way the device picks it up in aliquots of 5 minutes or 6 minutes, or more than 24 hours. What is the cumulative daily burden? And if there is a temporal relationship with stroke. So from implanted devices, you get intracardiac electrograms and they are likely to represent true AF. Short episodes, less than 6 minute duration, were shown to confer no significantly increased thromboembolic risk in 5,000 patients in the rate registry. So short episodes of AF may not necessarily show that there is a higher risk for stroke. The other study was ASSERT trial, 2,500 patients with pacemakers, CID patients without prior AF, atrial high rate episodes more than 6 minutes associated with stroke or systemic embolism, almost 2.5 times high, but there's no clear temporal relationship. Risk is lower than clinical AF, but obviously this is not trivial. And CHADS-VASc score, if it is higher for a given patient, the risk becomes higher. Other trial was TREND. If AF burden more than 5.5 hours per day, increased thromboembolism risk, and larger the duration, larger the burden, the risk would increase. So the gradient increase risk with increased burden. From wearables, the first studies were the Apple Heart study, the Apple Watch, and Huawei Heart study. This was from China. Wherever the device picked up AF, these patients were given monitors to detect their AF, detect their ECG, and almost 1/3 of the patients, AF was confirmed in these patients. We've all heard of the major trials for AF, the NOAC trials. For subclinical AF, it's Loop, NOAFNet, and Arrhythmia are the major trials. So these are the 3 major studies, and there's a meta-analysis of that which gives us some information about this. So this is to deal with our patient who has a dual chamber pacemaker and atrial high rate episodes were picked up. This was a Denmark study. 6,000 volunteers, elderly patients, people were given an implantable loop recorder, and 1:3, either ILR or usual care. CHADS-VASc score was 4 in both groups. AF lasting more than 6 minutes was picked up in 30% of the patient, but this did not lead to a significant difference in the incidence of stroke or systemic embolism in the ILR group. So this was people, not patients. The NOAA-AFNET study, here patients with subclinical AF more than 6 minutes were given either edoxaban, NOAC, or placebo, and it was found that again the cardiovascular death, stroke, systemic embolism was not significantly different between the 2 groups. Safety endpoint of death of any cause or major bleeding occurred more commonly in the edoxaban group. So what we intuitively think that patient has atrial high rate episodes AF, you give anticoagulation, things should be better. may not necessarily be better because here the patient is getting more bleeding. The Arrhythmia trial, again, apixaban compared to aspirin in subclinical AF between 6 minutes to 24 hours. Again, it was found that stroke or systemic embolism occurred in 0.8% of patients per year in the apixaban group, a little less than 1.2% per year in the aspirin group, but at the cost of increased major bleeding in the apixaban group compared to aspirin. So meta-analysis of this NOAA, AFNET and Arrhythmia was done 6,500 patients. It was found in both with the edoxaban and apixaban, reduction of thromboembolic events, but at the cost of increased hemorrhagic events. So here we come back to this picture. If the AF burden increases, from here it's from 5 minutes to approximately 23 hours, the likelihood of progression increases as the duration of these AF episodes increase. So AF begets AF. And stroke rate, as the CHA2DS2-VASc score increases and AF burden increases, the stroke risk also increases. So it goes to around 2% from around 0.3%. So higher the CHA2DS2-VASc score, higher the AF burden, likelihood of the patient getting stroke is higher. So this is the same thing. Patient risk, CHA2DS2-VASc score going up, and this is the AF burden. As both are becoming worse, the chances of having stroke becomes higher, and anticoagulation is probably related, probably indicated in this group of patients. Here in this, probably the bleeding risk of anticoagulation is more than what benefit you are providing by giving these drugs. So clinical implications of these 3 trials and the meta-analysis: routine oral anticoagulation for short SCAF is not supported. Risk benefit has to be individualized. You have to look at the CHA2DS2-VASc score and the AF burden. And the main point nowadays, shared decision making becomes important. So both ESC and ACC have given guidelines. ESC 2024 guidance, SCAF more than 24 hours duration, OAC becomes class 2B. Okay, so it is moderate recommendation. Shorter episodes, no routine anticoagulation. Emphasis on AF burden and risk profile. ACC is more conservative. OAC reasonable in high risk patients with longer episode. Shared decision comes into the picture. So just comparing the two, ESC versus ACC, ESC, if the SCAF episodes are more than 24 hours, CHA2DS2-VASc score 2 or more, class 2A recommendation for oral anticoagulation may be reasonable. The level of recommendation is B. We don't have too many randomized trials. And look at other problems, enlarged LA, atrial cardiomyopathy, etc., where it becomes more compelling to give anticoagulation. For ACC AHA, device-detected AF more than 24 hours, class 2A recommendation, again level of B, non-randomized trial, shared decision making. For shorter duration, ESC class 2B becomes level B. For ACC, again class 2B, level B. It is benefit is uncertain in both. ESC slightly more permissive for episodes more than 24 hours. Both discourage oral anticoagulation for very short episodes. Both emphasize the bleeding risk. So how do we apply it clinically? We look at higher AF burden compared to in these incidentally detected subclinical AF episodes, longer SCAF episodes likely to convey a higher thromboembolism risk. You need to discuss about anticoagulation with patients in whom SCAF has been detected, and be always attentive about possible bleeding effects of anticoagulation. No prospective data on smartwatch or smartphone ECG-based AF diagnosis. All that has been recommended is on the basis of implanted devices where you have atrial EGMs recorded and you have documented AF. Because photoplethysmography has lower accuracy readings, we need to have better ways of recording AF. You need to exclude artifacts such as noise, double counting, especially in the devices. If the CHA2DS2-VASc score is particularly high, 4 or more, probably you would lean towards anticoagulation. and if the previous patient has a previous cryptogenic stroke, embolic stroke of unknown origin, you would probably lean towards anticoagulation. As EPs, we need to look at the electrogram review. That is essential because there may be double counting in the devices. And if the AF burden is increasing, probably you are more compelled to use anticoagulation. Special scenarios, like I said, post-stroke patient, cryptogenic stroke, these patients probably would lean towards anticoagulation. Future direction, artificial intelligence is coming in everywhere, so probably it will be useful here also. For this lady, look at the episodes, look at the CHA2DS2-VASc score, and then decide accordingly whether you need to anticoagulate this patient or not. The thromboembolic risk associated with SCAF is around 1% per year. So if you are giving anticoagulation, if the perceived risk is more than 2 to 3% per year, probably you will get away with anticoagulation. But at 1%, probably it may not be such a great idea. If there is enlarged LA, if renal failure, previous stroke, these patients would probably, you would lean towards anticoagulation. So SCAF is common, prognostically relevant, stroke risk exists, but is lower than clinical AF. Anticoagulation decisions must be individualized. It has to be a shared decision. Guidelines between ESC and ACC differ slightly, but they are more aligned conceptually. Thank you. I'll stop at this point of time.
How reliable is the AHRE detected by CIEDs?
Yeah, so if you have an atrial lead in position, pacemakers, CRTs, ICDs, it is pretty reliable, but you need to make sure a person who is experienced in this electrophysiologist is looking at the atrial electrograms before deciding, not let the programmer tell you that there have been atrial high rate episodes. Because often there could be double counting or there could be other artifacts, so you need to rule that out. So that is essential because if you are going to take a decision about anticoagulation, like in coronary artery disease, once you've written aspirin, nobody would dare take it off. Same way things happen with anticoagulation. If once you've prescribed anticoagulation, it's a big decision taking it off also.
What will be the discrepancy between the machine given AHRE and the physician?
Yeah, so the physician, EP person is able to look at the electrograms and decide whether this is true documented, true AF or not. Sometimes if there is atrial flutter or PACs, or there may be lead artifacts, lead noise, that also is picked up as atrial high rate episodes by the device. That needs to be ruled out.
Likely percentage. The discrepancy between the physician drug, electrophysiologist and the machine.
Could you say that again?
The discrepancy between the machine given report and the physician report.
We see it all the time. I don't have the numbers to compare the two, but we do see it. And we do it as a routine practice when we are interrogating devices, we always differentiate.
Can we ask one question?
Yes.
There's a new variable has been introduced, so-called atrial fibrillation density. Would you like to comment on that?
Again, probably it is about the circadian rhythm and the amount of...
circadian rhythm. It is the number of events occurring as a group.
In a given time.
In a given time.
Yes. So, it is, I think it is still pretty new still.
No, it's not AF burden. AF burden is different, AF duration is different, AF density is different. So a new, actually in the European Heart Journal, new editorial has come saying that out of all the variables, AF density is most important determinant of embolic episodes. So I thought,
yeah, so probably high frequency of cluster of AF episodes
events,
together.
Yeah.
They are probably, there's a lot of change happening and likely to be more associated with thromboembolism. We are learning new things.
Yeah, it was a nice talk. I have one basic question actually.
Yes.
When do you start suspecting and screen for SCAF? And what is the best methodology? Because how long you will do a monitoring?
So currently what happens is our pacemaker patients, they come for once a year follow-up, or the CRT ICD patients come for once in 6 months follow-up. And whenever the interrogation is being done, these episodes are brought up, and then we look at it more closely. And if we do detect it, and the patient has heart failure on a CRT, then we need to take a decision regarding giving antiarrhythmics or starting anticoagulation for these patients. The other possibility is if the patient has had, in between follow-up episodes, has had a TIA or stroke-like episode, then we would probably need to look at it at that point of time and see if the patient has had these episodes. So probably these two scenarios are what I'm looking at. So with a single chamber ventricular based device, you will never pick up AF, other than the change in variation in ventricular rate, which you will think would be related to AF. It is not going to pick up, and you will not decide regarding anticoagulation dependent on that. Only if the device has an atrial lead and the EGMs are picked up, then you will decide.
So what will be this pickup rate with this aware leadless pacemaker? How good it is in picking up this rate?
I don't have experience in that. Maybe somebody from the US could talk about it, but I think it must be pretty good. Because we have the device in place.
Totally different now, sir. The algorithm it uses is different from the routine.
Yeah, but I think it should be. If it's a atrial based AVR, I think it should be able to pick up.
Atrial based.
It should be able to pick up. If it's a micra AV, again, it is not going to pick up because the way it works is different. It looks at the pressure tracings and all that.
I think, thank you, Dr.
Thank you.
We'll move on to the next topic. By Dr. Samin Datta. Dr. Samin Datta, electrophysiologist from Apollo. Hello. Next topic is by Dr. Samin Datta.
Good afternoon, chairpersons. Must thank Dr. Hygriv for having me here. Thank you for the privilege, sir. Really a privilege to be sharing this screen with such senior cardiologist and electrophysiologist. So he asked a very specific question of me. Dr. Ajay has already kind of put a few concepts in about subclinical AF that will make it easier for me. So we'll run straight into the question. This is a very nuanced conundrum again. I'm sure all of us experience this complex, little confusing area once a while, once or twice in a month, especially in high volume centers. We often, as cardiologists, get referrals for these atrial fibrillations which happen first time, a sustained atrial fibrillation. So this is an example. Middle-aged man who's hypertensive, had an angioplasty 5 years back, has a moderate LV dysfunction, is admitted with community-acquired pneumonia and sepsis, and he develops atrial fibrillation as he's on NIV in the ICU or HTU. He gets sinus rhythm as you would most of the time expect spontaneously before discharge. What would you do with this kind of situation? As you would understand, this is no longer a subclinical AF as Dr. Ajay just dwelled upon. It is not subclinical, it's already clinical, but again, it's probably in that gray area where it's not the amount of spontaneous AF. It's triggered by some unrelated, at least assumingly unrelated illness. So what do you do? Especially the relevant question is, where do we go for oral anticoagulation from here? Now let's look at some of the options or some of the things that most of the time we would do. Do we start, is it enough for us to start with this background anticoagulant in the recommended doses? Some of us will choose to continue with an antiplatelet, either a single or a dual antiplatelet one. Is that right? Do we do an extended cardiac monitoring to decide and see if we can capture something, some subclinical AF again, as Dr. Nayak said, or a sustained AF, and that helps us decide? Or give a half dose of, be a little diplomatic, play a little safe, as well as give some therapy, half dose of anticoagulant. Now, let's look at the problems with each of these steps. directly oral anticoagulant recommended doses, we do not have enough data. In fact, that's the reason why we're here discussing about this. We do not have recommendations to support that. And we have known enough now with previous, lot of papers and guidelines have stressed that antiplatelet single or dual do not protect against ischemic or embolic strokes in this situation. So that will obviously not help. Rhythm monitoring for a while, this is the first episode in a 50-year-old gentleman. You monitor for 1 week, 2 weeks. How likely are we to, document something? And how likely is it going to help us? Half-dose oral anticoagulant, again, studies have told us that you may not get full therapeutic protection. The bleeding risk is almost the same. So is it justified doing that? That said, there are difficulties. I know this is an area that we do not have a straightforward answer. We may not have a straightforward answer there. So what are the common causes of secondary atrial fibrillation? The commonest causes, among the commonest are, of course, like the previous example, infection, often a pneumonia and sepsis. Pericarditis, myopericarditis is very common trigger. Severe emergencies like burns or a polytrauma or, shock of any etiology can cause atrial fibrillation, the first episode. We all know that binge alcohol does cause atrial fibrillation episodes. Drug overdose, especially those sympathetic mimetic drug overdoses, cocaine, etc., can obviously cause atrial fibrillation. Post-surgery, either non-cardiac or cardiac, again is a subset, even intervention, you can have the first ever episode of atrial fibrillation after the intervention. Of course, endocrine disorders, particularly the hyperthyroid ones, and acute pulmonary embolism can also cause the first episode of AF. Now, let's understand about why this is the problem here. Now, in this situation, there is the interplay of a stressor, which is the stressful event, and there is an underlying substrate, if any. Now, some of us were experienced electrophysiology, we would know that with a very supraphysiologic or high or unphysiologic stimulation, we can almost induce atrial fibrillation in anybody. It may be even a non-sustained one. You do not need a substrate. But that said, what it means is if you have your routine stresses or some stresses which come and go, if that triggers a spontaneous sustained atrial fibrillation, that person is probably having an underlying substrate. All that event did is basically unmasked the predisposition or predilection of that patient of having a future. If just, we had a prior event before having a spontaneous atrial fibrillation. Most of the times, as we saw in this example, it usually resolves after the treatment of the precipitating condition. But there are enough papers to say, of course, they're not very systematic papers, but they have been observational, and they said that long-term stroke risk as well as AF recurrence is elevated, specifically in the context of sepsis and cardiac and non-cardiac surgeries. So now specifically talking about infection and sepsis, it's one of the most common triggers on almost 20% of the cases. And the reasons could be many: volume status, sympathetic tone, inflammation, hypercoagulability, dysrhythmia, and automaticity of the myocytes. In fact, elevated serum CRP levels do correlate with incidence of AF in this situation. Now, why consider oral anticoagulation, at least be proactive? Because new onset atrial fibrillation, even though it is the first time, it recurs in a huge number of patients, almost 1/3 or 50% of such patients in follow-up. A lot of them have been consistently shown in these studies. And the deleterious effects of infection can persist over years after discharge. And many of these papers, although the degree varies, but they also say that the trigger-induced AF may not be completely innocent. They may approach to have the same or similar risk as patients without trigger AF or the spontaneous atrial fibrillation, in other words. Not to forget that they also often have this inflammation and hypercoagulable situation which can persist and can make them prone for strokes. So what do the guidelines say? They sum it up. Again, the evidence is not too robust. The level is level C, not randomized, primarily observational. But they say that long-term anticoagulation should be considered suitable. That's why they're a little politically correct. You cannot, blanket all of them with oral anticoagulation. You have to choose the right patients. And how do you choose? At this point in time, we do not have a scoring system for these, but yes, like if you're rating a substrate, the best that you have is CHATS 2VA score, and you could use that as a surrogate to portend risk of atrial fibrillation-induced thromboembolic events. So you could use that score. Now if we have time, we'll just move on to one or two more examples. Another 65-year-old man who's hypertensive, normal LV function, develops the first episode of atrial fibrillation in post-operative care ward on the day 3 after a conventional CAG, a sternotomy CABG, where he went on bypass and came off. Sinus rhythm had to be restored because he was hemodynamically challenged after an antiarrhythmic amiodarone bolus. Again, what do? Do we consider DAPT, as many of these patients would continue to have over follow-up, single antiplatelet with half dose oral anticoagulant, single antiplatelet with full dose oral anticoagulant, extended cardiac monitoring, will that help? Or like we've heard extensively in the previous session, a refer for PFA. Now starting from lower up, PFA, of course, this is a first episode of AF. This patient doesn't have the necessary candidature for PFA. He's not symptomatic with AFA, so that rules it out. Cardiac monitoring, I told you about the limitations earlier. Antiplatelet combining with oral anticoagulant can be a little challenge. Again, if you do, we need to commit full. If the patient is a candidate for anticoagulation, we'd like to go fully committed, considering the antiplatelet requirement as well. Last example, 65-year-old man, hypertensive, diabetic, previous PCI, normal LV function but concentric LVH with a large LA, enlarged LA. He had to complicate things. He had a history of hypertensive basal ganglial bleed a few years back. Now he develops atrial fibrillation, sustained atrial fibrillation in the recovery ward after undergoing hernial repair. Sinus rhythm spontaneously came back at the time of discharge. Where do you go from here? What do you do about oral anticoagulation? Do we do an EP study to look for AF inducibility and decide whether the AF is inducible and then consider oral anticoagulation? May sound reasonable to some, but is it really necessary? Half dose oral anticoagulation, full dose oral anticoagulation. Will single antiplatelet suffice? Obviously no, for the reasons already quoted. Dual antiplatelet, will that help? Well, if the patient already has a history of coronary angioplasty, so he's already a candidate for antiplatelet, but does upgrading dual to dual make sense? Probably no. And I think Kumar will talk about this LA appendage occlusion. Is he a candidate for LA appendage occlusion, considering he has a history of bleed, and there are difficulties in committing towards oral anticoagulation? Well, this is a trigger AF now. He's never had an AF before, so is it a stretch to give him an LA appendage occlusion? At least consider that. Many times, there is no straightforward answer. Some of them rule themselves out, but you may not have one great answer. But the idea here is not to dogmatize. It's about considering that all of these patients, they have a lot of these cardiac surgeries, 30 to 50% of them have atrial fibrillations, atrial fibrillation during the course of recovery, and a significant minority of non-cardiac surgery patients who undergo that, they have atrial fibrillation. Obviously, it complicates their inpatient stay with a lot of complications, prolonged stay, heart failure, MI. And there are risk factors. The risk factors are increased age, male sex, LA enlargement, poor EF, COPD, CKD, and so on. We've heard all that. The highlight here is all of these patients have consistently, the studies have shown that they have a high chance of AF recurrence in future. And that's the point. If they have high chance of AF recurrence, then go back to their substrate and see whether they are a candidate for oral anticoagulation and protection from thromboembolic events. That's where you're now. So if they are going to have recurrent events, you need to consider oral anticoagulation. I'll conclude with that. So the guidelines say that, again, the data is not very robust, but you should consider long-term oral anticoagulation for patients who have had cardiac or non-cardiac surgery, AF during the recovery, because they could be predisposed to recurrent events and stroke. So to conclude, secondary AF is not completely innocuous, and it may actually unmask an underlying substrate which is already there. They are predisposed, they would anyway have AF probably in future, and you need to tease out the right patients to protect with oral anticoagulation. Thank you for the opportunity.
Thank you, Dr. Samin. What we will do is we will have the question and answer sessions after the other two talks.
Sure, sir. Thank you. Thank you.
Okay, now next topic will be by LA occludus by Kumar Narayanan. Dr. Kumar Narayanan.
Thank you, Dr. Hygriv and the organizers for this opportunity. So I'm going to touch upon a little controversial topic which has been in the eye of a lot of discussion in recent times. There is a choice of left atrial appendage occluders, and the question here is again specific, can it be chosen over NOACs in non-valvular AF? So we all know that AF significantly increases the risk of ischemic embolic stroke, almost a 5-time increased risk. And one of the factors in this is thought to be the issue with the mechanical LA appendage stasis. And we again know from large trials, both with warfarin and with NOACs, that the prevention is anticoagulation. It's not aspirin. And especially now with NOACs, the extent of protection demonstrated for embolic stroke is pretty good. And the bleeding rates have also been brought down reasonably well with NOACs. So this is the first thing we need to keep in mind. But we are not completely home, because there are issues with oral anticoagulation. With warfarin, we know very well the narrow therapeutic window, need for regular monitoring, lot of interactions, fluctuating INRs. And though NOACs have improved the situation a little bit with fixed dosing, more reliable action, but still there is concern with some rates of bleeding which are not ignorable, and also the patient needs to be pretty compliant, especially with NOACs. You miss a couple of doses, then the protection window is off, and there is also an issue in giving it to patients with advanced renal dysfunction. So this has really triggered the need in the field to see if we can give a mechanical solution to this problem, and the rationale is based on both autopsy and imaging studies which show that the LA appendage is the most common site of thrombus formation in both acute as well as chronic AF. But something to bear in mind, and we'll come back to it, is that this is not totally a mechanical problem alone, and we know that the genesis of thrombosis in AF is more complex with other factors like endothelial dysfunction, inflammation, and also the progressive atrial myopathy in general. So with this background, we look at some of the key studies which form the evidence base, and we are here talking about percutaneous LA appendage closure. Surgical LA appendage ligation, as we discussed before, is a totally different topic, and there are very specific recommendations for that backed by a different evidence. So this was the first IDE trial of the Watchman device, the PROTECT AF trial, which compared about 700 patients with non-valvular AF randomized to LA appendage closure versus warfarin for a primary composite endpoint of stroke, CV death, or systemic embolism. And what it showed was the rate was about 3% with LA appendage closure and about 4.9% with warfarin. And it concluded that Watchman was non-inferior in terms of efficacy. But a couple of issues with this trial is, number one, it failed to meet the primary safety endpoint, and this is mainly because of a very high rate of peri-procedural complications. It was the first time operators were doing it. And also the study was rejected by the FDA because of certain internal validity issues, especially with regard to how hemorrhagic stroke was adjudicated. So essentially they had to do another trial. This was the second IDE trial with the Watchman device, which was called the PREVAIL trial, which again took about 400 patients randomized roughly 2:1 to LA occlusion versus warfarin. Here, the primary endpoint of stroke, systemic embolism, or CV death was not met for non-inferiority with the Watchman device. This was the first thing. So they looked at a second, what they called a co-primary endpoint, where they excluded the first week after the device implantation and then looked at stroke and systemic embolism, and here the non-inferiority endpoint was met. The couple of issues here was also that, if you look at also the non-inferiority bar which was set, it was somewhere in the range of 1.7 to 1.8. Typically in the large NOAC trials, it was set at around 1.4, 1.45. So this was again another one of the issues where the non-inferiority bar was set fairly lax so that the Watchman device was able to meet the non-inferiority. The field moved on from there by the time these trials were done, and NOACs really became the standard of care with their much better bleeding rates compared to warfarin. And now warfarin, comparison with warfarin couldn't be considered the standard of care anymore. So the direct comparisons with NOACs were needed, and this was the first trial which looked at a direct head-to-head comparison between the LA appendage closure versus NOACs. This again used both the Watchman as well as the Amulet device from Abbott. And this trial looked at that segment of the population where it was thought to be more useful, that is, patients with a high CHA2DS2-VASc and high Hasbled score who may have more benefit from avoiding anticoagulation in the long run. And the primary outcome here, which was a composite of essentially everything, stroke, TIA, systemic embolism, CV death, bleeding, or any complication. They just put everything together in one primary endpoint, and they found that it occurred about 11% with LA appendage closure versus 13.4% with DOACs. And they also did a 4-year follow-up which showed similar results. Now, though again this met non-inferiority, couple of criticisms with this trial whereas they blended both efficacy and safety endpoints in one composite end group. Ideally, what you need to show with LA appendage closure is that it is non-inferior in terms of stroke prevention, but it should be superior in reducing bleeding, because this is the whole rationale of putting a device rather than giving anticoagulation. But when you jumble all of them in one common endpoint, then it becomes easier to meet non-inferiority because these two endpoints go in different directions. And again, one of the issues, if you look at all stroke and TIA here, the hazard ratio of about 1, but a pretty wide confidence interval ranging all the way up to 2.5. So if you were to look at it from a point of view of non-inferiority, you're saying that the device could potentially be 2.5 times as worse as the drug, but we are kind of considering non-inferior at this point of time. 3 major trials which came out in the last 2 years. One is the option trial. Here they looked at patients undergoing AF ablation and getting a Watchman device. So essentially they threw out the idea that patient is going for AF ablation, just put in a plug in the LA appendage at the same time. Again, fairly high mean CHA2DS2, 1:1 randomization this time, and a 3-year follow-up which showed again that the rate of the death from any cause, stroke or systemic embolism was similar between anticoagulation and device, and it met the non-inferiority margin. When they looked at safety endpoints, when they looked at bleeding excluding procedural bleeding, non-procedural major bleeding or clinically relevant non-major bleeding, it was lower with the device as compared to anticoagulation. But when you included procedural bleeding, then it was not superior. So the couple of criticisms with the option trial was, number one, if you looked at the primary composite endpoint, most of it was driven by death from any cause, and when they inspected those deaths, most of them were related neither to anticoagulation nor to device. So again, if you take about 45 events and 30 of them are related to death, which has nothing to do with either of your intervention, again you introduce a lot of noise into your endpoint, which makes non-inferiority easier to reach. And again, if you look at major bleeding, excluding procedural bleeding was probably not a very appropriate thing to do. The closure AF trial was a pragmatic open label trial which looked very high risk elderly patients randomized to LA appendage versus best medical care. This was the first non-industry funded trial, and here it showed that LAO was not non-inferior to medical treatment. Lastly, the Champion AF trial looked about 3,000 patients, probably the largest trial to date, randomized to LAO versus oral anticoagulation. And this again showed that non-inferiority was met with device rates of 5.7%, anticoagulation of 4.8%. And again, the main criticism was a very lax non-inferiority margin for the extent of events which was observed. So quickly going on to the fact that more newer devices are being developed now which might improve safety, and there are good amount of real world data coming out. And a couple of meta-analyses have looked at the issue. That one is that a 2024 meta-analysis which showed equivalent rates of all stroke, but ischemic stroke the signal was worse with LA appendage closure. And also if you looked at the major bleeding, it was pretty similar when you included procedural bleeding as well. A more updated meta-analysis in 2026 has shown a kind of similar picture with a slightly concerning signal of worse ischemic stroke. So I will just conclude by talking about the guidelines. Right now, the 2023 guidelines ACC give a 2A recommendation for patients with AF and a contraindication to anticoagulation, and a 2B recommendation for those who are at high risk of bleeding, whereas the 2024 ESC guidelines are more conservative and just give a 2B recommendation. And this kind of still reflects the uncertainty of the evidence base which we have. So I will not discuss much about the device-related thrombus or peri-device leak. These are two things to keep in mind which are yet unresolved with the LA appendage closure. So further studies we need in diverse populations before we can really say that LAO is ready to replace especially NOACs, which are very solid evidence based, and hopefully future improvements in device design will help us. So I just want to show this picture from the Watchman website, which says, Watchman implant one time for a lifetime, leave blood thinners behind. I don't think the evidence base is there as yet to make such a dramatic statement. So I think we need to proceed with caution. It could be a reasonable option for selected patients with careful decision making, and we need to really discuss the pros and cons in each patient. Thank you.
Thank you, Dr. Kurmanarayan. We'll go to the next topic, that is the role of artificial intelligence in AF and heart failure. Dr. Abhyuday Kumar Swami.
Thank you so much for having me. I don't know if you are able to recognize this particular font here. For those of you who do, they'll realize that you've been actually seeing AI throughout the day, right? Many of the faculty have used Claude Code that I see to generate many of their slides. And so, you can already say that AI is already helping us, right? Right. So, coming to AI in AF and heart failure, right? How will it enhance patient care? It's a little bit like asking how electricity in AF and heart failure, how it helps in management. Take for example, you've got a particular patient who's a prime candidate for ablation, and they have been conservatively managed right now, right? So is the electricity that was used to manufacture the drugs which they're on, is that detracting or helping the patient? Or is the electricity that is going to be used in their ablation, is that going to detract or help the patient? So it depends on the context, right? So this comes down to a very important point that I'd like to make. It's that AI is thought to be like a set of tools that you use. It's actually not. It's actually a resource, a utility. What these big tech companies are trying to do is not trying to create a car engine, they're trying to create crude oil. With a good set of tools, you can make probably millions of dollars, but with a resource and utility, there's a potential to make trillions. And this is not just as doctors that we need to be aware of, but as citizens as well, right? To be aware of good AI governance and good AI use. So since it's so ubiquitous, AI can be used so ubiquitously across the different levels of management. You can approach the current problems in AF and then enumerate them and see how you can use AI in them, right? So essentially it's at least in India, you've got problems with the unknown prevalence because we've got such a low visibility on what's happening in the population. Patients don't present early, and therefore you've got problems with early detection. And of course, a snowball effect on how it is going to cause problems with effective treatment. So why is unknown prevalence a problem, right? It's not just that we don't have enough visibility, it's that the splay is so much. So different studies ranging from 0.1 to 5% prevalence is, it's been reported across India. And something, of course, that we already all know is that age is a huge risk factor, and therefore you do see increase in prevalence as the age increases, right? But why is prevalence such a major issue? So this is a simulation of an actual model that I was training, and it has a sense of 80 and a spec of 80 as well, right? An ROC AUC of 90. It's supposed to be really good. But one really great thing about sense and spec is that, or not so much of a great thing, is that as the prevalence changes, the sense spec remain the same. But I want to bring to your attention what actually changes. If you look at the positive predictive value, at 0.5%, it's around 2% positive predictive value, and at 5%, it's around 19%. But what does that mean, right? It means that for the same model with the same sense and spec, with an ROC of 90, you'll have to do 43 confirmatory tests to actually get one true case of disease. Where at 5% of prevalence, you will just have to do 5 cases, right? So there's a huge difference. So it doesn't really come as a surprise that the current scores cannot effectively be used, especially in the Indian population, as a screening tool. So you've got Charge AF, of course, you've heard of Charge VASC, which can be repurposed, of course, to predict. And you see that the C statistic and AUC is about 0.65 and 0.76. So given how the model performed at 0.9, you can imagine what the state would be if to use a score with such a range of AUC. So we finally come to how AI did help us. Of course, detecting AF during actual episodes of fibrillation is a trivial problem. A computer can generate the results very easily, the rule-based algorithm that is. What is really hard is, of course, detecting the subclinical cohort. Essentially, what you want to do is you want to catch it at the periparoxysmal or pre-paroxysmal stage. And this is what folks from Mayo try to get done. So they use an AI called CNN, an architecture based called CNN, where they took the patients who had AF and went back in their history and took their ECGs, ostensibly normal looking ECGs, right? So to a cardiologist it should appear to be a sinus rhythm. And they tried to see if it could predict AF or not. And there was quite a lot of success. They were very excited to get these results. And so, the whole theme changed from an AF for an arrhythmia to be caught to an AF that is a risk state to predict. So it can finally be treated as the lifestyle disease that it is. You don't want AF to be presented, as a stroke. And they wanted to try to see if they can get this out into the real world. But alas, they had a reality check. Once it was deployed and once people tried to replicate it, they found a huge drop in performance. So for example, Hygriv out of a group from Sweden, they saw that the AUC dropped from 0.8 to 0.62, and the reason that they gave was that what they thought ATIA was picking up, the Mayo folks were picking up, was that the ECG was picking up age changes, right? And since age is correlated with AF, and they were getting good results when trying to predict AF. But if you account for this age homogeneity, so essentially if you take two patients who are say 75 years of age and try to use the model to predict AF or not, it used to fail. So the same thing was replicated in the Vital AF trial, where they tried to see if their in-house AI ECG was comparable to Charge AF. They found not much of a difference in that. Again, there is another trial, Air AF versus Charge AF, where they try to see if their own ECG AI could beat the current risk scores, but they didn't have much luck. So our foundation model is the antidote. So all these models that you must have heard of, right, ChatGPT and Claude, they're based on something called a transformer architecture as opposed to a CNN. And they are essentially foundational models in the sense that think of them being trained more on data rather than any specific task. And so whenever you're thinking about foundational model, think extremely large model, extremely huge amount of data, and they essentially become foundations for where you can tune them for specific tasks. But no such luck. Al-Masood in 2026 found out that even a small model, 3.8 million parameter model, was comparable to a 97.2 million parameter model. Actually, Coppola actually found out that their 30 million parameter model was much better performing than the 108 million parameter model, right? So overall, at least with detection just purely with ECG, they were not having more luck. But light at the end of the tunnel, what we do see is that your classic medicine approach, where you try to get evidence from different sources and build your case. I'm proud to say that very own Kerala AF model, for example, they were able to essentially improve upon performance quite significantly by combining CHADS-VASC multimodally along with ECG images. Same with ARF plus that other trial that I talked to you about. When they combined the models, they gave them better results. Where we do have some sort of really good results is in actual ablation guidance, where using PVI plus real-time AI-identified dispersion mapping was hugely successful, where compared to just using PVI, they were able to, using AI-guided ablation, they were able to get really good results. Freedom from AF at 12 months jumped from 70 to 88%. Coming to heart failure, much of the same problems that you see in terms of prevalence, it is replicated here in heart failure as well. It is augmented by the fact that you've got MREF plus preserved ejection fraction coming in. I'll just be very quick. But AI can actually make a huge contribution here. Why? Because you can actually use simple investigations as opposed to higher order investigations which are required for heart failure screening. To try to see if you can actually come up with a viable screening tool, right? So, and again, Mayo did the same thing at year in 2019, showed that they could just use ECGs to detect patients with low ejection fraction. This has been replicated across, it was first replicated by our group here at Narayana, where we looked at the Indian population and we were able to classify patients who have got low ejection fraction. This has been replicated across, robustly across 14 different centers. Thankfully, Narayana has got digitized data across a lot of different centers, and we were able to essentially validate these findings. We've also, one thing that I do want to mention is that the problem where you notice that there was less PPV, it might not actually be much of a problem, because many of the false positives that the AI model had picked up actually turned out to be that the patients actually were able to, did go ahead and develop heart failure in the next 5 years, right? So as compared to the true negatives, the patients who were flagged quote unquote as false positives actually went and developed heart failure. What this means, this is replicated again, it means that ECG AI might be able to pick up heart failure way before it manifests in the echo. Another thing, smart way to use the algorithm is that just because you've got a relatively low PPV, that doesn't mean the model is not useful. It's about how smart you are in using the model. Essentially, our group, again, we developed a model where it takes ECG as input and it flags if the patient has any one of the following: if the patient has valvular heart disease, if the patient has a low ejection fraction, and or if the patient has elevated PA pressure, right? And we were able to show that because with a great sense and spec, even though with moderate PPV, mathematically you will have a high negative predictive value. So you're able to say with very great confidence if the patient will have some sort of disease or not. So what you can do is essentially you'll be able to effectively streamline echocardiograms in your resource constrained settings, and you'll be able to deliver healthcare much better. So just to conclude, AI in early detection, AF needs a lot of work. Multi-modality appears to be the road forward. We need a very high sense spec for the PPV to become trivial. Genuine inroads have been made in AI-guided ablation. Screening for heart failure now is within reach thanks to ECG AI. And ECG AI might be able to pick up heart failure before it manifests in echo. And smart application of AI is much more important, right? Knowing what the limitations of the model are that you're going to use is really important. Thank you.
Thank you, Dr. Abhyuday. If you have any questions from the panelists. Any questions from the audience?
Practically, can you tell me in India in the next 5 years in atrial fibrillation, in what way AI should be? In AF, probably in the next 5 years in India, can it predict clinicians in what way it will help us?
Right now, it is just they have found evidence that a patient becomes fast bleeding. Right, we have problems again, like I said, in terms of detection. If you want to detect occult or subclinical AF, there still needs to be a lot of work done, especially given the fact that people don't realize that, like I said, prevalence matters a lot. So just because you've got a really good ROC AUC, that doesn't mean that you're able to get really good results. That's purely because of the fact that prevalence matters. The only way it becomes trivial is when your sense spec goes to like 98, 99, which means that you have to expect better from your models currently, if you're talking about detection. Why I focus specifically on detection? Because we have a problem, right, as we all know, in referrals, right? We don't detect them fast enough, and the EPs and cardiologists are probably introduced to the case way late. And therefore, the whole focus of my talk was on detection rather than just ablation. But right now what we see is that probably with digital twins and probably with better ablation techniques is what you're going to see immediately in the 5 years.
Does it in any way help in refining the stroke risk assessment?
Yes.
Huh?
Yes, I think Kerala AF showed that, right? So their model, yeah. So absolutely. Because they combined the CHADS-VASc with ECGs. I mean, they're already diagnosed with AF. But this is what I'm talking about, right? A clever way to combine AI with this thing, it definitely does.
Okay, with that we'll conclude and go to the next session.
It's a day of knowledge overload with so many stalwarts, iconic, eminent EPs, cardiologists taking trouble to gather here for exchange of ideas, knowledge, tips to give better care to our patients. A big thank you to all of you. And since we are coming to the end of the session, we are skipping the tea session, which can be had after we conclude today's program. So we are entering the last session of the day with heart doctors giving suggestions on how to manage and handle heart failures, giving heart attacks to many thriving advocates. So jokes apart, we have two speakers in this session who are not EPs they are neither EPs nor cardiologists. But one is a physician who is taking care of a cardiac rehab center, and another is endocrinologist from our own hospital, Dr. Prasann Dev sir, who is the HOD and senior most endocrinologist from our hospital, KIMS Secunderabad. So for this session, I call upon the chairpersons, Dr. Shiv Kumar, Dr. Ravikant sir, to occupy the chairs on the stage. And Dr. Sadiq Azam will be, sir, you will be there only in the first row chair. And the speaker, first speaker is Dr. Muralidhar, who will be taking over the podium now.
Check, check, check. Thank you. Good evening. I'm here to talk about how to add happiness to the patients who are diagnosed with heart failure or with heart condition. So I'm Dr. Muralidhar Babi. I have done my MD rehab medicine from CMC Vellore, and I practice cardiac rehab. So this is available in Film Nagar. Cardiac rehab is a WHO class 1A recommendation. It's as good as a blood thinner. So unfortunately, it is totally globally it is an underutilized service. Even in India, it is practice is very low. That's when ICMR decided to put this entire syllabus in rehab medicine. And fortunately, I'm the lucky person to be the first batch to be trained for this. And being a pioneering, it's an unfortunate, it's a lot of homework, a lot of challenges to raise awareness because it's an underutilized service. What we do, cardiac rehab is all about building endurance. It's all about building endurance to a person who has diagnosed with heart failure or various heart conditions. What does actually do cardiac rehab? So what are the structural changes happens? So it's a 3 to 6 months of program, around 50 to 100 hours of intervention happens in a clinical setup where physician supervised custom tailored graded exercise program is done. So here, what we make at the end of an outcome is endurance. The person will be able to do walk, maybe begin with walk, or walk to speed walk, or jog, or run. After run, again run. So at the end, half an hour of non-stop endurance is the outcome goal of this program. So what will happen? So in this 90 minutes of sessions, we induce beta stimulation in a systemic manner that your muscles, large arteries supplying the muscles will start dilating, increases its compliance, stiffness will reduce, suddenly there is a drop in afterload. When there is a drop in afterload on a myocardium, it's a good for heart to put a less effort to pump the blood. So this is associated with an increase in preload. The person is actually doing 60 to 90 minutes of cardiovascular exercise. So heart failure is associated with a lot of preload. And here we are also putting a systematic preload on the myocardial or cardiovascular system, which is stretching your left ventricle. So as a change, you will see a positive remodeling of the myocardium. There is an eccentric dilatation. Both heart failure has eccentric dilatation, even positive remodeling also eccentric. The difference is that in a positive remodeling, there is an eccentric dilatation with thickening. In a heart failure, it's a single left ventricle keep on thinning. Here, the eccentric dilatation with thickening and global hypertrophy also. So dual chamber hypertrophy happens both left side and right side ventricles. So these are the positive remodeling and these are the negative remodeling. So cardiac rehab brings positive remodeling on a person or a patient who is going towards a negative remodeling. So we prevent the worsening of a heart failure. So along with structural changes, we have a neuroplasticity also developing. So we know that as a positive remodeling in a patient with heart failure, one day the resting heart rate or the average heart rate comes down. So it doesn't happen overnight. It's a 90 to 100 hours of intervention. Person is able to do endurance. There is an increase in vagal tone as a part of a 3 to 6 months program of intervention. So vagal tone doesn't happen as such. It has an adaptive to the volume of exercise the person is doing. So when this happens, what happens? So the vagus nerve is not only the nerve which is supplying to the heart, it is supplying to many things, especially in a heart failure patients who is not taking any medicine. Today he had a heart failure and now he is a bunch of medicines which trigger frequent acidity attacks. That leads to a lot of compromise in quality of life, confusion whether I am again coming up with another heart incident. So there's a lot of things happen if the person has a recurrent acidity attacks, prone to the drugs or prone to the even his own lifestyle or a past history of acidity attacks, or he wants to have a good meal, next day acidity or my heart is worsening. So vagus will reduce the number of even acidity because it improves the digestion and reduce the number of acidity. And much more important is that vagus will also helps in increased peristalsis and defecation. We always say, don't strain after heart failure. You are asked to do a commode, utilize the commode rather than an Indian. Now look what vagus is doing, helps in even defecation. The long-term adaptations of cardiac endurance and cardiac rehab is not only decrease in heart rate, bradycardia, increased compliance of the myocardium, even the digestion and the defecation also improves. It's a lot of changes. And I'm very happy to tell the world that the half-life or the life of an endurance, it doesn't build over a period of time. So the adaptation also, decrease in or increase in vagal tone or suppression of sympathetic is a 3 to 6 months program. You build an endurance and you have all these adaptations. Unlike medicines, we have to keep on doing every day. So complementing both will give a lot of positive benefits or rather worsening of a condition. Now, what will happen? The structural changes both at the neuro and the cardiac will complement if the person with arrhythmia prone on guideline-directed medical therapy with and without cardiac rehab. Look what happens after a heart failure or a person who is having a device. Frozen shoulder, fear, not moving hands, not confident in utilizing the upper body or not having a confidence to and even exertion phobia. Now this person is doing 100 to 50 to 100 hours of intervention, jogging, walking, running. Look at the perception he has. He will see himself heart rate and ECG going 120, 130, 140 versus the person who is having an exertion phobia. The positive feedback itself kills all the negative feeling after having an ICD or a pacemaker under them. A lot of people's quality of life is very poor once they have a device set up. Not everybody are strong. Upon that, if somebody has a shock experience, imagine now how the persons will fear. Even if he wants to climb stairs, even if you want to travel anything, the exertion itself, no, it will give me a shock. My doctor has told me at this particular rate you will get a shock. So these kind of feeling has a poor quality of life. Rather that feeling will worsen the condition. Now the person with an ICD device is actually running marathons. Look at the level of happiness the person has. And along with the guideline medical therapy, if cardiac rehab is not there, so either it's a progressive disease or if the myocardial keep on thinning, the arrhythmia keeps increasing. But once we start thickening through cardiac rehab, the arrhythmia or the risk of getting an arrhythmia is also coming down. Now, this is what we do at our clinic. It's a custom tailored graded exercise program, which is very unique, that is customized to every condition, whether it's heart failure, left side heart failure, right side heart failure, whether the person is waiting for a heart transplant, or it's simple and a moderate to mild LV dysfunction, or it's simply another myopathies. So based on that, the exercise program differs from person to person, patient to patient, and the duration keeps changing. Ultimately, every myocardium or every patient with any heart condition has to build an endurance at the end of the program. Now, what happens? This is the more important. If you observe the life of a heart failure patient or people with heart conditions, exertion phobia is the most common thing. People treat themselves as one heart patient in the family. They always give special attention. He's a heart patient, he's a heart failure patient. Do you know everybody experiences the quality of life that person. Now this person is bringing embarrassment to the family. How? He's running 5 kilometers, 10 kilometers, some of them run 21 kilometers. Every Sunday morning he goes out and runs, comes back. In a year he brings back 30 medals to the house. Look at the family's embarrassment. He's more fitter than any other person in the house. That's an embarrassment happens if the person joins cardiac rehab. Yeah, this also brings down a lot of anxiety because every heart patient has a certain level of anxiety that being a heart patient, and that also that gets killed because the person is actually doing high volume exercises, sweating himself and doing a lot of activities. That biofeedback is enough for the patient to have a very quality life. Not to just few patients who have consented, patients with EF of 18, he was waiting for a heart transplant, listed in NIMS hospital for a heart transplant. Today is a marathon runner. And he's one patient with myopathy whose EF was 25 when he joined. He is also listed for heart transplant in NIMS. Today, after his diagnosis, after cardiac rehab is completed, he decided that I can live long, and he did his law recently at the age of 50. Some more patients normally function, but angioplasty done, not confident, psychologically gone, but today is a very good runner. The patient who had a recurrent heart attack, CKD concomitant, repeat hospitalization for around 6 months, he's never left the house. Today is a 5 kilometers jogger. Similar situation, he's one person DCM and he was also advised heart transplant. Today is a 10 kilometers marathon runner. Now we are a small community of runners called cardiac rehab runners, trying to influence the entire world, saying that you are fitter, healthier, and you are no far different from any healthy person. We need not require a special status that we are heart patients. We are runners. All are recreational runners once the patient goes through a cardiac rehab. So every Sunday morning we all gather, and this is for the last 4 years I have been doing it. Every Sunday morning, all my patients, family members, everybody come and do a group activity, and this is still going on. We have a big group, and yeah, just a promotion. On every World Heart Day, we do this run, cardiac rehab run. Everybody please come and participate. Thank you.
Thank you, Dr. Murali. That was an excellent presentation on what I feel is a very, very important topic. As you rightly said, a lot of patients have the fear of heart failure more killing them rather than the disease itself. Thank you once again. I think we'll take questions at the end of the session. Okay. I'd like to call Dr. Prasandev next for delivering his talk on management of obesity by incretin mimics to prevent cardiovascular events. Over to you, sir.
Yeah, I'm sure. I saw your photographs, man. All right, good afternoon. The good news is I am the last speaker. And so, I know it's been a difficult day for you. I came a little late. I have cheated. But you have been here since morning and wow. So basically, I will be talking about incretin agents, and it doesn't matter which part of the professional spectrum we are from, what your specialty is. Your patients have already started coming to you and asking about Mounjaro and Ozempic, and many of your patients have already started the medicine with or without your blessing. So the question then you have to ask yourself is whether your specialty is going to be affected adversely or beneficially with these molecules. And this is a valid question, you understand, that we have had an era of SGLT2 where we know that they are cardioprotective agents, but remember that they had a little issue with myocardial infarction. In fact, most of the studies which looked at SGLT2 inhibitors have positive cardiac outcomes based on mortality and congestive heart failure, not coronary artery disease. In fact, the empagliflozin study actually had a slight numerical increase in non-fatal myocardial infarction. And so to say that that entire group is cardioprotective, you have a small asterisk on top and say conditions apply. But this group, this is an amazing group. There is nothing that can go wrong apart from the fact that they're injectables, and till a few weeks ago they were very expensive. Now they are not expensive either. In fact, they are now cheaper than most of our oral antidiabetics that we prescribe. And so we are seeing a lot of patients using them. Until now, touch wood, we have had no major concerns that we have to report. And in the next 5 minutes or so, I'll just quickly go through some of the studies that have actually specifically looked at cardiac outcomes from these groups. So I'll just briefly talk about it, and then we'll quickly go through the slides, and then you can go to your tea break. So the only concern that people had with this entire incretin group was that they caused a slight increase in pulse rate. What a bad thing to say in today's meeting, because you have been talking about pulse rate since morning. There has been, initially you had this molecule called Byetta. They routinely reported a 6 to 10 beats per minute increase in the pulse rate, resting pulse rate, when you use this molecule. And so the common sense teaching initially was that probably this group will cause worsening of congestive heart failure because of that tachycardia. This has not been duplicated in studies, and now we have studies which have specifically looked at cardiac outcome, specifically congestive heart failure. In fact, it is a good molecule for HFpEF. So why don't I just quickly go through all these unimportant studies and go to this, right? Now, this is a very interesting study. You know that you now have GLP-1 analogs. You now have a dual molecule which is both GLP and GIP. You are familiar with Mounjaro, because that is therefore a slightly more powerful molecule than semaglutide. Your patients probably call it Ozempic. Now we also have a triple agonist data. Just remember that the black numbers there, the black letters there, is for the GLP. Triple agent is going to be really, really effective. And the kind of weight loss is becoming funny. The dual agonist can routinely produce a 10 to 20% of baseline body weight loss. the triple agent can actually outdo a bariatric surgery. 25 to 30% of baseline body weight, and we are talking about 55, 60 kgs of weight loss clinically. And so these are great molecules for everything concerned. And so I'll just quickly talk about the, this is what the semaglutide has done. It has, you have studies for weight loss, of course, all-cause mortality, liver benefits. I'm going to briefly discuss that. That's actually very interesting. Primary prevention, I'll touch that, and congestive heart failure. So this is the SUSTAIN 6. It is basically against placebo, and you can see that it's a nearly 10-year study. The lines have started diverging less than 1 year after starting the molecules. So these are all numbers. This is all these patients had already had heart diseases, and so this is a secondary prevention study, and it's very effective. And this was the STEP study. It basically looked at the score, the clinical score, and you can see that semaglutide improves weight loss, of course, and also heart failure symptoms. And so that concern that we had about the tachycardia not producing good effects on congestive heart failure is now no more there. In fact, it actually benefited the HFpEF patients, and that is actually much better. The SELECT trial is basically looked at obese people who are not diabetics. So you can give the maximum dose of semaglutide even to non-diabetics. This study used the full 2.4 milligrams per week, and the essence was the liver study, where this is the only molecule that we have which can actually reverses fibrosis in the liver, and that is really something. So they have looked at other markers with fibrosis being the same, and reduction of fibrosis with the other markers remain the same. And both the statistical calculations, it actually was statistically significant. So this is now the 2.4, not the smaller dose, is now recommended as a therapy for MASH, and that is huge. And so I'm not going to talk about the kidney because that is not what probably interests you. This is the oral semaglutide. So it's been around for a longer period with us. We have not been very aggressive with the oral semaglutide, but we now have data for cardiac output in the oral semaglutide also. And you know that oral semaglutide is a daily tablet of 3, 7, and 14 milligram. All these data is with 14 milligrams, fairly well tolerated by patients. And this also, the cost has significantly come down since they lost the patent. And so these are exciting times for us for semaglutide. What about the double agent, the tirzepatide, so-called Mounjaro? You now have data for cardiovascular outcome, heart failure, the SUMMIT trial, and also the liver. The data with Mounjaro is slightly less than Ozempic, simply because we have less time to look at the data. And so these are all exciting times. This is actually my last point that I wanted to make. And so all your patients who want to go on this molecule, please put them on it. Because whatever your specialty is, we are going to have good results with these molecules. Apart from probably gastrosurgeons, no one is really unhappy with these groups of medicines. And so, yeah, so there we are. I'm sure there would be no questions. There seldom is any questions in the last session of the day. So, sir.
When you put these patients on do you have a checklist? Because everybody is not entrepreneur. What are the sarcopenia is a concern. Like, for example, that's one thing I know. So, is there any checklist that we see 1, 2, 3, 4 before we put them on?
Biochemically, there's practically very little that you need to look out for, except for the fact that if your patient is a diabetic, make sure that someone has looked into their eyes, because retinopathy worsening is a significant problem with sudden loss of weight and sudden loss of blood sugars as well. That is the reason why pregnant ladies have so commonly worsening of retinopathy. The other thing is, although it is not recommended that you do it for every patient, you need not do an ultrasound abdomen for everyone. But if the patient has been symptomatic, that you need to ask. Upper abdominal discomfort, you have to rule out existing pancreas issues and existing gallstones, because both of them can worsen. We know that the entire incretin pathway does that. And anything that causes sudden weight loss causes gallstones. And it's very common after a... These are a little problematic. If it is the retinopathy, the proliferative retinopathy is a direct contraindication for starting these molecules. But they have also reported some ischemic changes in the nerve, optic nerve. And that, it's a bit of a bad luck kind of thing. You cannot predict it. It does not get better. The only good thing is it's very, very, very uncommon, very uncommon. So you can practically rule that out. Just make sure that proliferative retinopathy is not there, and I think we are safe.
Is it important that we rule out MEN2 or medullary carcinoma?
Oh yes, yes sir, absolutely. A family history of MEN2 is also there. Although you need not do the calcitonin levels routinely, that has been ruled out, because most of the studies found that there was a slight increase in calcitonin levels on practically all patients who go on these. So that does not appear to be a predictor for medullary carcinoma. But if there is even a family history of men, it's a relative contraindication.
So
how about
pancreatitis and this
pancreatitis, again, you don't look for it, sir.
No, if there is a history, we don't give.
And tell the patient that if there is upper abdominal pain, they should come back immediately. No point in doing the amylase routinely. Again, amylase will also routinely go up for all these patients. So,
Dr. Prasoon, how about irritable bowel syndrome? Suppose somebody is having significant irritable bowel syndrome. Is it a relative contraindication to start with GLP-1?
It is not, sir. It has not been recommended that if someone has this. The thing was, it was a little unexpected that Monjaro has reported with more loose motions than constipation, because there was really no reason why they should have loose motion, but patients are frequently reporting that. So if a patient has symptomatic irritable bowel syndrome, you might worsen this thing. But again, this is reversible. If the patient has it, you can just stop it. It doesn't worsen in the long run.
Sir, is there any subset of cardiovascular disease where you would not recommend these agents?
Cardiovascular?
Any of our patients where we should not be prescribing this?
Oops, offhand, I don't think so. No, I don't think so. Whatever your patients are, if they lose weight, everyone is happy, including the doctors. So,
Thank you, Dr. Prasanna.
Actually, the cardiovascular outcome was with 2.4 or 1 milligram also.
Most of the studies are with 2.4, sir.
Yeah.
But now you have with oral medication also.
But the diabetes one which showed is only with maximum 1.5.
0.5 and 1. 0.51 was the original Ozempic study. But now we have most of the studies at 2.4.
But majority of the patients, non-obese, diabetes, suppose mild obesity and diabetic, cardiac disease like coronary, whole day inferior value MI, if we want to reduce his non-cardiovascular outcomes by starting GLP-1. But in that case, 1 milligram is not, 2.4 is supposed to be cardiovascular outcomes, whereas in diabetes, there is no obesity here. We give only 1 milligram.
Yeah, that's
fine. Translates into cardiovascular risk.
That's fine. So 0.5 and 1 can be given to these patients where obesity is not an issue. The other good thing with this is that it can be given immediately after a myocardial event, which you could not do with SGLT2 inhibitors. That's not a good patient to start SGLT2 inhibitors. But this can be started during that admission if you want to. And there is a study which has looked at Ozempic in immediate post-MI patients, and it works.
Only thing is our concern will be the delayed gastric emptying. You have to time it properly because most of the medicals requires, even the injectable will have also gastric delaying.
Right.
So the effects may not be, in acute MI, we don't want to give post-MI period. Probably later phase only, because we require medicines, we cannot wait for the prolonged delayed with the antiplatelets being not absorbed is going to cause stent thrombosis.
Okay, so I'll send that particular study where they have used it in the immediate post-MI, and they found that it was okay. But I understand that. That is a concern that you can.
Thank you, sir. If there are no further questions, I think we'd like to conclude the session. Any questions for the first speaker?
Dr. Murali, this is for you. Suppose somebody cardiac failure, functional class 4, where we are unable to titrate the dosages because of the low systolic blood pressure to start with. We are only limited by his cardiac reserve. In such cases, can we recommend cardiac rehabilitation to improve his blood pressure and then start cardiac drugs later stage? You have any experience, those who are in class 4 and repeated admissions into the hospital with for heart failure?
Sir, the minimum fitness or the minimum capacity to begin cardiac rehab is at least walking independently for 1 minute. If that is there, we can transition any class. That's it.
I asked this question because there are few patients in your presentation waiting for heart transplantation, participating. Most of the heart transplantation patients we are currently all cardiologists in our, I think, state and in our country, they never refer the case like unless they have heart failure, class 3 or class 4, only they will send the patient for cardiac rehabilitation. In that case, your patient must be in class 4. Then.
Yes. So they all, when they are sick, absolutely their stamina is less. Once they have the standing capacity achieved, standing capacity is achieved, we make sure that he can at least hold somebody or something and walk for 1 minute. That's the initial fitness. From there, we start the transition, titration of the exercise. So any level of fitness, we can titrate the exercise program.
One case usually asymptomatic, they say that you walk about half an hour like that, but NT-proBNP is very high. LV dysfunction is there, echocardiographically almost 20-25.
Yes.
Do you check NT-proBNP that cases, or you will just do the rehabilitation to do that?
NT-proBNP levels are there that clearly indicates the load of the fluid. But again, we only look at the baseline fitness levels because it's all about adaptations. So even if that is there, the person is walking for 30 minutes, we will try to see improve the from walking fitness to a better endurance level. So maybe we'll speed walk or jog, at that level we do it. So NT-proBNP gradually over a period of time start dropping.
And in such cases, we lost a patient. He says that I'm asymptomatic, I'm walking, he's athletic, but he came with cardiomyopathy, EF was 25. But repeatedly, I'm telling that your NT-proBNP is high, but he's still walking. He suddenly had sudden cardiac death.
Sir, the reason might be different, but here in this case, afterload, preload adaptations happens that actually clears the overload and the chance of sudden cardiac arrest.
we have one of our orthopedic surgeons who had done a presentation, Born to Run, in which he inspired all of us, telling that it's never late to start running. And human beings are born to run. And I also had participated in one of the runs organized by Dr. Muralidharan and me and my husband. And apart from that, Monjaro is a very famous drug, sir. It's a world famous weight loss drug. Even a common man is talking about it. So thankful to both of you for talking on these two important topics today. And before I hand over the podium to Dr. Hygriv, sir, for concluding the program, I would like to thank the people behind today's program. Dr. Bhaskar Rao, sir, our CMD, who has dedicated this beautiful auditorium for any CME programs in our hospital. Dr. Abhinay and Dr. Sambit, the CEO and MD, for supporting such programs and giving the required permissions. The pharma companies who toiled hard, hand-holding us at every step. Our IT, F&B, housekeeping, maintenance, security, transport, parking, branding team who worked endlessly behind scenes. And some names who immensely supported us: Ms. Shramana Roy, Ms. Hema, Ms. Gayatri, Mr. Ramarao, Mr. Dr. Vivek, Mr. Raja, Mr. Chaitanya, and Dr. Anji Babu, and all the DNBs who were behind the program. The wonderful audience, without you, we are not complete, for taking time from your Sundays and your families and joining us here today. I hope you all enjoyed the session as much as we brought this to you all. Last but not the least, Dr. Hygriv, sir, who starts working for this program 5 months before, starting with first booking this auditorium, which is in high demand, and designing the topics, contacting the speakers, writing personalized mails to them, confirming them, chasing them, threatening them, requesting, finally begging them, and bringing this beautiful program for all of you. He's a man of passion, an eye for details, perfectionist, and finishes all tasks in class and finesse. A big round of claps to this man who is behind this program today. I request sir to give a quick recap of today's program and bid adieu to all of you.
I think Jyoti has mentioned all of the, I'm just going to fill in the blanks so that I will not repeat everybody. So the main organization pillars, Jyoti, Shramona and Gayatri, have done a great job in all these months bringing this one. Any program of this nature cannot be done without the support of two important pillars. One is because we are not doing in a hotel, the hospital and its resources have been extensively used. Thank you for the hospital management for giving us all the opportunity. And the second is the industry. Without their support, we would not be able to do any programs. I really thank profusely Medtronic, Abbott, the device companies and the pharma companies, the NATCO, USV, Reddy's, and so many others actually. These are the main companies who supported us. Thank you all, and we are very grateful to your support. Thank you. Pramod, you people missed. Come. You are not there for inauguration. Come.
You are looking much older than.
Oh, wait. You want us to come?
DJ.
One line we can stand up. One line we can stand up.
विवेक सर को फ्रेम से निकाल दे। इन्हें चेतना ना।
లేకపోతే అది ఆమె జాగ్రత్తగా కాపాడుకుంటే ఆమెకి ఎండి వరకు కూడా పనికొస్తుంది బెస్ట్ స్టెప్ స్టూడెంట్స్కి కాకపోతే 8,000 9,000 వాళ్ళు దిగుతున్నారు కదా
సార్